vision of both eyes for last 2.5 years. The patient was having apparently good vision prior to 2.5 years, and there was no history of any ocular trauma or any ocular surgery. There was no history of any local or systemic medications, and there was no history of any systemic diseases. General physical examination revealed no abnormality. On ocular examination, patient was having best corrected visual acuity of 6 by 36 in right eye and 6 by 60 in left eye, measured on Snell's chart. Pupil was round, central, and 3 mm in diameter, and direct consensual light reflex was present in right eye, and RAPD was present in left eye. IOP measured at the time of presentation by Goldman's applanation tonometer was 38 mm of Hg in right eye and 34 mm of Hg in left eye, and patient was not on any anti-glaucoma medications. Central corneal thickness was of 536 micrometer in right eye and 534 micrometer in left eye, and gonioscopy revealed all the open angles in all the quadrants in both the eyes. So coming to the fundus images, this is the image of right eye disc, and the cup disc ratio was of 0.4:1 vertically and 0.3:1 horizontally. NRR was pink with temporal thinning, and there was a deep cup. All the features were going in favor of glaucomatous optic atrophy. And the image of left eye was this, which is being shown.
Hello.
Hello.
I'm Dr. Kumudni Sharma from the HALL F.
Left eye disc image is being shown in the image, and the cup disc ratio was of 0.7:1 vertically and 0.6:1 horizontally. There was deep cup with laminar dot sign, and NRR was diffusely pale, and it was going in favor of primary optic atrophy. This is the same fundus imaging, which is showing a schematic diagram of the fundus images of both the right and left eye. Right eye showing the glaucomatous optic atrophy, and left eye showing the primary optic atrophy. So coming after a thorough examination and the fundus examination, patient was subjected to visual fields, central 30-2 visual fields. And after the visual fields, the scotomas were present in both the eyes in the temporal quadrant, showing bitemporal heminopia. So after this and consulting with neurosurgery, patient was subjected to gadolinium enhanced MRI brain, and on MRI, a diffuse mass of 2.9 into 2.9, 3.3 centimeter homogeneously enhancing cellular mass, causing superior displacement and compression of optic chiasm suggestive of a pituitary macroadenoma. Blood investigations were all within normal limits except the cortisol level, which was 28.2 microgram per deciliter, which was very much raised, the normal range being the 3.09 to 16.66 microgram per deciliter. So the plan of management was the early control of IOP and neurosurgical consultation. Patient was started on anti-glaucoma medications and compliance was good, and the IOP came down to the normal level. So neurological consultation revealed diagnosis of ACTH secreting pituitary macroadenoma. And after consulting neurosurgery, patient was subjected to transnasal transsphenoidal cellular decompression. So ocular hypertension due to endogenous hypercortisolism is fully reversible if the cortisol levels are normalized at the earliest. And the damage which has already happened to the optic nerve is irreversible. And the trabecular meshwork changes induced by endogenous hypercortisolism may be fully reversible. So post-neurosurgical intervention, the IOP came down with no anti-glaucoma medication, and improvement of vision was seen with best corrected visual acuity of 6 by 18 in right eye and 6 by 24 in the left eye, and the cortisol levels were returned to the normal range, which is 7.2 microgram per deciliter, and the normal range being the same, which I told earlier, that's 3.09 to 16.66 microgram per deciliter. And the patient got relieved of symptoms like headache. So post-surgery, after 3 weeks of the surgery, patient was again subjected to visual fields to see if there is any improvement. And on visual fields, there was improvement seen, and the scotomas were reduced. So to compare with, this is the visual fields of right and left eye at the presentation, which is having bitemporal heminopia. And after 3 weeks of surgery, the scotomas were reduced in number. So to summarize with, it's a case of bilateral IOP in raised IOP with gross decrease of vision in a young adult, and there was no evidence of any local or systemic precipitating factors, and the visual fields were suggestive of pituitary lesion, and on MRI, ACTS secreting pituitary adenoma was found, and the high levels of cortisol was the culprit for the raised IOP. So, neurosurgical consultation and radiological investigation revealed pituitary adenoma, for which patient was subjected to transnasal transvenous cellular decompression, and post-op IOP was controlled, and patient is on regular follow-up now. So ACTS secreting pituitary adenoma can cause raised IOP, which may be one of the secondary cause of glaucoma. So in cases of glaucoma, particularly in cases where no local or systemic evidence is found, thorough evaluation should be done with neuroradiological investigations to rule out any pituitary adenoma. Thank you.
Thank you, doctor, for the wonderful session. I would like the judges to please share some few words.
Dr. Pratibha?
Yes, ma'am.
Can you hear me? Yeah. So your visual fields were classical of a neurological etiology. So, but you are stressing on the fact that the increased IOP was probably associated with the decreased vision. So the fact that the visual fields were something atypical of glaucoma should have pointed you towards the correct direction and not continued pursuing glaucoma as a possible cause for decreased vision. And also I had a query whether you had done any OCT of the retinal nerve fiber layer, because it's very rare to see visual fields completely normalizing after your tumor is removed.
Well, completely it was not getting normalized. Some scotomas were present, and it was repeated 3 weeks after surgery. And the reason for that you are saying ki IOP was the main culprit, because when the patient initially presented with only decreased vision and headache. So, ma'am, after seeing the visual fields, and it was classically like bitemporal hemianopia made us think that it can be a pituitary cause for the same. So therefore, that we consulted a neurosurgery, and they asked us to do a gadolinium enhanced MRI. So on that, it was fortunate that we found the tumor was there, and the patient was immediately subjected to neurosurgical intervention.
Can I say something?
Yes, ma'am.
Oh, field always they improve after the surgery. It's known in pituitary. It depends upon how the duration of the compression. If
Yes,
the
ma'am.
duration of compression is very short, the patient will recover the visual acuity. Even in the evening of the surgery, the patient can recover the visual acuity, some visual acuity, and the field recovers completely.
Yes,
in compressive lesion, it is a demyelination. Simultaneously, remyelination is also happening. And it's a conduction block because of the compression. These are the two phenomena which is responsible for the visual deficit. And both of these, they recover after the decompression of the tumor. There's a possibility visual acuity and the field will recover completely after the surgery.
Yes, ma'am. Duration matters a lot, ma'am, in this time.
Yeah, and the consistency of the tumor. And the consistency of the tumor, how hard it was.
Yes, ma'am.
So I don't have to ask anything. Can we move on to the next speaker then?
Yes, ma'am. To begin with our next speaker, I would like Dr. Tanmoy. Do we have Dr. Tanmoy? I believe we do not have Dr. Tanmoy. So we go with our next speaker, Dr. Astha. Dr. Astha Gandhi, could you please switch on your camera?
Good morning, ma'am. Hello, am I visible?
Yes, you're visible. Can you please share your screen?
Share the screen, yeah.
Okay.
Is my presentation visible, ma'am?
Yeah, it's visible.
Okay. Good morning, everyone. I'm Dr. Astha Gandhi. I'm a resident in Safdarjung Hospital, New Delhi. And the topic of my presentation is Too Many Puzzles to Solve, an ophthalmologist's dilemma solved by a multidisciplinary approach. So, my patient is a 39-year-old female who presented to us with the chief complaints of inward deviation of right eye and diminution of vision since the past 3 to 4 years. And the patient was a known case of unsteadiness of gait since 10 years under evaluation in neurology. The family members had noticed her to be occasionally confused. Otherwise, there was no history of trauma, fever, systemic illness, prolonged weakness, weight loss, tremors, weakness, or decreased sensations in any other parts of the body. No history of decreased hearing, olfaction, or swallowing problems, and no history of, basically, there was no apparent negative history. The past history was not significant besides the unsteadiness of gait. The birth history, personal history were normal. The family history was normal. General physical examination was within normal limits, except for proximal neuropathy noted by a sensory examination of the central nervous system. The ocular examination, the visual acuity in the right eye was finger counting at 2 meters, and in the left eye was 6.9, which improved to 6.6 by refraction. There was no acceptance in the right eye. The lady had a slight head turn to the right. The Hirschberg, the patient had 45 degrees of esotropia in the right eye, and the Hirschberg was central in the left eye. There was no movement on direct cover, cover-on-cover test, or alternate cover test. The extraocular movements were limited in both the eyes, in both ductions as well as versions. This is the 9-case photograph of the patient showing 45 degrees of ESO in the right eye in the primary gaze, as well as both duction and version limitation bilateral. So the horizontal fissure width was normal, the vertical fissure height was normal in both the eyes, the exophthalmometry and the anterior segment examination was normal. The Bruckner's reflex was brighter in the left eye. On performing a direct and indirect ophthalmoscopy, we could not really view the fundus of the right eye because of the esotropia beyond the macula, but in the left eye, we could note mild pigmentary changes in the mid-periphery, and otherwise the disc and foveal reflex were normal. So the patient was advised a routine blood investigation and was asked to review with the reports of MRI brain, which was advised in neurology and which was done 4 years back. So the blood investigations routine were normal, including the blood lactate levels, the thyroid profile, the ACH receptor antibodies, the vitamin B12 levels were also normal. The MRI brain, which was done, revealed a mild bilateral cerebral atrophy, and the orbit imaging was within normal limits. We also asked for the old photographs to rule out any congenital element, and the old photographs showed that the patient was normal prior to this episode. When we asked the patient to come for follow-up, we also noticed an early KF ring in both the eyes, which might have been missed on initial examination. So an immediate neurology referral was done for the same, and blood investigations like serum copper and urine copper were advised. So the case summary, let's skip this. So our provisional diagnosis was chronic progressive external ophthalmoplegia, reference disease, oculopharyngeal myotony, and dystrophy and Wilson's disease. But all the investigations that we had advised came out to be within normal limit, including the blood phytanic acid levels. So we were in a fix as in what to do. So we planned an FDT to differentiate palsy from restriction, a field testing, macular OCT, ERG, and we asked the patient to get a repeat MRI brain done along with neurophysiological testing. So macular OCT right eye could not be captured, left eye was within normal limits, FDT was negative or mildly positive for medial rectus actually, bilaterally. The field testing was unreliable. The patient was not at all cooperative. However, on confrontation test, the field came out to be reduced in both the eyes. On ERG testing, it showed both diminished photopic and scotopic responses. This is the MRI picture of the patient, the latest MRI which we had advised. So this is basically showing bilateral thinning of the lateral rectus as can be seen in the T1 section and the post-contrast section also. So the bilateral lateral rectus are thinned out as well as the bilateral medial rectus are slightly fibrosed. Neurophysiological testing, EEG was normal, and the nerve conduction studies revealed a purely sensory axonal peripheral polyneuropathy. So we planned a lumbar puncture and CSF analysis with the neurology department, muscle biopsy to rule out any component of CPO. We advised a repeat field testing and also coordinated for a neurogenetic testing of the patient. So the patient was admitted in neurology, investigations done and discharged. However, the patient developed an episode of myocardial ischemia the next day, for which he was rushed to a nearby hospital where it was managed. So is everything well? I don't think so, because the patient succumbed to cardiac failure and died. So the final diagnosis was made when the results of neurogenetic testing came out, and we found a mitochondrial DNA 8993 mutation T2J. And the patient was diagnosed as having NARP, a mitochondrial disease, and with heteroplasmy of 49%. So yeah, that's my case. And a NARP is characterized by, NARP is basically neuropathy, ataxia, and retinitis pigmentosa. And so yeah, that's what makes my case unique is that this is the first documented case of KF ring being present in a patient of NARP syndrome. And this is also the first case of a patient in a middle age and still having salt and pepper retinopathy, not progressed to the retinitis pigmentosa stage. And also the patient has a very low heteroplasmy in genetic mutation. So NARP is characterized by a combination of proximal neuropathy, sensory motor neuropathy, ataxia, and pigmentary retinopathy, and a battery of investigations is required for early diagnosis. And supportive management is the treatment for this patient.
Thank you, Dr. Asta, for this wonderful talk.
So, like in the mitochondrial cytopathy, what you had this patient, they usually, was there any night blindness complaint in this patient?
No, ma'am. The patient, actually, we did not first get, because the patient was looking slightly confused. She was not able to express much. It was her husband, basically, who was giving all the history. So she was not very cooperative with the history part also. And but then when we asked retrospectively, then the patient said ki overall he vision he come and not just night blindness.
Because in mitochondrial cytopathy, it is a bilateral symmetric ophthalmoplegia,
Yes,
what you
yes,
get.
ma'am.
Not the isolated muscle, like asymmetric type of what you had.
So no, ma'am, it was bilateral ophthalmoplegia.
But there was a esotropia, bilateral. That means the primary position, eye should be in the primary position with restriction of the all movement, all the adduction, all the version adduction should be restricted, and the eye should be in the primary position. The eye was eso. That shows that there is more involvement of one muscle.
Yeah, ma'am, but that was when
we formed. Was it a nuclear palsy, sixth, or what was type of it? Is an infranuclear?
No, ma'am. It was bilateral. Lateral rectus were thinned out, but the nucleus, sixth nerve nucleus was completely normal. So,
The
yeah,
muscle atrophy was there, that shows intranuclear. That's no problem. Okay.
and also the right-sided medial rectus was fibrosed. That is why the FDT was also positive for medial rectus
Was
in
there
the
any
right.
facial muscle dystrophy was also there?
No.
Or generalized body muscular dystrophy?
No. Ma'am,
No
there
seizure,
was no
nothing.
muscle dystrophy, but when we performed a neurological examination, the patient had sensory neuropathy in the proximal limbs.
Okay, yeah, you said that.
Yeah, but she did not have
What
any
was the cause
complaint.
of KF ring in this patient?
Ma'am, that is one thing that we could not make out because all the copper level, seroplasmin level, and the urinary copper level was also normal. So probably, and we did a lot of research. Also, I personally went to the National Medical Library also, but we could not find a correlation. So this is something we're still investigating, and even in literature search we could not find. So probably this is some new finding, and we're thinking of reporting it also.
Because KF ring is because of the copper deposition.
Yeah.
But you said the copper level was normal.
Yeah.
So, and I have never seen and never read also that in mitochondrial cytopathy there is a KF ring.
Yeah,
It's
ma'am.
very classical of Wilson. There might be a Wilson where I don't know copper level. How did they do that? I don't know. But
Ma'am, but the patient was admitted in our neurology department only, and a 24-hour urinary copper level monitoring was done, and still it was within normal limits. And this patient had been under neurology follow-up since 10 years in our hospital, and they did not find this disease was diagnosed right now, because when we spotted the KF ring, then we thought that we should probably, this is
her
something.
discs were normal. You said the discs were normal. Optic disc was normal.
This was normal, ma'am, but pigmentary retinopathy. Yeah.
Okay, because optic atrophy is also one of the feature of mitochondrial cytopathy.
Yes, ma'am.
Dr. Astha, very interesting case. I would like to ask you two things. Your first provisional diagnosis was chronic progressive external ophthalmoplegia, but usually it does not present like this.
Yeah, without
There will be a
ptosis.
bilateral progressive ptosis, and the eyes
Yes,
usually are
ma'am.
in lateral gaze or in abduction, they are
Yes,
fixed, right?
ma'am. Yes, ma'am.
So that was one thing. I think you should put it lower down in the list. And second thing, I think in every patient where you are suspecting a mitochondrial dystrophy, you should always get an ECG done, because it's very common to have cardiomyopathies in these patients. And I think that was an important thing which we
Yes,
missed.
which we missed. Yeah.
And second thing, the MR FDT, you told that it was tight, right? So one of the reason of tightness was not just because of, could be because of the long-standing esotropia in the patient, which could have resulted in the tight medial rectus, rather than correlating it with the MRI findings which you were telling. Okay. So these are some of the queries and things I would like to add. Otherwise, the case was good, but you had crossed your time. I would like to warn the other speakers to please stick to your time, 6 minutes. Okay.
Thank you, ma'am.
Thank you, Dr. Asta. Thank you, judges. Now we move on to the next speaker, Dr. Sadia Ejaz. Do we have her? Yes, doctor, please share your screen.
Hello, am I audible?
Yes, doctor, audible and visible too.
Okay. I am Dr. Sadia Ejaz, a resident from the Department of Ophthalmology, Sher Kashmir Institute of Medical Sciences, Srinagar. I am
Hello, Sadia ma'am. Your voice is not audible.
Syndrome. Bizarre movements of upper lids or presence of any non-consanguineous marriage. Full term. Hello. Am I audible now?
Yeah, you are audible. Yeah, you are audible. Continue.
Okay, thank you. All other milestones like cognitive, social, communicative were acquired at a normal age. Coming to the general physical examination, the patient was conscious, cooperative, and well oriented to time, place, and person. However, facial dysmorphism was seen. I'll come to a picture. The left side of the face was dysmorphic, and there was a left external air atresia. He has a downward slanting left palpebral aperture too. I'll come to the examination. The vision was fixing and following light and
Dr. Sadia, we can't hear you.
lid creases were present in both. My volume is at the maximum right now. Ma'am, I have kept it at the maximum, the volume.
Ma'am, your network is very low bandwidth. The issue for only network problem, ma'am.
Yeah, actually the Wi-Fi is not available here. I am at the shows, but we have not been provided with a Wi-Fi connection. I've connected it through my phone only. Hello.
Yes, doctor.
Should I continue?
Yes,
We
please.
can hear you. Yeah, you continue.
Okay. Coming to the examination part, the palpebral aperture was 4 mm in the right eye and 2 mm with the downward slant in the left eye. 25 mm both eyes, the horizontal palpebral aperture. The marginal reflex distance was 1 mm in the right eye and it was minus 2 mm in the left eye. 3 mm both eyes, marginal reflex distance 2. The LPS function was 3 mm in the right eye and 2 mm in the left eye. Bell's was poor in both eyes. Frontalis overaction was observed in the right eye, but due to facial dysmorphism, it is not visible in the left eye. Marcus gun jaw winking reflex was absent in both eyes. Normal shimmers in both eyes. Non-contact tonometry 12 and 14 and normal fundus in both eyes. Coming to retinoscopy, it was plus 4.5 in both eyes. Complete restriction of extraocular movements in both eyes. Coming to investigations, we have done an X-ray cervical and dorsal spine. The intervertebral disc space was maintained. Prevertebral space was within normal limits. However, there was a hypodense odontoid process present. Coming to EEG, there was no evidence of any focal or generalized electrical abnormality of brain. Coming to USG abdomen, it was mild hydronephrosis with dilated renal pelvis. Coming to the echo, normal segmental analysis, normal ventricular function and dimensions. There was no structural heart disease, no patent ductus aortus or coarctation of aorta. Coming to brainstem evoked response audiometry, in the right eye, wave V could be, a fifth wave could be raised till 40 decibels with a good wave morphology and reliability. However, in the left eye, there was no waveform elicited, even at 90 decibels. It was severe sensory neural hearing loss. Coming to MRI, there was evidence of bilateral enophthalmos. The actual reference line joining both lateral orbital walls is intersecting in the anterior third of eyeballs. The brain study was normal. The left cochlea shows architectural distortion with absent mediolus. Cochlea has cystic appearance with dilated vestibule and shows wide communication, which is suggestive of cystic cochlear vestibular anomaly. Left internal auditory canal is hypoplastic, with eighth nerve complex is also hypoplastic. Genetic testing, no abnormality was detected. The diagnosis we have made is Goldenhaar syndrome, and we could only prescribe crutch glasses to the patient.
Dr. Sadia, could you present your initial slides again, because I could not hear because of your connectivity issue? What did the patient present with?
I think she lost the connection again.
Okay.
I believe we have lost Dr. Sadia as she has left because she had some internet issues. So we'll move on to our next speaker, Dr. Anuradha. Dr. Anuradha, please switch on your camera, unmute yourself.
Good morning. Good morning, everyone. Is my presentation visible?
Yes.
Good morning. My name is Anuradha, and today I shall be presenting a case of congenital combined eyelid imbrication syndrome. So congenital eyelid imbrication, it is a very rare clinical entity. So far, only 5 such cases have been reported worldwide. It is characterized by malposition of eyelids at birth. And in extremely rare cases, it may also be associated with congenital floppy eyelids, in which case it is known as congenital combined eyelid imbrication syndrome. And so far, only 3 such cases have been reported worldwide. Today, I would like to present the 4th case of combined eyelid imbrication syndrome. As per my literature search, this is the 4th case that we have seen. So my patient, a 3-hour-old male baby who was born by a normal vaginal delivery at term with no significant antenatal and perinatal history. He was referred by the pediatrician urgently because since birth, he had a swelling in the both eyes, around the both eyes, which was gradually increasing. There was inability to spontaneously open the eyes, and there was associated redness of the eyelid skin. There were no other comorbidities, no syndromic association, and no history of consanguinity, maternal ailments, or any teratogenic drug intake. So at presentation, the baby was active crying. The eyes were found to be bilaterally bulky, edematous and erythematous eyelids, with overriding of the upper eyelids over the lower by 6 mm. And the horizontal length of the upper eyelid was 23 and the midpoint of vertical height was 10 mm. There was no spontaneous opening of the eyes and no other facial anomaly was seen. So when we tried to gently open the eyes, there was spontaneous eversion of the upper eyelids on very gentle traction. It exposed the underlying conjunctival, tarsal conjunctiva, which was found to be severely erythematous. The lower eyelids were folded inward, but on trying to gently pull them down, they were also everted and the conjunctiva was equally inflamed. There was a mild mucoid discharge. So how the globes, as much as we could examine them under these eyelids, they were found to be bilaterally normal on gross examination. So based on overriding of upper eyelids over the lower, eyelid laxity, spontaneous eyelid eversion, and inflammation of the tarsal conjunctiva, we made a diagnosis of congenital combined eyelid imbrication syndrome. Conjunctival swabs were sent from both upper and lower conjunctiva for microbiological analysis. The baby was started empirically on topical antibiotics, tobramycin, and lubricating agent, that is carboxymethylcellulose. The patients, most importantly, they were found to be very afraid to see their newborn child with such gross features. So they were counseled to alleviate their anxiety, and the baby was followed up closely. Over a period of 10 days, we saw a gradual resolution of signs. There was reduction in eyelid laxity, and spontaneous eye opening was achieved by the 9th or 10th day. Subsequently, a detailed ophthalmic examination was carried out, and it was found to be normal. These are the follow-up pictures of the baby. This is pictures at 3 days after birth, which showed that there was still some eversion of the eyelids, but if we notice, it was lesser than what was there at birth. The erythema has also reduced. At around 6 days, the bulkiness of the eyelids has reduced, and about 10 days of age, the normal eyelids and eyelid opening were seen. Eye opening were seen. So combined eyelid imbrication, it is a rare congenital disorder. The etiology is yet unknown. It is characterized by bulky erythematous eyelids, upper eyelid overriding the lower with easy and spontaneous eversion of eyelids. It is hypothesized that the overriding of upper eyelids is due to congenital lid laxity, and the tone of medial and lateral canthal tendons in these babies is poor, and so this leads to the overriding of the eyelids. There is no documented hereditary predisposition. It is most likely sporadic. Irritation of the upper tarsal conjunctiva is caused because the lower eyelid is inverted and the lashes brush up against the conjunctiva. And it leads to a vicious cycle of orbicular spasm and eyelid eversion. So treatment is based on breaking this cycle and is achieved by topical lubricant, which alleviates the irritation, and empirical antibiotics to take care of any infection. Topical antibiotics prevent secondary infection. Babies who have pre-existing infection must be treated more aggressively. Condition is essentially self-resolving with conservative management, probably because the resolution takes place due to tightening of medial and lateral canthal tendons as the bony orbit grows and the involution of eyelid structures happens, but the influence under which it happens after birth is still unknown. Congenital floppy eyelids, they have been associated with Down syndrome in babies, but our patient did not show any syndromic association. Most importantly, it is very crucial that the parents are counseled adequately and their worries are allayed, since the management is essentially conservative and the babies achieve a normal eye opening and normal appearance with conservative management over a period of 1 to 2 weeks. To conclude, congenital combined imbrication of eyelids is an extremely rare clinical entity with 4 cases reported worldwide so far. Essentially a self-resolving condition with conservative management. So the knowledge of this condition, its management, and the role of counseling play a very important role. And treatment essentially aims at reducing the irritation and prevention and treatment of any infection. These are our references. Thank you.
Thank you, Dr. Anuradha, for ending the session on time. Over to the judges.
Thank you.
I just missed out. When did it resolve? It was present at the time of... yeah.
Yes, ma'am. It was present at the time of birth. It was gradually increasing for maybe 6 or 7 hours. It was increasing, then it stabilized and gradually resolved over a period of 10 days.
10 days.
Yes, ma'am.
So how do you explain the puffiness of the upper lid?
Ma'am, as I explained, the etiology and the mechanisms that cause this ailment are yet unknown. It is just said that the laxity is high. Laxity is low due to certain developmental deficiencies at birth, but the puffiness of eyelids has yet not been explained in these situations.
Could birth trauma have something to do with the lid edema?
Ma'am, maybe, but during birth, the baby was born through normal vaginal delivery. There was no application of forceps or vacuum. And otherwise, the baby was absolutely fine. And when we did the ophthalmic evaluation, even at onset and even afterwards when the edema resolved, we did not find any signs that could point towards birth trauma in the cornea or in the retina.
You said laxity was low.
The laxity was, there was laxity of the eyelid, ma'am. Poor
Yeah,
choice
it's
of
not
words.
low, it's a
Poor
too
choice of
lax.
words.
That's why it was overlapping.
Too lax. Yes, ma'am. Yes, ma'am.
Dr. Anuradha, thank you for that case. I would like to ask you two things, ma'am. First of all, was any lid massage advised to the patient? Because you didn't mention about that.
No, ma'am, we did not advise any lid massage to the patients. To be honest, to be very honest, when this case came to me, I was also in a fix. What is this? A newborn baby who cannot open the eyes and such floppy eyelids. So I had read up on this. The few cases that were reported previously, based on that, we based our management. Since there was no history of any spontaneous epiphora, there was only a mild mucoid discharge. We planned to manage the patients with the topical eye drops, and we saw a good outcome with it. Even afterward, the baby did not present with any epiphora.
I'm not asking about the Krigler's massage. I'm asking about the lid massage, because usually in patients with congenital entropion, we do advise lid massage to them,
lid massage,
so that the
yes,
eye works out. Second thing, if your patient would not have resolved within 10 days or more than 10 days, what would have been your next plan of management?
Ma'am, we would have continued with conservative management. Of course, we need to keep in mind that the corneas are not getting affected because of the eyelashes. And as I said, I based my management on previously reported cases. And so we managed the patient with lubrication and antibiotics. And if it had not happened, then I would have probably referred the patient to a pediatric ophthalmologist for further management.
And then it would have been interesting to know, as this is a 5th case which has been reported. So it would have been interesting to know how your case was different from the other cases which were reported.
Ma'am, different in the sense that this case had associated floppy eyelids, which is not reported, which is even lesser, reported even less than compared to congenital imbrication of the eyelid. Other than that, our case was pretty similar to what we have seen in literature.
Thank you. Nice.
Thank you. Thank you so much.
Thank you.
Thank you.
Thank you, Dr. Anuradha. I believe we do not have any other speakers.
Has Dr. Sadhya joined back?
Yes, we do have Dr. Sadhya.
So we can take questions for her. Actually,
Dr. Sadhya, do we have you? Can you please unmute yourself?
I think there are severe network issues there, so we might not be able to connect to her.
Yes, doctor. I believe the same.
We don't have any more speakers?
No, doctor, we do not have any other speakers.
I have joined late because I had to present something in some other topic.
Meenakshi ma'am is here, I think.
Yes, ma'am. Yeah.
Meenakshi is here. We can.
Yes, ma'am, I'm there.
Present a case.
Yes, Dr. Meenakshi, you can share your screen, please.
Okay, thank you. Thanks a lot. Good morning, everyone. Thanks to DOS for giving me this opportunity to present this case on optic neuritis, a case of Ma'am, am I audible?
Yes, doctor.
You are audible, yeah.
Okay, thank you. It's a case of optic neuritis in a 6-year-old child. A 6-year-old male child presented to the IOPD of a pediatric tertiary care hospital with the complaints of diminution of vision in both eyes for the past 3 days. There was no history of trauma or painful eye movements or fever with rash. On ocular examination, visual acuity was finger counting 1 meter in both the eyes, and there was no RAPD on anterior segment examination. The systemic examination was within normal limits, and there were no signs of increased intracranial pressure, and blood investigations were also normal. So we advised the parents for imaging, and contrast enhanced imaging was done. Before that, we did the posterior segment examination, which revealed bilateral swollen optic disc and elevative optic nerve head. These are the pictures taken from by phone, and then on the advice, we gave them the advice to get a MRI scan done. On the MRI relieved thickened optic nerve head with the enhancement with the contrasting agent. The transverse diameter of optic nerve disc was 8.5 millimeter in right and 8 millimeter in left eye, indicating increased perineural fluid under the nerve sheath. So diagnosis of bilateral optic neuritis was made, and the child was started on intravenous steroids 500 milligram once a day for 5 consecutive days. And there was an improvement in visual acuity even after first dose of steroids. Then we discharged the child on oral steroids in a tapering dose of 1 milligram per kg for 6 weeks. When the child followed to us, after child came to us in between also, but after 6 weeks, we got a repeat contrast MRI scan done. There was a complete resolution of optic nerve head swelling, and the final visual acuity at 6 weeks was 6/18 in both eyes. Then after that, the child was lost to follow-up in lockdown period. So what is optic neuritis? It is inflammation of optic nerve. The incidence of pediatric optic neuritis in children is estimated to be 0.2 per lakh. Optic neuritis is much less commoner in children than in adults, but it is not rare and accounts for approximately a quarter of pediatric acute demyelinating syndromes. And in one combined series, children, 5% of the children had been studied with the optic neuritis. Most common presenting complaint for pediatric optic neuritis is loss of vision and headache or painful eye movements ranging from between the 37 to 56% as symptoms. The presenting visual acuity may range from 20/20 to no PL, with 50 to 77% having severe visual loss in the form of less than 20/200. The presentation of symptoms ranges from RAPD, which is relative outfront pupillary defect, which is found in almost 100% of the patients with unilateral and 47% with bilateral disease. Visual recovery occurs quickly within 3 months with 20/40 or better vision in 78 to 96% of the cases. And yes, it is associated to sometimes with multiple sclerosis also. Of children presenting with a clinically isolated syndrome, 29% cases converted to MS over the duration of mean follow-up of 6.3 years. These are my references. Thank you.
Thank you, Dr. Meenakshi. Judges, do we have any questions for Dr. Meenakshi?
Yeah, Dr. Meenakshi, was there any prior history of viral fever or any vaccination given to the child?
I had mentioned there was no history of viral fever or any vaccination. We had elicited from the mother. And also, ma'am, we had done a few systemic other investigations also to rule out tuberculosis and sarcoidosis, because sometimes TB is also known to affect the child's vision also. But but they were all within normal limits. So that is why when we found the posterior segment examination with the optic nerve head swelling, then we had advised them for this MRI scan.
To me, in the MRI, you said there was a perioptic spaces were enlarged.
Ji, ma'am. Yes, ma'am.
It was a whole nerve enhancement. Yeah. So I think it is the sheath enhancement was theirs. And when you showed the resolution, still the nerve was enhancing. And it was quite a large segment of the optic nerve which was enhancing. So NMO is also described in children. MOG and NMO antibody should be done because the visual loss was quite marked. It was bilateral and enhancement was very extensive.
Yes, ma'am, but in neuromyelitis optica, the parents were not because there was an improvement after giving them steroids. So we
but that would be in NMO also, giving the steroid. But those antibodies should be studied, you know. NMO and the MOG antibody should be done because they are reported, not very commonly, but they are reported in pediatric age group.
Yes, okay, fine. But actually, ma'am,
But the extensive optic nerve segment involvement on MRI goes more in favor. I did have any history of viral fever.
there
was no confusion and the child was perfectly all right?
Yes, ma'am.
And there was no any demyelinating plaque anywhere in the CNS?
No, ma'am. No, there was no demyelinating lesion or plaque in the CNS.
Okay, Adam is also one of the diagnoses. In these children, if you have multiple demyelinating plaques in the CNS on MRI.
Okay.
Dr. Meenakshi, did you do a CSF analysis?
No, we did not do a CSF analysis because we gave steroids, the child recovered. So we did not plan for that CSF analysis.
Has there been any recurrences?
Actually, the child came to us after like in between and then till 3 months of his problem. After that, the parents have not reported to us. So we cannot conclusively say whether there was a recurrence or not. But like if there would have been any recurrence, so I think the child would have reported to us because they were quite satisfied when the child's visual acuity improved. So in case of recurrence, I think they would have definitely reported to us. In this child.
How long was this follow-up?
Only till up till only for 3 months they came to us. After that, they have not reported to us. Thank you.
Okay, nice case.
Thank you, ma'am.
So I think we are done with the session.
I believe so, doctor. We have no speakers left.
Okay.
So I would thank all the speaker and the judges for your valuable time and for the wonderful session.
Okay.
I would like to ask, ma'am, have you marked out of 10, right? Actually, मेरा उस time connection चला गया था, so I could not listen to that.
Gunjan, you're talking to me?
Yes, ma'am. Yes, ma'am.
Okay, I just saying hi to you.
Hi, ma'am. Marking is out of 10.
Marking with Dr. Namita has sent on email the mark sheet.
No,
but it doesn't mention the total marks.
Okay, out of 20, how much is the total
No,
mark?
the total is not mentioned. It's only an Excel
total is not mentioned. Oh.
No, it's only an Excel sheet.
Yes, so we have to mark out of 10 or out of 20?
I think we asked them, you know.
Yeah. So
we asked Dr. Dandia or Dr. Namita.
Okay.
Okay. Then we will decide, okay?
Okay.
Okay, bye.
Thank you.
Thank you.
Hello, good morning.
Good morning.
Is anybody from audiovisual?
Hello, good morning.
Hello. Hi, good
Hi,
morning.
Mangat. How are you?
Good.
I thought I'll just share and check. Is it video?
Yes. Yeah, I think, yes, that will be great. Absolutely.
So let me know if the screen is visible.
Yes.
Let me start this video. In fact, then only.
Yeah, I think it has gone.
Is it there now?
Yeah, we can see. So you can maybe go to slideshow and then. Yeah. Yes, it is. Yeah, it is showing very well. Good.
और मंगत, how are you?
बस good, बिल्कुल बढ़िया. आप सुनाओ कैसे हो सब? Everything is good.
Early morning dose में है पकड़ लिया.
I know.
Early morning ना थोड़ा laziness होता है.
I know. बिल्कुल. In fact, today I am also not in Chandigarh, in Kasauli. So I'm, in Garewal has a beautiful place here. So we came. Yeah, but I think the connection is good here and it's so lovely.
Long weekend also, na?
Yes, इसी करके long weekend ही.
Yeah.
Because of this. So we thought maybe might as well. So परसों आ गए थे Friday. So we'll be back today evening. Yeah.
Kasauli must be reasonably close.
Yeah, pretty close. Yeah, just upper time would be 1.5 hours, maybe सवा घंटा पहुंच जाते हैं. That is one advantage of.
How is Mohit?
Mohit is doing well. Mohit is fine.
He's doing very well. In fact.
Hello. Thank you, Dr. Lalit. All blessings of people like you and others, those who have always wished well. I think हम तो यही चाहते हैं कि अब बच्चे आगे करें तो भी है बस. That is हमारी.
The key to success comes when he has a name independent of Mangat.
Yes. मेरे को यही था पहले से ही. I never wanted him to work with me. He worked majority of the time.
I've never seen you also promoting or telling anything about him.
No. I don't believe in that.
I have interacted and questioned with him for a couple of lot of sessions in fact now.
He
is brilliant.
Thank you, Dr. Lalit. Actually, that was my philosophy right from the beginning. Good morning, Dinesh. Good morning.
Morning.
So, Dr. Lalit, that was my philosophy right from beginning. And he also had a great influence of Dr. Amod Gupta because he worked with him maximum time.
But let me be honest, I have so many peers here. Everybody does not have similar philosophy.
Yeah, that is true.
Good morning, sir.
Good morning. Good morning.
So we hope to start in time and finish in time.
Yeah, that will be wonderful.
Jam-packed.
Yeah.
And Sabina, I think she will not allow us also.
Yes.
Good morning, doctors. Welcome to the 72 Annual JAWS International Hybrid Conference. So we would begin with our session. To begin with the session, I would like Dr. Lalit Verma to please unmute himself.
Yeah, it is unmuted.
Yes, Dr. Lalit, over to you.
So good morning, everybody. I don't think we need to introduce one of the pioneers of retinal surgery is here with us, Manga. And Dr. Dinesh has joined. So we hope to start in time. The topic of the session is challenging situations. So what I feel at the outset, improprio, I should say, life itself is a very big challenge, let me be honest. And every day, especially for VR surgeons, in fact, for every surgeon, it's a challenging. People who operate, they face so many situations. So challenge जिंदगी का ये एक नाम है, and surgeon का ज़्यादा हो जाता है because believe me, there are palpitations still before I go to the theater, and till the time you operate and have a good satisfactory outcome. Because believe me, all surgeons are looking for one thing only: a good outcome and a smile on the face of patient, on the face of patient. That gives the biggest satisfaction, whether it is Dinesh, Mangat, or anybody operating. So that is the, and I hope we will be joined by Raju Sampangi as well as Shaurya Azad. Both of them, Shaurya is from RP Center, Raju is having a practice in South, and we have 8 talks, and hopefully we will learn from each of these talks and have some messages, because Mangat is very keen to give message to everybody, practical message, and I hope he will make this session very lively. So Mangat, if you allow, I will start with my address.
Dinesh, Dr. Lalit, it's over to you. You don't need any introduction. You've been sort of a example for everybody, in not only in the vitreoretina field, but the whole ophthalmology. You have given a new direction to everyone, and we look forward to your presentation, especially on a topic, I think, where we all get so scared in life, and I think you'll make things much better and easier for us. So over to you, Dr. Lalit Verma.
Thank you, Mangat, and good morning, everybody. I'll share my screen. Just to reconfirm, I think everything is okay. So I'll start.
Yes.
So at the outset,
no, I think this is the other program showing at present, but not your slide. Yeah.
Is this the slide visible or not?
Yeah, slide is visible with the entire program.
Yeah. I just so
okay.
Yeah. So at the outset, let me thank the people who have arranged this event, Dr. Subhash, Dr. Namita, and the entire executive of DOS, and labeled very nicely as practice to perfection. And perfection, believe me, is a theoretical word. That perfection keeps happening in the life of surgeon, in the entire life. So I'll begin with one emotional kind of slide. All surgeries are fraught with complications. And all of us know all complications are bad. Nobody wants. You see, the day I have any issue or complication, there is a sadness on my face, and even the entire family comes to know that kuch to gadbad. But they do happen, and they have to happen. I think we are not gods that we can deliver 100%. That is the reason we pray every day. And complication happens in the best of hands. And we have been told every time, people who don't operate only, they may not have complications. Therefore, medical retina is catching up so fast. So, and they happen with everybody, whether it is the top person or the budding surgeon. But what I believe is, you see how you handle that complication. That shows your patience. That shows your skill. Because that is in the best interest of patient. How do you handle that? Especially in VR surgery, there are a lot of oops moment, which I say struggle at during surgery. And no two VR surgery are same. And a lot of these patients, as you grow senior, a lot of VIPs you have to tackle. Somebody, doctors, some eye surgeons, some MLAs, MPs, and a lot of them expect immediate recovery. And you see patient demands and expectations in this Google era so high, and they want next day 6x6. Partly because the awareness of retina, what is retina, how does the vision form, is not there in general population. Therefore, they equate it to any other eye surgery, cataract surgery. Doctor, uska vision to agle din aa gaye. And they want to join back their duties very fast. So MIVS has solved a lot of these issues. There's no doubt about it. But you see, you can't expect 100%. Other thing is, consumer courts are always on your head. So I'll just show you 4 or 5 videos which I have joined together in one video only, where, I learned from some of the mistakes which I did during surgeries. So let me start this. Was a young patient actually. He had evidence of uveitis and he had secondary reg RD. And pupil was dilating, so we started doing this surgery. And I did check the cannula here. Started doing the vitrectomy. And the upper temporal port, where the illumination was there, hasn't, illumination is not so bright. So I thought it is subretinal. So I carried out for some time because the vitreous was quite sticky. I didn't want too much interchange of instrumentation. You see how the illumination is going through this balloon, upper nasal balloon, upper temporal balloon. But I did part of the thing. And then I shifted. See, now I have made another port. Now we have 4 ports here. Now the illumination has suddenly become brighter. I injected PFCL and did most of the membrane surgery. There were multiple breaks already here. You can see multiple breaks and pigmentation of the scleral retina, and tried to peel off this PVR kind of membrane. I didn't want too much of exchange of instrumentation here. So, with the help of illumination only and holding the footsteps, tried to do as much separation of membrane, relieve all the traction. And injected PFCL also. So when most of these membranes were out, so now notice I started doing exchange. The upper nasal part, there is a subretinal air coming in, and the whole retina is becoming balloonous once you start doing exchange. So I suspected that this infusion cannula has gone subretinal now. Infusion cannula, which was properly placed, can go subretinal during also. This time I made this port. Sorry. Made this port straight. Instead of initial 3 ports I had made for 2 steps. So now you have 5 ports here. 5 ports have been made. And then I started doing it to exchange again. And fortunately, we did. And did lasered all these holes as well as entire retina eye laser. So what did I learn from here was that any patient who has anterior segment issues like uveitis or a choroidal or a mound in this thing, so kindly have straight entry rather than having 2-step entries, and keep checking the infusion cannula, because infusion cannula can become subretinal during the course of the procedure also once you start doing acquisition. So this was a second patient. He had a relatively simpler kind of PVR. So you notice this PVR. So I'm trying to use this MVR blade, which has a small pick, micro pick at the, and then with the help of forceps started pulling this. Somehow the force required was more than the toughness of the membrane, and had to exactly exert. And I did not win in this. The retina won actually, and we had a large break, just sparing the vessel, and this actually stopped my heartbeat. Itna bada break, and immediately had a deep breath, put PFCL, and this membrane had to be taken out. So used various instruments like this. I'm using a spatula here now, a blunt spatula, but this membrane was pretty tough. So I put in a chandelier. I thought, don't zyada khishna nahi hai. So have a bimanual this thing. Took this scissors and cut this membrane. So this membrane was cut. You see this bridging vessel here, iatrogenic tear here. But this was not all. There was a membrane in the anterior part of retina also. So this time I was careful that I will try my best not to create another one. So with the help of MBR only, I teased the entire membrane. from the posterior to the anterior, and with very gradual, force, very gradual. And maybe this membrane was not as tough as the posterior membrane, and fortunately did not land up in further iatrogenesis. And rest was not a very difficult step. Exchange, laser, because this patient already had multiple surgeries outside, and then put in silicone oil. Fortunately, could wriggle out of this, and did extensive laser also. So this is the third patient. This again is a relatively simpler RD. So what you notice here is that I started doing this vitrectomy. There are hardly any PVR in this patient, and I did a drainage retinotomy. I noticed this red blood subretinally. So I started doing exchange. I thought this is extramacular, maybe. So then I still give it a try. I did a retinotomy over that hemorrhage with gradual side-by-side movement, got the grip of this blood since it was still fresh. So, but aim is to get that grip of the blood in the subretinal space. I could tease it, but most of the hemorrhage did not come out. Then what I suspected was this, you see this track coming out. I suspected a needle perforation because during surgery, I hadn't done anything wrong which could result in subretinal hemorrhage. Or the patient was also not prone. So there was actually a subretinal, because this patient had difficulty in this block. So I made a small retinotomy again over another area of the hemorrhage because I was successful to remove part of the blood. So this time again got the grip, and again went to base again. After one grip, go to base again so that you have a major chunk of the hemorrhage which is under your control. So fortunately for me, the entire hemorrhage came out. And we could settle this retina very nicely, lasered and beautiful. It was a fourth surgery I am trying to show here. Young patient, 18-year-old. So in all young patients, I try to put a band, 15 steps of ear surgery. This was actually a post-traumatic RD. It is holding the macula. So young patient is face identification is not so easy. I thought in the anterior part I have identified with the face. So I was not very happy. I was with the suction only try to use the PVD. Not very happy still. I was trying to struggle to get this PVD in young with face. So put this PHCL also. And this was a retinotomy here. I thought let me drain out some fluid and then maybe I'll get hold of some. Could not. So PVD I could not induce in this. So I started partial exchange. This hole in the macula has come up. Has become very prominent. The under air, I was still trying to piece with the help of diamond dusted stretcher. I say PVD ka wo nahi. Fortunately, under air, I could catch hold of this large hyaloid thing, and then gradually patiently pulled it, the entire retina. This actually is the fold. Now you see this fold in the neck. So induction of PVD young patient is of paramount importance, and you may have to struggle. Then it included exchange. Fortunately, it can be covered by 18 patient. What did we learn in this young patient was that PVD induction may be difficult. You have to persist. I could have injected tricot, which I didn't in the initial part, because tricot does help in inducing PVD in these young patients. And the entire surgery or the result is dependent on induction of PVD. So this was a relatively simpler fifth surgery, a giant tear. no PVR, followed all the steps. You can clearly complete especially macula was pretty good. Paid attention to the horn, radial horn with this. Cut the anterior flap also. Mobilization of flap is very important. Here horn radial tension of the tail, so pay a lot of attention to this. Then build up the PSL up to the tail. Laser the retina, special attention to the horn, radial horn here. But if the retina had gone back completely, what if I could not position my backlash needle in the gap in the tear? So I noticed that once I was doing this direct exchange, I noticed this slippage. All slippage here. You see this is slip. The tear is not visible even with the wide angle unless you intend it. So it's not visible at all. And I was struggling because of the phakic eye. So I did a small hole here and made to the retina and got laser direct. So slip inferior. Ultimately, patient gets well. My last video here is a diabetic patient. This is a young diabetic IDDM. Multiple surgeries done elsewhere. Sorry. This patient had multiple surgeries for diabetic. So, first step was to remove this oil. This oil was 5,000 Once I removed this 5,000, because it takes around more than half an hour to remove 5,000 centistrokes oil. I took this oil, then injected it to dye to identify what is happening. So I created a bimanual sequence, identified severe membranes, and whatever best I could. Bimanual dissection of the posterior probe. And I thought the majority of the membranes had come out. I checked see how much retina is there. But the interior part was not affecting. You did some report there. And there was some suspicion that there is something wrong with this balloon here in the interior part. And I started to exchange. What I noticed was a separate oil in this, which I had not diagnosed. You see this oil coming out of the here, which I had felt for the 5,000 separate oil, believe me, I hadn't done in my life. That how to remove this 5,000 centistroke silicone oil, because from a vitreal also it takes a lot of time. What I did was that I took a high dose needle and with the help of active suction, and it took a lot of time. This oil is large here, like 10 scale, 5,000 centistroke did not come out to the oil at once. And I had ultimate to extend this period so much. We converted to a giant here. I cut backward this 5,000 oil. And this entire oil came to my section. Then injected PSPF. Then trimmed this anterior flap. And fortunately the retina now was while no further balloon, no further separate oil. Lasered as per tenant of PRC. This surgery taught me multiple things. That in a young patient who has already operated and you are removing oil, and if the retina is not flattening, suspect subretinal silicone oil. Removal of subretinal 5,000 oil, you have to take a large retina, otherwise it won't come. So these are a couple of videos I thought I'll share with you. And what I wanted to conclude with is, I have shown you 6 surgeries, but no 2 VR surgeries are the same. No 2 surgeons are the same. And at times, believe me, we are confused. We are in dilemma, operatively also. Because any awkward movement or any impatience which you show may result in disaster. And blindness for the patient. And there's always a constant struggle at close quarters during surgery. And every VR surgery for me is a fight, and fight for what? Fight for success, for the surgery, for the patient. And no one else, believe me, can realize the pain or the stress which VR surgery undergoes, except the fellow who is assisting you or a fellow VR surgeon. He only can realize that what this difficult surgery sometimes can mean. Thank you very much for your patience. I'll stop sharing here. Any comments? I'm more than happy to.
Thank you, Dr. Lalit, for excellent cases. I'm sure everybody learned a lot from this. We all in VR area, we encounter such problems, and these are always such difficult challenges. Your 6 cases every case taught us a lot. I think you did talk about subretinal cannula. I think we have to look at the cannula, whatever it may be, before we start anything. I think if it is not visible, there is something wrong. We can't. I have many a time just put something in the anterior chamber, done little surgery, and made sure that my cannula is visible. I think it's very, very, you made a great, and so was the iatrogenic brake. We can't pull beyond a point. Your membrane was so tough, you had to go by manually. So I think, again, a great lesson for everyone. And needle perforation, I think it is a nightmare for anybody. Once either it is hidden, nobody tells that there was a perforation because of injection or something. And it's a...
That was the issue in the needle perforation case. I was not made aware that there was a struggle during the perivalvular block.
Yeah.
So I started surgery in a routine. So as soon as I did, finish the vitrectomy, I saw this track. So I thought there's something wrong here. Even the first patient where cannula, I did check the cannula. It was intravitreal.
Yeah.
But the lesson I learned is now in any patient who has anterior segment pathology, because the choroid is thicker in those. So we have to enter. We have to enter. Straight rather than having a bi-step.
Exactly, very true. Especially now with the newer all small gauge surgeries, it used to be different with the when we had a thicker and bigger both cannulas. So absolutely, I agree. I have to only tell one thing here. If you see a needle perforation, this is for everybody. At least I have encountered many cases. If there is, because this is a double perforation through and through. If you have a vitreous hemorrhage along with it, don't sit on it. Please do surgery, remove the hyaloid. Otherwise, they have intraocular fibrosis later on, and there are a lot of problems. This intraocular fibrosis can never be removed with anything, modern instrument. It is so thick. Please remember this. This was a research done long time back by Stephen Ryan. That was his maximum contribution. Remember this. And we have burnt fingers. I have seen young patients losing eyes because they thought the patient has become all right. No, it is a great nidus for intraocular fibrosis. So I just wanted to add that. Yes.
Very true.
Absolutely. Well, I can go on and on. I don't know. There may not be that much of time. You have excellent cases. And I must say, how you must have removed that 5,000 centi stroke. You will be surprised. I have never used 5,000 centi stroke in my life. I don't use this. Whatever it may be, I hate this. This is a bad strategy. We can always put again, because I think it can give nightmares even removing otherwise also. And why we put 5,000? Because we have not done it.
I agree with you, Mangat. My usage may be 1 vial in 1 year maximum. That to a kid who can't position. You see, but routinely I have never used. But in the notes, it was nowhere mentioned. He had undergone 3 surgeries in the past. And I started using oil, but oil removal took 45 minutes from the vitreous cavity. So then membrane dissection was reasonably, okay. But subretinal oil, I never suspected. And that was another nightmare.
Great. Thank you very much for showing all great cases. I think please move ahead. We can otherwise...
I think let's move ahead. And I don't know who all are there, but...
Bhuvan is there.
Bhuvan, can you start your presentation on redesigning the macular architecture? In fact, topic is not very clear to me. Will become clearer after listening to you. Morning, Bhuvan. Can't see you.
I can see him, but he's not audible. He's not audible.
No, something wrong with the audio, Bhuvan.
Yeah, you are not audible, Bhuvan.
Go to the audio settings and increase the volume.
No, you are not audible at all.
You're not muted, but the thing is, you go to that audio settings and increase the volume. Hi, Dr. Pradeep, Dr. Simar. How are you?
Good morning, sir.
Hi.
Thank you so much.
Good morning, sir. Good morning, Dr. Lalit. Good morning, Dogra, sir.
Morning. Good morning.
Good morning.
Good morning.
Maybe
Dinesh.
Bhuvan can fix the thing and we can go to next. Yes.
If the next is Dr. Rajiv Kumar is not there, I can't see. Or maybe we can request Pradeep to start. Pradeep, are you ready with your presentation?
Yes, sir. I'm ready with my presentation. I'd love to start.
We'd love to hear your talk on managing PPF.
भुवन सर एक बार ना लीव करके फिर से ज्वाइन कर लें.
I hope my slides are visible now, sir.
Yeah, very well. You're audible also. You can carry.
Sir. And first of all, I thank DOS for giving me this opportunity to present. And it is such a privilege to be in midst of all my teachers and dear stalwarts of VR, looking at whom we have developed our strategies to deal with vitreoretinal surgeries. So as we say in Army, offense is the best defense. So the first idea is not to allow a PVR to happen. And how I do that is by using buckling elements whenever it is required, going for removal of the lens and placing an intraocular lens wherever I feel that aura shaving or handling of the ciliary body will be required. And confirming and reconfirming that a PVD has occurred, because a re-VR is almost equivalent to a remnant vitreous. If we have been able to remove the vitreous in the first sitting completely, generally there are no chances of having a re-VR. And the choice of tamponade should not be decided by factors other than the surgical factors on table. And one should not shy away from using oil, though the silicone oil study said that up to the grade of C3 PVR, they were able to use C3F8 and oil optimally. In an era where doing a silicone oil removal is quite safe, I feel that oil should not be shied away from when we are doing VR surgeries. So I'm starting off with a simple video of a mind blast injury patient. This is the large wound which has been repaired in the periphery. I am buckling the wound. We could see the ciliary body area, very thin pseudomembrane over there. I placed a 276 buckle over this entire gap in the sclera, removed the adhesions which had formed after the hyphema had settled. This patient was 4 weeks after the initial trauma. Once we replace the IOL, I go very gently removing the hemorrhage towards the disc. And as I mentioned earlier, that removal of the entire vitreous is very important. Hence, once I have reached till my posterior pole and started shaving the vitreous hemorrhage anteriorly, I ensured that I have removed all the vitreous from the posterior pole by staining on table. Whatever few membranes I could see, I peel. And after peeling all these membranes and removing the subretinal hemorrhage, which is quite usual in these traumatic cases, I always remove my ILM just to be sure to myself that yes, the PVD is complete. A gentle laser is done after that and placing the oil. So now coming to one of the most challenging situations while dealing with re-VRs, and that has been adequately covered by sir also. I will not like to repeat much here. But I'll say that transscleral drainage, as has been described in books, I hardly find it reasonable now to remove few of the muscles and do a transscleral drainage. The PFCL pushing the oil anteriorly towards the retinotomy generally does not work. And we don't need to create very giant retinotomies. So what we can actually do is use a hybrid vitrectomy technique as had been described by sir, going to the bimanual mode on our machine and creating a 20 gauge entry. As sir had used a large needle, what we did in our case, Here again, we had a very large bulle of subretinal oil, which was just not ready to come out. We introduced a 20 gauge MVR, and don't go by the color of this cannula. This is a 20 gauge cannula. And with this 20 gauge cannula, once you go below this giant retinotomy, it allows you to remove this subretinal oil to your satisfaction. It comes slowly. It does not come out in one bleb, but if one tries to keep their hand steady and keep applying suction pressure, it does come out after some time. Sometimes, even if you don't have a 20 gauge instrument to be applied to the active suction technique, I have been able to remove it with passive 60 millimeter mercury pressure inside also. The second question is identifying the PVR, that once we are doing a ReVR surgery, after the oil has been removed, one retinotomy is created and you are able to settle the retina. It is not so easy. If you remove any of the PVR there, it is going to create a problem later. And triamcinolone does not work as the oil has smoothened all the surfaces of the PVR, so the dusting does not occur actually. And BBG dye just stains the ILM. So what we have realized over a period of time is that the trypan blue dye can be safely used, and this trypan blue dye is the same that we use for anterior segment surgeries. So under air, leaving the dye there for some time, not starting the fluid till most of the dye has been removed, because if you start the fluid slightly early, the entire vitreous cavity gets filled with this blue stained fluid and you're not able to see the posterior pole during some time of the surgery. But once this particular step is complete, now you allow the fluid to come into the cavity, then you see this beautiful, nicely stained membrane. Now, this is a delight for all us VR surgeons that you can see these edges so easily and you are able to peel off. Though I'm using an ILM forceps for this particular step, one can also use an end grasping or a pre-Schaber forceps with large serrated edges. I created a small macular hole while I was trying to peel, but this case luckily did well and had a 660 vision after we had done an ILM peeling. So ILM peel always helps, and whenever I'm asked this question that what are your indications for doing an ILM peel in ReVR situation, my answer is always, it always helps. And the next step is that when to do the retinotomies and how much to do retinotomies. So one thing I realized that if you bring the patient under air, the air traveling under the retina itself serves as a guide and keeps telling you that how much more of the retinotomy needs to be extended. I'm not a fan of vertical retinotomy, so I prefer going circumferentially, use my cautery itself to create the retinotomy, and then use the cutter to complete it. Now, completing the retinopexy, again, is an issue that after you have done retinotomies, you have a settled retina. Sometimes the laser may not be able to reach till the anterior edge. And I have seen this tendency of many of my colleagues doing a circumferential 360-degree just periequatorial laser and leaving a large frill of unlasered retina anteriorly, which generally detaches, causes a ring of detached retina with the patient seeing a very good 612, 618, and we are very afraid to enter. But these are cases which later on land up with neovascularization of iris with hypotony. So it's a very dangerous combination. If you try doing DVR in those situations, generally it doesn't work. So what I have been doing in these cases is using cryo. So using cryo, again, this is an old-time technique, but one should not shy away from it. If you see such a kind of a break where subretinal fluid is there, however amount of laser you try to apply or try to suck out that fluid does not happen. If you just apply a single spot of cryo, it works out. And how to tamponade that, as I said, that checking under the ear that how much of the retinotomy needs to be completed has to be decided. And once you do a very large extensive retinotomy, the retina will roll back. And a direct PFCL oil exchange will help in these cases. And lastly, that what are the pharmacological agents we should use for preventing PVR? Though a lot has been talked about steroids, methotrexates, and anti-VEGFs also. But I feel that leaving a little bit of triamcinolone at the end of the surgery always helps. Does it work? Scientifically, I don't have an answer. Thank you so much for this opportunity to present.
Thank you. Wonderful concepts, Pradeep. I think most of them are agreeable. Whatever you have told, that first surgery is the best surgery. And ILM peel, we also, have increased the usage of ILM peel in a lot of these patients because it does ensure that all the membranes have been taken care of.
Sir.
I do not, subretinal oil, I haven't had any chance to remove from the sclera surface, but I agree that you have to have a high bore needle and do it. Cryo, I am very doubtful that cryo, because cryo, if at all I do, the relevance of cryo has decreased quite a bit. And if at all I do, which I do mostly, but has to be very, very low intensity. As soon as you see you should not see the white, this reaction coming at all. You should just be barely in the choroid, some change, discoloration, because by the time it's, thaws, it comes there. If you do in the retina, believe me, it will do anterior PVR. So rest of it, I think you have told very, very nicely. Oil usage in our country is especially higher compared to what SPR or other studies have shown that the usage is, gas versus oil is similar. But we should not overuse oil also, because under the oil membranes also form. That also is not so easy. But removal of oil should not be delayed also. You see, in our country, a lot of people keep roaming around with the oil, because the real test will come once you remove the oil. That is the real test of surgery. Exactly. With the oil, patient will have some vision, but once you remove the oil, then is the real test whether you have done a good job or not.
Sir.
I agree with your observations. Under air, I also have been doing for a very long time, staining with, but I don't use the trypan blue. I use a reti blue dye, which is a higher concentration of trypan blue.
Yes, sir.
Stains the membranes very, very well. So, any points from Dinesh, Mangat, or?
So, first of all, am I audible?
Yeah, now.
Yeah, you are. You are now.
Now you're audible.
Yes. I think I just wanted to add one point. Everything has been covered well. Dr. Pradeep, you did a wonderful job. I think when we peel membrane, especially in the posterior pole area, I have always peeled them towards the macula rather than away from the macula, because there's always a chance that we might tear. So I think that is something I think we should keep in mind, because many surgeries these days where these membranes are tough, so we may, or if retina is very thin there, we might pull a break. So that was the only thing I want.
I'll incorporate that. So that's a very valid point.
The other point is, once you hold the membrane, you're having only an AP direction, you can, have some wriggling movement sideways, thoda sa usko loosen karne ke liye.
Okay, sir.
You see, you have done a great job, but this we keep doing it, but not stressing sometimes.
This sideways movement. Yes, sir. We also use that, but I didn't show it. But yes, very, very, very valid point.
It's not especially for people like you and Mangat, but primarily for people who may be listening. It's not just a full AP direction. It's a AP weight, then move slightly like this and slightly. So, but very well, nice videos, Pradeep. Lot of love.
Thank you so much. Thank you, sir.
So let's go.
I use scissors. I use scissors quite a bit, especially in diabetics. And
diabetics is okay. In a reg RD with PVR, generally scissors is not. Maybe sometimes very tough. It's okay, but by and large in PVR reg RDs, maybe PVR C, C2 or whatever, we try to create one edge with the help of MPR and then peel.
And then pull it out.
Yeah. In diabetics, I agree. Posterior pole membranes do require, scissors.
Because with that you are able to remove those attachments and then.
Diabetics, you dare not
keep going further.
Yeah, diabetics, you dare not pull. Believe me, especially in the posterior pole, because diabetics are fraught with two B for break and B for bleeding. So this will happen. This will happen if you pull, because you see, bimanual is so precise and so safe. Only thing is inertia. I think we have to overcome the inertia of inserting one more instrument. That's all. So let's listen to Bhuvan, what has to tell us about macula, because he wants to revise anatomy of architecture, macula anatomy.
So thank you, sir. Thank you, DOS, for this opportunity. So, sir, I'm just discussing like something which are very simple cases, not complicated cases. The topic may look complicated, but it is just those things which distort the macular architecture, and then we do some surgeries to revise it. Majority of the things which I'll discuss, I think, have been covered by Dr. Lalit only. And the thing regarding the ERM, which Dr. Lalit showed, I also very recently had the same problem. I was removing a epiretinal membrane, which was very close to the macula, and I created a iatrogenic break. I think this was just 2-3 days back. So very important point, you should not try to pull a ERM. You should always try to give a tangential traction or try to tease it out, especially those taut membranes which are present at the posterior pole. And then a bimanual technique is of course very effective in such cases. And sometimes it is better rather you just segment those, dissect those membranes remove those bridging traction and do not try to remove whole of the membrane. So coming to my presentation, I'll be discussing few cases in which the macula has been distorted. So this is a case which had an old BRVO. You can see there is some swelling which is appearing on the fundus photograph. I did a OCT. There is a global ERM. There's so much traction in the macula, and this is long standing. So the prognosis in such cases, you have to explain to the patient very well, because despite a successful surgery, the patient may not gain vision because of the long-standing nature of this disease. So in such cases, I always use triamcinolone to remove the vitreous because this was a young patient especially, and Dr. Lalit has highlighted the importance of PVD induction. I think that is the key for success for every retinal surgery. So the vitreous was not coming out, PVD was not getting induced with a simple cutter. So I used the ILM forceps. And once I have that plane, then you can go further removing the vitreous, and the epiretinal membrane is also added to it. So you can see that once I removed it from the macula, then the membrane, it had some attachments at the disc and it was removed. Then this was followed by further removal of the trimming of the epiretinal membrane in the posterior vitreous hyaloid. There were some dense attachments which was also present, and I did an ILM peeling also in this case because of the presence of the traction. So the ILM was also quite adherent and it was coming out in piecemeal. So I'm going again and again and trying to have a pull at the ILM. You can see that it's quite densely adherent. It is not coming firmly. It's coming in small islands. So I think important for every VR surgery, I think we have also discussed in previous sessions with Dr. Lalita had, I think you have to be very patient in retinal surgeries. You don't have to be in a hurry, because if you're patient and you do your steps, then probably you might succeed even in complicated cases. So you can see the ILM is also very tightly adherent. There was a small bleeder while removing the ILM. So, but these things do not usually bother if they're not much, you can leave them. Then this is further followed by the vitrectomy, and this is the end of the case. So this was the patient preoperatively, and this is the patient postoperatively after about 6 weeks. So you can see that the macular contour is coming out to be reasonably normal. The patient has gained a vision of approximately 6/24 from a vision of about 2/60. So I think the patient was quite happy. So this is another case. This is a diabetic case. The patient vision is 6/18. You can see the fovea is quite normal, but there is a bridging traction which is present from the disc. There is a presence of neovascular fronts. There is a bump which is present at the fovea. So, operating such cases are very risky because the patient may have a reduction in vision, but the patient was very persistent. He had got severe metamorphopsia and the patient wanted to undergo surgery. So this is a case of PDR with the epiretinal membrane and having traction at the macula. So by explaining the patient everything, I decided to undergo this surgery. I was very clear at the beginning of the surgery that I don't want to inject silicone oil. I, in fact, avoid silicone oil in most of my cases, especially diabetic cases, because I feel silicone oil in a closed chamber will lead to increased IOP if there is a hemorrhage. So most of my dissections now I do with a 25 gauge or a 27 gauge cutter. So I've dissected the membrane from the center. Now looking at the planes from where it is not attached to the retina, I go between these and remove these bridging tractions. So you have to be again very patient. You can use a chandelier system. I use it quite commonly. But in this case, I didn't do a bimanual surgery. A chandelier was there, but I didn't do a bimanual surgery because most of my dissection was possible with the help of a cutter only. This is the nasal retina. So I've removed all these traction. You should not do any pull. In diabetic patients, it can lead to a bleed. It can lead to a break. But this membrane over the disc, I just teased it out. And you can see most of the traction has gone away. So again, this traction which is present, it will go on with time, but I decided to undergo ILM peeling in this patient also. And after staining it with brilliant blue, the ILM peeling was done. So this is the patient pre-operatively. And again, this is the patient, you won't believe this is the patient after 2 weeks. So after 2 weeks, the macula is looking much more better, and probably this contour will become better with time. So this was an international patient, so I've not followed it. After about a month, the patient never came back to me. So I hope he's doing fine. So this is another case. This was a case which had a posterior break, rheumatogenic retinal detachment with posterior macular pucker, posterior PVR. So again, I have injected, after doing a vitrectomy, I've injected brilliant blue. I'm trying to remove this membrane, but I'm not very successfully able to, I'm not successful in removing these membranes. And as Dr. Lalit highlighted, excessive pull at these membranes can create a iatrogenic break at the posterior pole, and then the case becomes very difficult. If there is a hemorrhage, it can go subretinal. So you have to be very gentle. You have to give a tangential traction rather than pulling it anterior-posterior. So since I couldn't get an edge of the epiretinal membrane, I couldn't remove this posterior PVR, and the retina will not settle without the removal of this posterior PVR. So I injected PFCL in this patient so that it pulls the retina back. And then under PFCL, again, I tried to remove this membrane. PFCL, it acts as a third hand. It will push the retina back. And then quite gently, you should just try to remove this epiretinal membrane. And luckily in this patient, the membrane came out and no break was created. You can see that the foveal, the macula has become quite healthy. Now it is looking, the pucker has been released. So now this is the patient post-operatively under silicone oil. You can see that the macula is quite healthy. There was a break which was lasered. And this is the OCT intraoperative picture. You can see there is still some ERM which is present there. This I done before the silicone oil removal. There are some cystic spaces. So while doing silicone oil removal, there was a part of the ERM which was still there. I'm trying to remove it, but the ERM is very, very adherent. So again, I'll just try to tease it out, relieve the traction, and then I'll just, you can cut it. We can dissect this membrane with the help of a scissor rather than completely trying to remove it, because it will lead to traction on the retina and it can create a break. So when this membrane is teased out, I'll just trim the membrane with the help of a cutter. With these 25 gauge cutters, especially the 10,000 cutting Alcon, you can go very close to the retina. You can sit on the retina and just trim these membranes. So this membrane post under was also removed when silicone oil was removed. So this is another case. So this is a case. So this is one of the most difficult macular hole surgeries which I have done. This was a case of pathological myopia having an axial length of 38. And the macular hole is not visible in this patient. I did a OCT, there was a macular hole. I stained with Reti-Blue, but the ILM is not visible because in such severely atrophic retinas, there is not much contrast. So I was just regretting that why did I take up this surgery? I don't even know whether the patient will benefit after surgery. But by God's grace, I think I was able to peel the retina. But I also went through literature later and I studied. And I think in such cases, I think the staining will be better if you do the ILM peeling with triamcinolone, or you do it with ICG even. So I have not been using ICG for many years. So I used Brilliant Blue only. We didn't have ICG at that time. But again, I think the only reason which I was able to peel the ILM in this case was that, you have to be patient. If you're too aggressive while removing, or you become impatient, then probably it will be difficult. So this was the patient pre-operatively, a case of pathological myopia. I removed all the cannulas and I did a direct entry. I removed the trocars and I went directly because my instruments were not reaching posteriorly. And post-operatively, you can see that although there is there is macular thinning, but the hole has closed. The patient also only had a gain of 2-line vision. So it depends whether you should do such surgeries or not. I did it, but next time maybe I'll be more careful, do more counseling, and will probably do it with the ICG or triamcinolone again. So this is my last video. So this was a case which had a young patient which had a trauma. And the patient had a subretinal bleed involving the macula around the disc and a inferior giant retinal tear. So again, posterior vitreous detachment and inducing a posterior vitreous detachment is quite difficult in such patients. It was not happening. So again, used the ILM forceps, created an opening in the posterior vitreous, and then with the help of a 25 gauge cutter, gradually teasing it out. There is also presence of vitroschisis in this patient. So I always use triamcinolone in young patients. It helps to stain the retina, to have a proper plane. So once the PVD is induced, then I went to the giant retinal tear. You do a good vitrectomy, you clear the anterior edges. And after completing the vitrectomy, I decided to drain this blood. So I made an inferior retinectomy, a small retinotomy, and I tried to drain the blood. Nothing came out. I made a superior retinotomy. Nothing is coming out. The blood is very clotted. So something just came into my mind, and I decided to infuse fluid through the superior retinotomy. And to my surprise, the fluid came out through the inferior retinotomy, which is there. So you can see this gush of blood coming out when the BSS is injected through the superior retinotomy. So majority of the blood removed. Then I just proceeded normally with as a GRT surgery. I injected PFCL. I did 4 to 5 lasers of endolaser at the PFCL edge and injected silicone oil at the. And so this is a post-operative picture. The patient had a vision of approximately better than 6/60. And this is under oil. This patient came to me last in 2019, and till 3 years, surprisingly, the oil was not emulsified. And the patient also advised for surgery, did not want to undergo silicone oil. And after the pandemic, the patient has not come. So luckily, the patient has got an attached retina. The macula looks quite healthy. There is a small choroidal rupture which is present there, but with this technique, the blood was also drained. So I would like to thank all of you for your attention. So over to you, sir, please.
So again, wonderful set of videos, Bhuvan, as usual. Last case, I agree, was the most challenging, and how did it come, and it did not come before. That squirting of fluid. This we also try always, because either you have to, if the blood is clotted, it may not, but if it is reasonably fresh, it may. So any questions from anybody? Or any comments? Dinesh, Simar, Deep?
Yeah. These are actually difficult cases which we do, especially kind of
Dinesh, your audio is breaking up quite a bit. Simar, any comment?
Summed up everything what a surgeon thinks and goes through.
Yes, I think excellent surgeries are very complicated cases. Just I think the diabetic case with the ERM, I wouldn't have, the BRVO case with the ERM, I wouldn't have peeled the ILM myself, but yes, I think trends are going more and more towards peeling the ILM rather than leaving
ILM surgery has become a nasha. It's become an addiction, actually. Any surgeon who goes inside, honestly speaking, if he does not remove ILM, he does not feel satiated. So, but believe me, we have had a reasonably competitive trial, especially ERM surgery. ILM peeling is not a problem. I'm talking about ERM surgery, simple.
Yeah, absolutely.
3-4 patients of Bhuvan's were ERM. I agree with you, Simar, on this, so that I do try, but I don't struggle. See, if it comes, macular hole is a totally different ballgame. ERM is again totally different ballgame. If ERM you have removed satisfactorily, and ILM, when I do try to remove, I do stain, but I don't want to struggle myself. I don't want to use any diamond dusted there. I do not want to use any traumatic instrumentation there. If it comes with one pinch glue and it starts peeling off, it's very good. But if it wants me to do repeated pinching and repeated struggle, I would not, because that I have seen is not advantageous. If it comes very, very.
I only have to say.
So I usually do it in cases like in diabetic cases, especially when there is marked distortion of the macula, when there are those lines visible.
You have to redesign the macular architecture.
Yeah, so though I don't do it in rheumatogenic RD, which they have been recommending. I don't, but I would like to do it in a diabetic TRD case. I prefer to do if done without much struggle. I would like to do it.
Yeah.
I only have to say one thing, Bhuvan. I have burnt my fingers in diabetic, especially macular ILM, where the retina became so thin later on. It's not one patient. I have almost 3 patients down the line, and I don't feel at all in diabetics ILM, because sometimes you will see such a severe thinning that their visual recovery will be very, very poor. So I think be careful about that. At least that is my experience. So I only reserve it if there is a hole or there are other indications that I have to do it. Yes.
So that's what I said. You see, ILM surgery, I have reviewed a lot of literature, and it's categorically said in a lot of meetings that ILM surgery is not advantageous in ERM surgery. It does not add any. Only thing is gives you satisfaction that all your membranes anterior to that have been taken care of. That is one thing. And people who say that you see further prevention of recurrence or this thing, I don't think so. It is borne out. I'm talking of one of simple ERM surgeries.
No, definitely.
I'm not talking of
But I think in most of the ERMs, the ILM usually comes along with the ERM.
That is another point. Second point was, if it's a tough ERM, the mere pull of that membrane from cerebral retina, and in case you stain with PPG again, you will have a patchy kind of stain, and meaning that most of the ILM also has come up. So very nice videos. Bhuvan, again, you see, this other comment was about the ERM surgery in a silicone filled eye. Munad, do you want to go directly under the oil and remove it, or do you want to first remove the oil and then do it?
Always under the oil, always under the oil. It comes off and it provides traction, also counter traction. I think that is something which we have done all the way right from beginning, and that works well. Absolutely.
So with this comment from the master, let's move on because there are a lot of.
Just to add one thing, sir. So
yes,
I also prefer to remove under oil only, but just unfortunately, as I said, 3 days back, a case which I did had a break. I really regretted that. Why did I do it under oil? Because if I had done it under fluid, probably I would have injected PFCL and had those tamponade and then removed that thick membrane. So I also do it under oil. So that was a very thick membrane, the one like Dr. Lalit showed. So I was just trying to remove it, and the moment I just snagged eyes, I saw that there was a similar break, slightly smaller than what in Dr. Lalit's video, but it was there, which was present just superior to the macula.
So by and large, I agree with Bhagat. By and large, we try to remove under oil. Like I said in my very honestly, I said, no two VR surgeries are same. So no two techniques also can be same. So by and large, we should try to remove under oil because majority of the times we are successful. If not, then there is an option always.
So sir, I think if the membranes are coming out easily, under oil is the best. But if it is a taut ERM, you should always remove the oil so that you can do a lot of manipulations without oil.
Yeah.
This I can
everything in VR surgery is one ball game. Only one ball game is visualized.
And you learn from
Believe me, there is nothing like it. It will come out.
And you learn from every iatrogenic complication you make.
Yeah. So let's go ahead and I don't know whether this Raji is there or not, or Shivrani I can't see. I can see Vaibhav smiling face. I just saw he has disappeared again. Yeah, Vaibhav, how are you?
All well, sir.
So, Vaibhav, are you ready with your presentation?
Yes, sir.
Or it's too early for you? You have just joined.
No, I was.
So let's hear Vaibhav. After that, we'll hear Simar. Vaibhav wants to tell us about chandelier-assisted buckling.
Correct. So just taking, extending your point, visualization.
Yeah. Absolutely, because the entire vitreous surgery is visualization. Yes, carry on, Vaibhav. Vaibhav, we all know Vaibhav is doing great work in Delhi, Gurgaon, in fact. Delhi NCR is same thing. And they have a huge hospital. In fact, I know the entire family so well. And Vaibhav, I've seen him growing and flourishing now very well. Yes, Vaibhav.
Thank you, sir. Thank you for the kind words. So, chandelier-assisted sterile buckling. So why isn't sterile buckling attractive to the young VR surgeon anymore? The main reason is lack of visualization for the trainee during procedure. There's lack of skill transfer from the person who's doing it to the person who's watching it. The crucial steps are still a mystery from the outside. There's lack of training, and there are further much more advancements in the vitrectomy part of VR surgery, especially with wide angle viewing. And the most important aspect that the chandelier brings to the game is ergonomics. So Chandelier has all the advantages, good view, good visualization. Every step is very clear for the surgeon, for the assistant, and for the trainee. Good skill transfer, effective training, and better ergonomics. As Dr. Lalisa rightly mentioned, जो दिखता है वही बिकता है. So surgeon can see and do better. The assistant can assist better. The assistant understands what is required in which step, because otherwise sometimes fell buckle for them also is difficult to manage. Trainees learn each step better. The anesthetist who is busy on the mobile phone can also enjoy the surgery and understand what's going on, and can also vary the anesthesia accordingly. Gives a direct, non-indirect, non-inverted view of the retina, which is also sometimes very, very crucial in certain steps. And you have the option of zooming in and focusing, which makes the surgery easier. Ergonomics. Vitreoretinal surgeons are at a high risk of developing musculoskeletal disorders. The neck and the back are at maximum stress when you're doing indirect ophthalmoscopy procedures in the OPD and OR. A very interesting study done in large cohort of vitreoretinal surgeons showed 55% reported both back and neck pain, and 7% of the VR surgeons required surgery to relieve their neck and back symptoms. That's a lot. And nowadays, with post-COVID, the era of e-learning comes into play, where we all are influenced by YouTubers, which are us only, showing YouTube videos. So Snell buckle, if you don't have a chandelier assisted view, then it'll be difficult to show that surgery on a website or on YouTube. So the learning kind of stops because it only happens in the operation theater where the trainee is there. Otherwise, you cannot really learn without being there. And why add more pain? And this study done by Dr. Ramesh Venkatesh and colleagues in 2017, which actually in Indian ophthalmologists had a national survey for back pain, showed that significant amount of back pain is there in surgical retina. So why should we add more back pain is the question. And in the era of 3D surgery, now we move from 2D to 3D and later maybe 4D as well. So why not do 3D chandelier Snell buckling? So just a short video of the key steps. So the important things is, most of the steps of the Snell buckle remain the same. Create a conjunctival peritomy all around, leave some amount of frill for the limbal stem cells to be healthy. Do your proper tenotomy. Create the tenotomy. Loosen the tenons all 4 quadrants. This was a patient with an inferior detachment with inferior break. And so very important to hook the muscles properly in the right plane to avoid hooking the obliques. So here I place a twin chandelier, which I normally use with a dock machine, and it gives you a good visualization because you get a broader view. You can visualize the break as well as the detachment inferiorly. Then you go in and mark the break after doing the cryo. Date your cell pockets to place an encirclage in all the quadrants, because this also gives you a good amount of view of the periphery all around if you're not seen that in the pre-op examination. So that's the key to do. So pass the 12 sutures after marking the position and choosing your tire appropriately. If you're placing a tire along with in this case I was placing a 276 tire along with a 240 millimeter band. So key steps again, after placing the first suture with a slip knot, tightening it up. We also have to be sure, because so these steps, you can avoid again lifting of the microscope, putting on the indirect ophthalmoscope, placing the 20D lens, and also the view gets compromised because your cornea also gets a bit dry, and later on sometimes also develops some amount of epithelial erosion. So you can visualize, you can indent properly, take your time, zoom in. Here there was still some amount of fluid, so went ahead and did a needle drainage, draining the fluid by milking out the fluid from posterior to anterior aspect. And so these steps, you can do it quicker, and even the person who's assisting and training you kind of understands the procedures much better. What's happening? So you drain in the bed of the buckle, and now again tighten sutures to be sure that now you are again placing the slip knot to be sure that you've had a good amount of buckle effect. So there's a good amount of buckle effect. The brake is in position, but there's some amount of fish mouthing that's there. Again, that also is very important to see because sometimes when doing indirect ophthalmoscopy, you miss out on these key steps, this key position. So injecting gas at the end of the surgery and closing up the case. This patient did well. So the additional important things when you're placing a chandelier along when you're doing a buckle is place it at 180-degree directly opposite the brake, the primary brake, or even you can also place it at 90 degrees to get a good amount of view. Avoid excessive angulation or manipulation in cases of phakic patient to avoid lens touch. Subretinal fluid drainage can also be done under the view. So you can also actually go through with a needle and you can visualize the needle and then drain the fluid. Use valve cannulas which are better because there could be some amount of vitreous prolapse when you are coming in and out with the chandelier to avoid incarceration. And when you're doing that, to avoid vitreous prolapse, reduce the intraocular pressure by doing some amount of paracentesis so that you don't have too much of vitreous prolapse. If it's there, you'll have to cut it off and preferably suture the chandelier port at the end. And special situations, as have been very well shown by a case study, a case report by the Schroff Eye Center, that even in patients who have severe leukomatous corneal opacity with Stevens-Johnson syndrome, who have unhealthy corneas, the view is not there. In this such a patient, you might have to do an endoscopic surgery sometimes, but you can sometimes even get away by doing a chandelier illumination. You can see the view is still there. Surprisingly, the view is still good, and you can get away by not entering the eye and doing a buckle with a chandelier. So buckle up, light it on, and teach all the steps and save your back. Thank you very much.
Thank you, Vaibhav, for this, I would say, controversial kind of topic. I don't think so everybody does it. So that's the reason I said controversial. And before, I don't know how many speakers are left, I don't know. So depending on the number of speakers left, we'll take up the discussion. To my thinking, what I see in participants, we have only 2 speakers left, that is Simar and Dinesh. Is that right? Or anybody else left?
Vivek was also
Yes,
there.
doctor.
Vivek is there? No, I can't see in the participants because he hasn't logged in yet. Any idea, Sabina? Is 2 speakers are left or how many are left?
Yes, doctor. We have only 2 speakers left, Dr. Simar and Dr. Dinesh.
So,
For now, we have only 2 speakers.
So before we ask the doyen, I'll ask Bhuvan, the relatively younger generation, about their comment on Vaibhav's surgery. Because you see, making 2 ports, you have made 2 ports. You could see the break pre-operatively. You said inferiorly there was a break, inferior RD, and then you have made 2 ports. Hopefully they were valve cannulas, and you said if vitreous collapses, we will suture that, so wanted comments from relatively younger people. Bhuvan,
Sir, I have done 2 cases. I have done.
One is doing it. One is doing it. One is recommending it. You see, doing it.
So I'll tell you, sir, the pros and I won't
pros and cons. We know. Pros and cons. All of us know.
Sir, are
you recommending it?
Yeah, sir, I will recommend it in a patient, in a young patient, where you want to do a scleral buckling, but you are not very sure that you will be able to cryo the break because the media is slightly hazy, there is presence of PVD, there is mild cataract. Then I think in these cases, this is a very effective technique. The only thing you have to be...
Let me, Pradeep, your take.
Sir, I am a slightly conventional surgeon, so I have never been very comfortable with this. I use my indirect and I'm very satisfied with that. So I've never used a chandelier buckling with good effect.
So this is, I think, one of the things that I do differently from Dr. Dogra, who's taught me everything.
My question.
I do entirely chandelier.
Do you recommend it?
Yeah, I would recommend it and have good results with it. But just a couple of points from what I saw from Dr. Vaibhav's videos. And so especially in cases when you don't know the break preoperatively, that is where it really comes in handy.
So my question started that he said indirect colonoscopy preoperatively revealed inferior RD with a break.
I do it even those also. I'm just telling the difference from what we just saw, what I do currently. So I also put in 2 ports. Don't use this 2-port chandelier, but the single Alcon chandelier that comes. But both in the superior-nasal and the superior-temporal, because when I feel when you are trying to search from the break with the chandelier, the quadrant under the chandelier is not very well visualized to you. So I like to do, so since we are doing this for the clarity of the view and everything, and you have put in 1 port, you can always put in another one and get a proper view, see the whole retina, cryo the break and do a good buckle. So I just put in 2 ports in both the superior quadrants and do the chandelier buckling.
So now let me ask from
Dr. Dogra is not going to agree with us. So
I deliberately moved in the reverse direction.
Well, Dr. Lalit, I have never done it. So we being traditional bucklers from old times. Incidentally, as you mentioned, my son, Mohit Dogra, I think Simar has learned this more from him than from anybody else. So he is also very fond of doing this. But somehow, to me, the necessity has never been felt to do it this way, as well as also whatever additional things happen with the chandelier. I mean, we are really going inside the eye, and we don't go inside the eye as far as the buckling is concerned. That's how we did all our life. I'm sure you did the same. So
I agree with some points which were, which Bhuvan was trying to mention, and I scuttled him, and Simar also was saying. You see, when media is haze, for the sake of visualization, I may agree. I have one very nice video which I have done just for the sake of recording Vaibhav, not for the sake of advocacy. Believe me, I do not advocate. And I'm not a very big fan of one of your slides which you said 55% and 7% this thing. Better do some exercise rather than not teaching indirect. See, not including indirect in the curriculum of VR surgeon, believe me, any VR surgeon today who does not know the art and science of indirect, I would be hesitant to get myself operated from him. You see, isko indirect nahi aayega na. As of now, I may be conservative. You can pull me down, Mangat can, whatever. But indirect holoscopy, believe me, is bread and butter. Whatever MIVS may expand to. But the dynamics of indirect holoscopy, nobody can beat, believe me. The dynamics which it adds, 3D visualization, right, left, depression here, there. Because indirect holoscopy has to be taught, has to be in the curriculum. Let it be. It's only laziness. It's only laziness which people do. The reason I'm taking some time is because
actually, Dr. Lalit, that is where the problem is. Why probably we are shifting to this kind of surgery, because we are not, the younger people are not interested in doing indirect holoscopy. They not only that they will go through procedure like they have these wide angle now, ultra wide field. So they don't feel the necessity, and that's how there is a problem that the younger people, and that's how they don't want to do vitrectomy for every case. They don't want to do buckling first phase.
Yeah.
Then if they want to do at least in some, they'll do chandelier assisted, because indirect
coloscopy. Pradeep, let me be very blunt. Pradeep, suppose God forbid somebody of very closely known to you, or let me say myself, if I have an RD, if it is buckleable, I will force Vaibhav to do buckling, not do a VR surgery with chandelier. That is my honest.
Sorry to interrupt you, doctors.
Yeah.
I am really sorry for the interruption, but can we please begin with our next speaker, as we have very few time left?
Okay.
Just to add one question in the chat box.
Correct. So with these comments, I think we'll move on to Dr. Simar.
Sir, I think endogenous. The key to a success.
There is a question in the chat box about how will chandelier help in SRF drainage? Why were 2 ports made?
Chandelier, I don't think so can help in SRF drainage at all. It's I think because Vaibhav also showed drainage through a needle only. He drained it under the buccal only and marking with the help of chandelier. I don't think so has help in.
Sir, I think even in chandelier assisted scalpel buckling, indirect ophthalmoscopy you have to master. I think we have
what is the ultimate fayda?
Sir, the ultimate faida is, sir, with a chandelier, if you're doing a chandelier assisted and you just cryo one break, probably you will miss something or the other because you don't keep on indenting and searching everything.
I am against entering a vitreous cavity with two instruments. दो आपने track बना दिए vitreous के अंदर.
Sir,
in a young patient.
In some patients, sir, it benefits, sir. In which you will rather do a vitrectomy.
I will do a vitrectomy. If I enter vitreous cavity, believe me, I will do a very neat total vitrectomy, posterior hyaloid base dissection. That is what I want to do vitreous. I do not want to do a non-vitrectomizing vitrectomy. So let's hear Simar for the short of time. Endogenous.
Thank you, sir. And thank you, Delhi Ophthalmological Society, for this opportunity. So after seeing some beautiful videos, I'm not going to have those many videos, but to cover the basics of endogenous endophthalmitis. So it is basically an intraocular infection secondary to a hematogenous spread of microorganisms and constitutes about 2 to 8% of all the cases. And we need to have a high degree of suspicion in cases with intraocular infection without any antecedent history of intraocular surgery or trauma. And contrary to the popular belief, majority of our endogenous endophthalmitis patients walk into our clinics and they are not usually admitted sick or debilitated prior to having the endophthalmitis. So the risk factors are recent hospitalization, immunocompromise. We have to specifically ask for this in any form. That could be diabetes mellitus, could be long-term steroid or immunosuppressive use. I think we had a spurt after the second wave of COVID of endogenous endophthalmitis, which were related to long-term steroid use. And we have various publications on that also. Could be HIV or could be a systemic malignancy. So these questions need to be asked when we get a patient. Urinary tract infection and indwelling catheter in a chronic disease patient. IV drug abuse, an important cause. And IV infusions for trivial infections in the periphery where they get some dextrose infusions. And I think we reported from our center also where we showed that actually those dextrose bottles grew the fungus from where those patients were coming in the periphery. So as far as the etiology is concerned, it can be bacterial or fungal, gram-negative organisms predominating in our part of the world. And the Western literature supports more of gram-positive organism, Klebsiella, especially because of hepatobiliary infections. And second would be the urinary tract infections. The fungal infections, endogenous, can be due to both yeast and molds. And it's important to know the differences that these two basically cause in the eye. So yeast, that is most commonly Candida, and mold, that is most commonly Aspergillus. So the yeast, they have a longer history and a more indolent course, while the molds would have a shorter history and a more aggressive course. And yeast are most commonly associated with patients with prolonged admission, indwelling catheters, or on total parenteral nutrition, while molds are more commonly associated whenever there is neutropenia, could be iatrogenic immunosuppression in solid organ transplant patients. So yeast are more common to be misdiagnosed, some studies quoting as much as 50% misdiagnosis of yeast endogenous endophthalmitis, while Aspergillus is mostly a classic diagnosis. The yeast prefers the vitreous to grow. So you see more of vitreous inflammation, more of vitreous balls, while the Aspergillus grows in the subretinal and the sub-RP space. So it is more damaging actually. And yeast may do well with systemic and local antifungals also, but Aspergillus more or less requires a vitrectomy. And again, because it is mostly in the vitreous, yeast have a better functional outcome and molds tend to have poorer functional outcomes. So whenever we have a patient, these are some of the battery of investigations we would like to get done, especially to get the source of the infection. So blood cultures, urine cultures, and we need to send them on 3 consecutive samples, 3 consecutive days, and not just one sample. And the first sample to be prior to the first shot of the IV antibiotics that you would like to give. Blood sugars, blood counts, HIV status, targeted examination and history for any systemic source. And of course, the sample from the eye, the vitreous or the AC tab for culture sensitivity. And we would like to admit the patient, such a patient, and not keep him on an OPD basis, get a systemic workup, start systemic antimicrobials, intravitreal antimicrobials, and vitrectomy. So coming on to a couple of cases, just to exemplify, this is something of a very typical presentation we have of endogenous endophthalmitis. A 45-year-old diabetic man with decrease of vision, both eyes for the last 1 month, recently treated for fever and dysuria and uncontrolled blood sugars. So you can see this abscess kind of spurting out from the posterior pole in both the eyes, thankfully sparing the fovea in the left eye. And you can see it growing into the vitreous, and this what is typically described as a rain cloud sign in Candida endogenous endophthalmitis, coming from the choroid to the retina and then that. So urine culture was positive for Candida sensitive to the azole group of drugs and resistant to amphoby. We treated the patient with 2 injections of voriconazole in both the eyes, as well as systemic voriconazole. The right eye already had a macular scarring because of the infection coming from the posterior pole. The left eye was still the balls in the vitreous were not going away. So we decided to do surgery for this eye and also prevent this fovea from puckering into the infection. So a 25 gauge pars plana vitrectomy. Started with the core vitrectomy, clearing out the vitreous, sending a sample of the vitreous for confirmation again, and then detaching the hyaloid from around that abscess at the inferior to the fovea and till the equator at least. So this part had some bleed and had a retinal break here because this abscess usually involves full thickness of the retina. So it's important to detach the hyaloid all around it, kind of trim it over there, and you can eat this away. And especially for the posterior pole part, because once we have a abscess right here inferior to the fovea, it is invariably going to cause a macular pucker. So this is something where I prefer to do an ILM peeling just from the posterior pole till the abscess so as to save the fovea from a subsequent pucker that might occur. And once the ILM was peeled from over this abscess, you can see we could take some abscess out, which was just under the ILM also. Fluid air exchange was done and laser was done to that inferotemporal area where there was a suspected break. And the patient was left under sulfur hexafluoride gas, 20%. The patient did well following the surgery. In the left eye, you can see that edema from the macula is slowly going away and the break is well sealed. And now it's been almost 6 months following this patient and he's doing well with the left eye. The right eye, unfortunately, already had the macular involvement and it's a major deterrent to the visual gain. So this was a 22-year-old female who presented with low vision 20 days post delivery. This was the first child. So she had a sudden diminution of vision. On getting to the targeted source, we could find this cracked nipple with pus coming out of it, and culture from the pus from the nipple as well as the vitreous staph both grew staph aureus, and which was sensitive to vancomycin, and we treated with just systemic vancomycin and intravitreal vancomycin, and we can see the resolution. And as can happen in up to 10% of these cases, once the hyaloid detached, there was a horseshoe tear right here inferonasally, and so subsequently underwent vitrectomy with gas tamponade again, and had a good anatomical outcome, but again, functional outcome would be limited due to the subretinal scarring at the posterior pole. Something that I personally see a lot often, neonatal endophthalmitis. This was a 10-day-old child, white reflex and redness in the left eye. And most of these children are septic, they have sepsis, they are admitted, but eyes are not taken care of. So once they start with a small focus, usually that is not detected. And usually they come back to us when they have such a picture. You can see the vitreous cavity is full of echos, and you can even see a T sign here. So progressing on to panophthalmitis. So usually the visual prognosis is dismal in such cases, and a very nice study from the LP Prasad group, which showed that there are 2 forms of neonatal endogenous endophthalmitis. One is the fulminant, as I just showed, and the other is the focal retinitis that we sometimes detect incidentally during ROP screening. And that usually has a better outcome, and we can treat that subsequently. So from the Indian perspective, just a few points of difference from Western literature. We have a younger age of presentation compared to the Western literature. In majority of our cases, we do not find the underlying cause. So the patient just walks into our clinic and they do not have an underlying cause, or we may not be able to find it. Bacterial causes form the majority of our cases, with Klebsiella being reported a lot in Southeast Asia due to hepatobiliary infection. But fungal infection should always be kept in mind, and cases with immunocompromise and IV dextrose infusion or any form of treatment for fever outside. And yield from blood and urine culture is often poor in our cases because we get partially treated patients when they finally come to us, and protocols usually have not been followed of sending for culture before starting the first dose of treatment. And early vitrectomy, both us as well as Western literature, early vitrectomy increasingly being preferred. So a lot of this information about the Indian scenario comes from these two landmark reviews in the landmark publications in the previous year of IGO from the LV Prasad group and from Cochin. So to conclude, need to keep a high index of suspicion to detect endogenous endophthalmitis, as it may occur in otherwise healthy individuals. Effort should be made to find the source of the immunocompromise and infection. Targeted antimicrobial therapy helps salvage the globe in a majority of these cases, and early vitrectomy should be considered, and it gives better functional outcomes in some of these cases. Thank you.
Dr. Lalit, I have to excuse myself from here. I have to go to another hall. So I hope it'll be all right. So I'm sorry for that, but I have to do that. So thank you. Thank you for, you are muted, anyway. So Lalit, you are muted.
Yeah, sorry. I will request Dinesh to please start his talk because I don't want to miss his talk also.
Yeah, I'm just
Thank you, sir.
So Dinesh is going to tell us about work-related ocular injuries.
Good morning, everybody, and thanks for giving me this opportunity. Basically, I come from an industrial city of Punjab, and I shall be talking about work-related ocular injuries, mainly the industrial trauma. So, worldwide, 55 million eyes are believed to eye injuries are believed to occur every year, and about 1.6 million blinds from these injuries. Globally, about 200,000 open globe injuries each year, with an estimate of 3.5 per lakh per year of perforating injuries. Mostly these are work-related injuries, and they affect young adults with productive age group and economic consequences, of course. Indian studies are, the data is not very good, but there are a couple of these studies. Reported incidence of ocular trauma is anything between 1 to 5%, and amongst the total number of blind cases in India, 1.2% they contribute is contributed by the injuries. So classification, mechanical like blunt trauma, perforating or penetrating trauma, foreign bodies, and then the non-mechanical like chemical, radiation, electrical, or thermal. For this talk, I'll be restricting myself to the perforating or penetrating injuries along with foreign bodies. So this is a pie chart with various causes of occupational injuries, and housewife all get injuries. Manual labor, factory workers are of course prone to occupational hazards, and farmers are also included in this occupational injuries. So according to the classification, Birmingham trauma study, there's a closed globe injury where the full thickness wound is not there. So that's usually resulting from blunt trauma, or there can be a lamellar laceration. And then the open globe injuries, it can be a full thickness wound of the eye or the rupture caused by blunt trauma, or inside out injury. It can be a full thickness wound with a sharp object like a laceration. Single laceration is a penetrating injury, and if it is a double perforation, it is a perforating injury. And along with these, there can be a retained intraocular foreign body, and which come in various sizes and shapes. So high index of suspicion should be there. Any dark spots or streaks on the sclera or a jelly-like material should point you to the globe laceration. And if you have any doubt, assume the trauma to the orbital area to be involving the globe. So these can be industrial, accidental, like roadside, And these are surgical emergencies and need to be repaired at the earliest. For retained intraocular foreign bodies also, we need to have a high index of suspicion. There can be foreign bodies lodged in the anterior chamber, lens, iris, or retina vitreous. And if there is a double perforation, of course, the foreign body can go and lodge into the orbit. So in our center, we deal a lot of these industrial injuries, and we reviewed our data of 70 patients of open globe injuries who underwent surgical repair at our center. And we took into consideration the mechanism of injury, preoperative visual acuity, time lag between injury and surgery, and size and location of wound. And the other parameters which could predict visual outcome, we took into consideration retinal detachment at presentation, uveal or retinal tissue prolapse, vitreous hemorrhage, lens damage, hyphema, retained foreign body, and how many number of procedures were performed. So we grouped them into 6 different groups depending upon the presenting visual acuity. And we had a group where the no PLIs were there, and it is said that even for a no PLI, you should try your best, and you might get some positive visual acuity in these situations. So age of the patient, initial visual acuity, evidence of infection or inflammation, uveal prolapse, vitreous prolapse, lens status, and presence of retained foreign body. All these things were taken into consideration. And at last follow-up, best corrected visual acuity and anatomical status was recorded. Preoperatively, we did ultrasounds, X-rays, and CT scans as needed. But CT scan is my most preferred investigation in this situation nowadays. So out of the 70 patients, mostly they were males, and mostly at presentation, they had a very poor visual acuity. 45 of these had 162 PL vision. And post-operatively, we could regain reasonably good vision in 37 of these patients. Similarly, 11 patients had endophthalmitis at the time of presentation, and the visual acuity, of course, in these situations were low, and still we could salvage at least half of these patients. Lens rupture or dislocation was there in 45 of these patients, and we could again salvage at least 17 or maybe up to 25 of these patients. Uveal prolapse was there in 13. Again, post-operative visual acuity or recovery was good in all 6 of these patients. Detachment, vitreous hemorrhage, 28 patients, and they always present with a poor visual acuity, and could achieve a good post-operative visual acuity. And this is important. Retained visual intraocular foreign body was present in 54 of these patients with a very poor presenting visual acuity, and we could regain good post-operative vision in these patients. So these foreign bodies, they come in various sizes and shapes, and these are few of those foreign bodies which we have removed. Most of these were ferromagnetic iron foreign bodies. So these are another few of these foreign bodies. They come in different, all different types of shapes and sizes. And this is a small video. If the time is permitting, I'll just go through this. And in this, on X-ray and ultrasound, we thought the foreign body is very small. Along with that, there was endophthalmitis. But when we went in, this was stuck at the back, and we literally had to pull out. And you will see that this is such a large foreign body. Removing these kind of foreign bodies, I have now decided that the CT scan should be done in all these cases. So this was the large foreign body. It was nearly about 2 centimeters.
My God, very great.
these are few of those images of foreign body or trauma cases where we have done multiple surgeries and implanted lenses with good results. So open globe injuries are common and preventable cause of permanent visual loss, and the factors which correlate significantly to visual outcome are type of injury, initial visual acuity, extent of wound, hemorrhage, detachment, and presence of foreign body. Prevention is, of course, better than cure, and there should be mass awareness about it. There should be vision screening of industrial workers, determining of visual requirements, and they should be trained about eye hazards and advised accordingly about the protective and corrective eyewear. And these are the kind of signboards which the industries are supposed to put and train them. To conclude, there is a lack of good information system on injury burden, its pattern and impact. Ocular health policy, of course, includes it one of the components of national health policy. However, there is very little attention paid to mitigate the effects of occupational diseases. Awareness and attitude of workers and employers towards safety norm is partly responsible for the low compliance. Thanks a lot, sir. Thanks for patient hearing.
Thank you, Dinesh, for finishing in time also. Must say that very nice compilation of data, especially in a private setup, not easy to have data of 70 to 80 patients. And also, Simar, I was very much impressed with your talk on endogenous, one of the best talk I have heard on endogenous endophthalmitis. Very nice talk.
Thank you so much, sir.
Really sorry that we don't have much time for discussion and time is up, but I wanted to compliment Simar because of one of the best talks. I have heard so many talks on endogenous, but this was very, very nice. And Dinesh must compliment for, in a private setup to have data of 74 eyes and with such a huge collection of foreign bodies. I am sure we will do your talk again sometimes. But I agree that trauma is not a small subject. Trauma is pan ophthalmology itself. And but suffices to say that it's the VR surgeons who primarily save most of the eyes. And one very nice comment which you made was that even PL negative eyes should be offered surgery with proper consent. With this, I think we would like to conclude this session and hand over to the audiovisual people. Thanks a lot. Bye-bye.
Thank you so much, sir.
Thank you, everyone.
Thank
you.
Thank you.
You made very nice talks.
Thank you, doctors.
Wonderful talks.
For the wonderful session.
Yeah. Thank you. Thanks a lot.
Thanks a lot. Thank you. Thank you, sir.
Thank you. Thank you.
You have to go by road to Alibag, and from Alibag you have to take. So we can
Hello.
send one Gadi ahead, or we can go from Mumbai to Alibag.
Hello.
Yes, sir. Yes. Lalit.
Good morning.
Yeah, good morning. Lalit, you can continue.
Hello.
Hello, Lalit. Continue.
Pranam.
Pranam, Lalit.
How are you, sir?
Fine, I'm fine. So I will request the other panelists to join. Mahipal has already joined. So I request the Grover and Pradeep Sharma are not coming. Rohit Saxena, Mahipal has joined. Ragini has joined. Manish is going to join slightly late. Then the Nikhil is not there because he is joining some other session. Hello. Hello.
A lot of people are requesting, sir, to promote them as panelists. Dr. Mahipal, Santosh on our.
Yes.
Admin, you have to promote them as panelists. Then only we can see them.
Yes. So I think, so I think the person who is there in the IT person should promote them.
Yeah.
Sir, but the session has no schedule for our sides.
Session, it is not
So
scheduled.
just a minute. We'll just check and let you know. I'll just get an update from the other team.
What is this, sir? You say that.
What will you do? What will you do? Session is there by Dr. T.P. Lahane. You can just talk to Namrata or someone. I will talk to Namrata. so that you can promote them.
So you can take your car in the ro-ro and then आगे गाड़ी से जाने का आपको सब मालूम है तो इधर अलीबाग में मुड़ो हम लोग तो जाने ही वाले थे मेमोरी हमारा फाइनल है जाने का.
Good morning, Lalit and Natarajan and Sumit and Dr. Lahane, please.
Morning, Mahipal.
Morning.
I have just now I have spoken to Namrata.
In fact, Santosh is waiting, Sumit is waiting.
Sumit has joined.
Sumit has joined, requesting IT person to just upgrade this one also.
Santosh.
Santosh also. Lalit is there. Santosh also. IT person, the Namrata is going to send you the this one session. So requesting to upgrade the Santosh also.
Yes, doctor, will do that.
Also Apurva Grover, please. Also Apurva Grover.
I believe we have added all the speakers.
Okay. Thank you.
Good morning, sir.
Thank you very much. There was some communication gap. I'm sorry for that. So now I will request the Sumita Muthure has joined.
Not till, sir.
Okay. And the Sumit you have joined, na? Sumit?
Yes, I have joined. Rushad is also there and Apurva is also there. So we can start with cataract with the Rushad. Rushad, are you there?
Yeah, Sumit.
Rushad, you start from cataract.
Yes, sir. I'll just start sharing my screen then.
Okay, Rushad, go ahead.
Rushad is a dear friend and senior fellow, and he is being not less than a mentor to me during my fellowship. He has done his cataract and cornea fellowship in Narayan Netralaya and working at the Shroff Hospital in Delhi at present. So he will be presenting a cataract subspecialty session.
Is my screen visible?
Yes.
Yes, Rushad, your screen is visible. Go ahead.
Thank you, sir. First of all, at the outset, I'd like to say a big thank you to Professor Lahane, sir, and Sumit for giving me the opportunity to present. So I'll just be presenting a couple of scenarios and we'll discuss what we should do in this particular cases. The first case is that of a brown cataract. You can see it's a fairly dense nucleus. This patient also had some gutte, so we decided to go ahead with an SICS rather than a phacoemulsification. Initially, the peritomy is being done, followed by the cautery, which you can see over here, and the incision. Along with that, the scleral tunnel is going to be made. So here you can see the tunnel being fashioned. So all this was normal. While doing the rhexis, it was a little challenging to do the rhexis, and it came out a little bit smaller for the density of the nucleus than I wanted, but I managed to complete the capsulorhexis. But this is the important step when, while doing hydrodissection, suddenly the entire nucleus just dropped down. You can see again now, following this case was referred to the VR surgeons to manage further. So this is predominantly the complication I wanted to show in this case. I'd like to ask the expert panel, what could we have done preoperatively to diagnose this, because the patient didn't have any obvious phacodonesis. There's a very mild kind of thing. And was this like a capsular block syndrome that happened? Should I have made some relaxing cuts on the capsulotomy? What should have been the management?
Okay, Dr. Mahipal.
So thank you, Rushad. The first thing is that having such a drop, one of the things that comes to mind, did you examine the other eye?
Yes, sir. The other eye also had a dense cataract. There was no polar component that we could see in that.
Okay, so that's the first thing, that you need to rule out a polar component, because this only happens when there is a significant polar component and there's a blowout because of the hydro procedure that is there. capsular distension syndrome, basically your rhexis wasn't terribly small. So if you would have depressed the nucleus from the other side and done smaller squirts, that would have happened. But also the second thing is I would have used trypan blue, which I obviously didn't see you use. And if you thought that the rhexis, because you had planned an SICS, maybe we could have gone ahead and done an extension of the capsular rhexis. There's no harm if it is coming small that you spiral it out more and increase the size of the capsular rhexis. Apart from that, I think the quantum of fluid, that obviously I can't judge from the video as to the quantum of fluid and the speed at which it has been injected. Those are the other things that one would have done from this thing. And sorry, I missed the video. At times, if you do the hydro from the side port rather than from the main port, that also has a chance of doing a capsular distension syndrome. So these
So
are
this
couple of
was
the
from
things.
the main wound only.
Yeah, sorry, I just didn't see it at that time, but just for the sake of completion, I was saying that that is the other thing that could be done. So these are a couple of the points that I would wish to emphasize in this particular case.
I think what Mahipal said is very true, Rushad. We must see the other eye, and here the rhexis. In such cases, if you are methylene blue and slightly larger rhexis, and secondly, if not, you can go for the extension of the rhexis. Otherwise, when there is a small rhexis in such situation, or such type of capsular block syndrome or posterior polar cataract, we may get such type of thing. And I think we have got Lalit also. Lalit, are you there?
Yes, sir.
Now you can tell us now how you will proceed for this case.
See, for us, it's actually not a big job here because we will go ahead and do a complete vitrectomy. The only thing I would like to say is what Rushad has shown is because the capsule looks intact, the anterior capsule rhexis is very nice. So we will do a complete vitrectomy, do a phacophrac, and do a IOL insertion as was being planned. So the caveats for the success is total vitrectomy, not a because the nucleus to me looks pretty hard because it's brown colored view which I got on the video, and you most likely phaco-fragmentation will be required, and we take out the nucleus, do a total vitrectomy, and do a foldable IOL and put the lens on the anterior capsule.
Sir, one point, Rushad,
Yes.
what you had said, I would not be in favor of giving a relaxing incision. You said about the capsular rhexis, you said to give because that is when the tear can extend behind. So it's better to enlarge the rhexis rather than do a relaxing this thing.
Yes, it is a no, extend rhexis only, not relaxing. You can't give relaxing incision. It is always better to extend the your rhexis. Okay, now how do you have managed, Rushad?
Sorry, sir.
How you have managed this case?
So basically, we had referred to the VR surgeon. The frag was done, the same thing that Dr. Lalit Verma said, and then we managed to insert the IOL into the sulcus, a 3-piece, and then we managed to do an optic capture also with the anterior capsule.
Can I add a point? Hello.
The overall visual prognosis may not be affected. I think with the total vitrectomy, taking out the nucleus and putting it on the sulcus, overall, although surgery gets prolonged by around half an hour, 45 minutes, from the patient's point of view, the overall visual prognosis should be similar.
I think during the first surgery itself, you can consider placing an IOL in the sulcus and suture the phaco wound well. So it makes our job as VR surgeons easier. We only have to go posteriorly and we don't have to enter the anterior chamber if a lens is already placed and the wound is sutured well.
Okay. I think after this, Rushad, you have got a second case?
One more case, sir. I'll just screen. I think it was again. Yes. Okay, so this is the second case with a 45-year-old patient presenting with blurring of vision in both eyes since a year. The best corrected visual acuity in the right eye was 660 and the left eye was 636, and it was an NS2 cataract. When we looked at the cornea on the slit lamp, what we can see is inferior thinning. This looks like a pellucid marginal degeneration, which was evident on the topography as well. When we looked at the IOL master, you can see here that the K values are quite, there's a large astigmatism. The K1 is 40 and the K2 is about 62 in the right eye, and it's about 58 in the left eye. When we did the calculation with the Barrett and the SRKT, we were getting a IOL power of around 15. We also went and looked at the Kane formula, which is being used more and more for keratoconus calculations for IOL power, and this was giving us at around 12.5 diopters for the right eye and about 18 for the left eye. So my question to the panel is, in these kind of cases, what IOL power calculation do you normally use? How do you plan these cases? Because there's a very high chance of refractive surprise in these kind of eyes, especially in keratoconus or pellucid marginal degeneration. Do you counsel them regarding contact lenses post-surgery, especially if they are on them beforehand?
Dr. Mahipal, sir?
Okay, so Rishad, the very valid point, it's a dilemma for all of us. The first thing is that whenever I have an ectatic disease, though the results may be slightly suboptimal in case of a PMCD, but I would prefer to cross-link the patient first. And once you have cross-linked the patient and you have got stability, then there'll be much reliance on these formulas. The Kane formula, as you said rightly, is correct. But often in such things where you have a 14, 16 diopter kind of an astigmatism, you have to tell them about specialty contact lenses, and that you will require, because you may do whatever you want. The patient will still need a contact lens to take care of the degenerative ectatic change that the patient has and the asymmetrical cornea that the person has. So the criticality of an IOL power becomes slightly less. Because you may do anything, the kind of astigmatism that you have shown, that is not going to give the person a good vision with glasses, and it has to be a contact lens, RGP or a scleral contact lens or a positive, whatever. So those are the kind of lenses that need to be done. So you rightly said that the patient needs to be counseled. That I will not be able to give you a perfect thing. And as regards this, and it's the same, I don't therefore go in for any specialty kind of a lenses. Though toric lenses at times, if you have stability documented on topography and you have cross-linked the cornea and there is, then you could go in for toric lenses and that can take care of this. But the main thing is that when the astigmatism has spilled over to the posterior surface of the cornea, neither a spectacle nor a toric IOL will give you that quality of vision as you would if you replace the front refracting surface of the cornea by a rigid lens. So that is what my thought would be as regards the IOL.
I think what Mahipal said is very true. We should counsel the patient. Now, I request all the who are listening to this, that they should counsel properly the patient. And whenever you are going for toric lens, and when there is such type of astigmatism, again, you will have to tell them that you will have to go to the contact lens. Secondly, when you will do cross-linking Mahipal, up to what is the duration of stabilization of the astigmatism?
Sir, basically 3 to 6 months is what is required. I looked at 3 months and then the repeat of pentacam at 6 weeks interval to see that it is stable. So it is always better to first advise them on a cross-linking. So similarly, also post RK cases, whatever, there hasn't been much concentration on an IOL power formula. So I don't go in for trifocal lenses for these particular cases, as also because there's a progressive hyperopia in these cases that you get in RK. So these are certain corneal conditions that are really troublesome for the surgeon, but at least 6 months post cross-linking is the time that I'll wish to see the stability and be sure about it.
Thank you, Mahipal. Because see, whenever we do cross-linking also, we should not operate in hurry. We should wait for 6 months and then we can go and operate the case. But whenever you are operating, then we must tell them that you may require to use the contact lenses. So, Rushad, you want to say anything?
Yes, sir. So we'll just go ahead with the management of this. So basically, what happened was, yeah, 1 second.
Mahipal sir, just to add here, can you hear me?
Yeah.
Yeah, sir, you cross-link every patient, like even if the patient is 45, 50 years of age with minimal ectasia, and still you prefer to cross-link before going ahead with the cataract surgery?
No, I am talking about progressive. We are talking about a peripheral degeneration, right? A PMCD in this particular case, which is likely to progress. It's surely Rushad would be able to say that it is something of recent origin and that's been happening for some time. A patient who is old, a patient who has mild ectasia, keratoconus that is there and is non-progressive, then under those circumstances, I will not wish to cross-link. The point is stability. That's what I'm trying to say. If there is a progression and there is this thing, then one doesn't need, because as a person ages, the cornea tends to toughen on its own. So those are things that we have to take into account.
Dr. Sumit, this is PMCD is generally more progressive than keratoconus. Keratoconus most of the time stops, but PMCD even in older patients may tend to progress. So that I think Dr. Mahipal's point is well taken, that we need to see stabilization in them. So in this case, a 15 diopter IOL was put, following which there was a refractive error of +13 and an IOL exchange was done a week later, and the patient was better with a -2. The next question I would put is, so above 55, would you look at standard case for the calculation? Because there are papers talking about this, whether keratometry greater than 55, it makes sense to look at standard case. But even with that, most studies show a ±6 diopter variation. So would you go by that, or would you go by the Kane formula? And how would you judge your decision in these kind of cases?
Dr. Mahipal?
So Rushad, you may do anything. There are going to be surprises. That's what I told you. See, all these guys, everyone comes out with their own formulas, but the cornea is so unpredictable in these cases. And the IUL power calculation, the analysis, they've all worked on a very small set of patients to get to a regression formula. And obviously, the each cornea is so very different that it's very difficult to get to a regression formula. So that is the problem that you have, whether you go on a standard, like I have seen, say, again, I'll come back to post-RK. Post-RK, you can do the total K, the true net, etc. All those things. And if I apply a rule of thumb, whatever I'm getting, I add +3 between +2 to +4, depending on the number of incisions, I come nearer to that formula. So those are a couple of things, whether you do the standard K, or you do the TrueNet, or you do the Kane formula, whatever you may do, you are going to end up with surprises. So that's why I said IOL power, the kind of emphasis that you are laying on the IOL power at times is immaterial, because you have to give a contact lens rehabilitation to these patients.
I think Professor Lahane, sir, and your point is very valid, sir, that we have to counsel these patients beforehand, because they have to understand that probably they will require a contact lens post-surgery.
Thank you. Thank you, Rushad. Thank you very much. I think thank you. Thank you very much for both.
Sir, one stupid question can I ask?
Yes, you can ask any question.
Can't anything be done for the cornea? Since everybody is saying PUK but a progressive disorder, can't anything be done for that? Or?
So you can cross-link, but very often it doesn't work very well in PMD, in marginal degeneration. But cross-linking is not as successful as in the second thing is, obviously, I mean, you wouldn't go in with a transplant or even with a patch graft for this kind of thing. Normally, that won't change the outcome very much.
Okay. Thanks, Rushad.
I think Dr. Lahane.
Yeah, so we will go ahead with the session, sir.
Yeah.
And now I think we can go ahead with the retina cases with Apurva being here. Apurva, are you there?
Yeah.
Yes, Apurva, go ahead.
I'll go and share my screen. Go ahead and share my screen. Yeah. Yeah, my slide, is it visible now?
Yes, Apura, your slide is
Yeah.
visible. You can go ahead.
I'll be presenting a case of recalcitrant myopic CNV. This was a 28-year-old gentleman who'd gone ICL implantation at our center 2 months prior, and he came to us with a complaint of distortion of vision in his left eye for the past 10 days. On examination, anterior segment was normal. His BCVA was 6/6 in his right eye and 6/9 in his left eye. This was also his uncorrected visual acuity. So when we examined the fundus, we could see a CNVM complex just inferior nasal to the fovea with surrounding hemorrhage. And we advised him anti-VEGF injection for that. However, he went for second opinion, and after second, third opinion, yeah, so this is the OCT of the CNVM complex, just inferior nasal to the fovea. So he went for a second opinion. He came to us 2 months later for injection. And by then, the CNVM complex has increased in size, and you can see the surrounding subretinal hemorrhage. So we went ahead with 2 injections, and after that, as you can see, the hemorrhage has resolved, and although there is a scar which is left behind. And so we waited for another month, and then he was lost to follow up for 3 months, didn't follow up for 3 months. When he came to us after 3 months, his CNVM complex has again reactivated, increased in size, and another hemorrhage at the edge of the lesion. So again, we gave him 2 ranibizumab monthly injections, after which again his CNVM complex has stabilized, although it has left a bigger scar behind, and his hemorrhage has resolved. So he received another injection after 2 months just to make sure that it doesn't come back. However, then he missed 1 or 2 follow-up visits, and then he came to us again in July after the last injection being in April with a drop in vision. As you can see, again, there's a hemorrhage at the margin of the lesion. His vision has dropped. CNV complex has reactivated again. And we again gave him two anti-VEGF monthly injections. The CNVM has resolved, but it has left a scar behind again. And again, he had a recurrence and rebleed after a few months, which again stabilized after another injection. And then another recurrence in Jan 2020 with hemorrhage, as you can see at the margin. And we went ahead with another injection, after which it stabilized. Lost to follow up in the first COVID lockdown. Again, the CNV reactivated. We gave him 2 injections. His vision stabilized to about 6/18. Again, in the second lockdown, he's had another recurrence. You can see the hemorrhage, large hemorrhage again at the margin of the old lesion. Vision has dropped to 6/60. So after that, again, we gave him 2 injections. His vision has stabilized to 6/24 at the end of it. And now I've been following him up, and I keep giving him injections every 2.5 months. So make sure it doesn't keep coming back again. So this is the summary where you can see how the CNVM complex started from a small lesion just next to the fovea, where it has progressed and scarred over time. In spite of 13-14 injections and good response to injection, the scarring has gradually worsened with every recurrence. So these are the serial OCTs where you can see it started out as a small complex, increased in time further, and then further has gone on and involved the fovea, and the vision is now about 6/18. So to further points for discussion here would be myopic CNVM. It remains a treatment conundrum where ARMD, we have fixed dosing treatment intervals and regimen. In myopia, we do not have any fixed regimen as such. Here we followed PRN dosage initially, and this, along with intermittent missed follow-up, resulted in repeated recurrences, so the patient lost vision over time in spite of good anti-VEGF response. So I would like to ask the experts here if they would have managed this case any differently, and what would be their recommended dosage schedule in myopic CNVM. Would you consider injecting in dry disease also in patients like these, so as to avoid another repeated recurrence? And also how to determine CNV activity in myopic CNVM, because often these patients do not present with fluid as an ARMD patient would present. Often you just see a CNV complex with surrounding hemorrhage. So it's difficult to determine whether this complex is active or not. So
I think yes,
yeah.
Apurva. I think your questions are good. Lalit.
Purva must
Can I
compliment.
stop?
Yeah, you can stop sharing.
Yeah, I'll stop sharing. We can come back to the second case later
Must
if we have time.
compliment for a very good follow-up for nearly 3 years of your patient, which
Thank
is
you, sir.
very important in a lot of these retinal diseases. But see, did you do an FA or OCTA in this patient?
FA was done. Initially, it showed some leakage around the CNVM complex. However, I did not repeat it in subsequent visits.
One of the very good ways of following up CNVMs in myopia is not OCT.
I do not have an OCTA, sir. Yeah.
Yeah. If not angiography, then OCTA. If not OCTA, then angiography.
Yeah.
Otherwise, you see, follow-up, as you rightly said, on diagnosing only on OCT is not a very good way in diagnosing myopic CNVM.
Yeah.
The second point is, by and large, statistically, myopic CNVMs behave very nicely in contrast to ARMD CNVMs.
Yes.
Why this patient has been, unfortunate is not because of your issue, but probably because he has been lost to follow-up every time. Because there is some disconnect between his understanding of the disease or counseling. Because even though we do not require very aggressive treatment like loading doses and every monthly injections in most of the myopic CNVMs, and they normally respond to 1 or 2 injections very well. But there are a subset of myopic patients, say maybe around 10-15%, who do require more than 2 injections also.
Yeah. So every time we
follow-up generally is on OCTA in these patients, and second point is I do scare them that they have to follow up diligently, because I don't want them to unnecessarily progress. But remember, every time you have treated, he has responded. That's the beauty of that. Every time you.
Yeah.
So
however, every time we increase the interval.
Combining interval is different, because you see, even if interval can be increased only if the patient is stable for 2 OCTs or 2 OCTAs. Interval can't be increased based on one this thing. So interval increase will be done primarily if he is stable on 2 OCTs or 2 angiographies, or vision is stable. Suppose this patient started with 6/9 as they started, and he was maintaining 6/9, no fluid, no membrane, no OCTA on 2 consecutive visits after the last injection. Then I would ask him to, because normally in myopes, I do not do treat and extend kind of regimen.
Right.
Treat and
But
extend
in this case, now I'm doing that because every time we increase the duration between injections, he tends to recur.
That's what I'm saying. That's what I'm saying.
Yes, sir.
You can't increase this thing. You have to do monthly monitoring at least, if not monthly injection.
Yes. Monthly monitoring has been advised, sir. Yes.
Yeah, that has to be done. Otherwise, very well documented.
Thank you, sir.
Thank you, Lalit, and thank you, Apurva. Apurva, you can go for the second case.
Yes, sir.
Natarajan sir is also here.
Dr. Natarajan sir, any addition to this? Dr. Natarajan?
I will call him. Apurva, you can go ahead with the second.
I'll go ahead with the second case. Yeah, so my second case is a 56-year-old lady who's presented with a gradual diminution of vision in her right eye for the past 6 months. She'd undergone cataract surgery in her left eye 5 years prior. Last visit was about 4 years back, where she was noted to have moderate to severe NPDR in both eyes, and she was advised a review in 6 months. However, she was lost to follow up subsequently. So now she came to us 5 years later. And after 5 years, her cataract has significantly increased in her right eye, and the fundus view is very hazy. We can see that in the left eye, although the vision is still 6/6, she has developed multiple areas of neovascularization with fibrous bands and extramacular TRD, nasal and inferior to the disc. In the right eye, the fundus view is very hazy. However, we can faintly see a vitreous hemorrhage, and some vitreous membranes and fibrous bands were also noted, although away from the macula on B scan. This was a fundus picture that we got in the left eye. The view is slightly hazy because of vitreous hemorrhage. How you can see the fibrous bands inferior and nasal to, inferior nasal to the disc, and some fine NVD is also there. So her blood sugars are uncontrolled. Fasting is about 160 and postprandial is about 311. HbA1c is about 9 milligram per deciliter. Yeah, so BP is about 140/90. So how will you proceed with the right eye in the above case? Since the view is hazy and you cannot do a PRP, we went ahead with PRP in the left eye. So would you refer to physician and control the blood sugar first? Would you go ahead with the cataract surgery sooner, so that you can manage the high risk PDR in her right eye, which needs relatively urgent management? Because if we leave it for a long time, she may be lost to follow up again and she may lose vision in that eye. Or would you just consider anti-VEGF injection before surgery to bide time in this case? Yeah, can we move to the discussion?
Lalit?
Thank you, Apurva. We can stop sharing.
Yeah, yeah.
So it's quite a perplexing and challenging situation. Your left eye vision is 6/6. Can you stop the share?
Yes, sir. Done. Yes, sir.
Because left eye vision is 6/6 despite having nasal TRD, and right eye you said has a vitreous hemorrhage with 3/60 kind of vision.
Yeah, that is because of cataract.
I am not a very strong proponent of injecting anti-VEGF in an unlasered retina at all, because I can't have the total view, and I have not lasered this patient before, and blood sugars are not under control. Because if you inject anti-VEGF, you have to be mentally prepared for vitrectomy also in such patients. So what my take home would be that I would have a good physician consult, get his HbA1c and other metabolic parameters under control as fast as possible, and advise him an early combined kind of surgery. Take help of my fellow colleague, what is what we do at the Center for Sight. Do a combined surgery, remove the vitreous hemorrhage, because at this point of time, although he has a proliferative component, believe me, this is one eye which is potentially salvageable to a near normal eye. So during surgery, I will do a very good endolaser PRP, remove the blood, cataract surgery done.
Vitreous hemorrhage is very minimal, sir.
Yeah.
Very minimal. Some faint fundus view is there, although we can see some tractional bands away from the disc again in the other eye.
The presence of vitreous hemorrhage in a diabetic patient with fellow eye PDR raises suspicion of a proliferative disease in this eye.
Yes, yes.
Which we can't laser because of the cataract.
Right, true.
And I would not like to inject anti-VEGF. If I inject anti-VEGF, I will do surgery within few days, because I want to ultimately depend on laser in this patient, not repeated anti-VEGF injections in this patient. And laser best is, you see, because cataract is dense enough, only cataract surgery may also fetch him very good vision. But laser, if I do, if I take off the PVD and remove that blood, whatever minimal is there, and endo PRP till the vortex vein or maybe till ora serrata, that will give me better, satisfaction rather than injecting antibiotics.
Thank you. Yes. So what we did in the patient, we did cataract surgery with Avastin, and now post-op, now I am planning to laser her after 2 weeks. Some vitreous hemorrhage is there, which is now resolving, and I'll go ahead with laser after 2 to 3 weeks. That's what I have planned so far in the patient.
So that also is a good option, primarily because you said vitreous hemorrhage is minimal.
Yes, yes, sir.
Okay. Thank you, Apurva, and thank you, Lalit. Is there Dr. Natarajan?
I called him. He is in the meeting, but
Okay, no problem. Now we can go to the
you, sir.
case.
Thanks for valuable input.
Thank you,
Thank you,
Lalit, and thank you, Apurva.
Thank you, Lahane, for igniting this feeling, because I have been attending this session at least seven times now.
Every time. Once you were not there.
Yeah, because I read his mail, I could not say no to him. And he started way back in Bombay, and then I had requested him to please do this session for me in AIUS, and he has been kind enough to do it for 2 consecutive years. Thank you so much.
Thank you for that, Lalit. And now I think we'll take a cardiac case. Santosh, I request you to just wait, because Kudesh is going. So we will take a cornea case from Sumit and then we will go for oculoplastic case.
Sure.
Thank you. Thank you. Thank you. Thank you. Thank you, sir. Sumit, cornea case.
Yes. Dr. Anu, can you share the screen, please?
Yeah, I'll share the screen. Give me a moment.
Can you hear me? Hello? Can you hear me? Hello? 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 Hello?
Yes.
Yeah, you can make a full screen.
Can you hear me?
Yeah, done.
Yeah. Can you hear me now?
So, thank you everyone for being
Welcome,
here.
Namrata. We are taking cornea case one.
Yes, yes. Good morning, sir.
Thank you, Namrata, for
Thank
allowing
you.
us a session.
Thank you, sir.
For
Thank
every
you.
help.
Thank
Go
you.
ahead.
Yeah, so I would be presenting my first case here. It's a 38-year-old female came with the complaint of redness, pain, and watering since 15 days. She gave a history of conjunctivitis, and followed by that there was a lot of photophobia, and examination was very difficult. Clinical picture was nothing but a severe filamentary keratitis, and her Sherman's was low from 7 to 6 millimeter in the right and left eye. Next slide, please. And this is a clinical picture. Now this somehow I felt that this is not related to her conjunctivitis, but then she was very much insisting on that this all happened post conjunctivitis only. Next slide, please. She was an array of drops given by the multiple ophthalmologists, from antibiotics to antifungal to tear substitute and the immunomodulators as well, but not much of a relief with all this. Next slide, please. So at this stage, when you get a severe dry eye patient, educated patient complains that everything happened only over a period of 2 to 3 weeks, what do you do when she's already been treated by multiple doctors? Increase frequency of the eye drop, put a bandage contact lens, autologous serum eye drop, or you systemically investigate such case. I put forward this to Kuresh sir and Namrata.
Thank you. Thank you, Sumit. Now I will first ask Kuresh sir and then Namrata ma'am.
The first diagnosis that comes to mind is the conjunctivitis keratitis medicamentosa, because of all the masala that has been put into the eye. So this is a typical stippling effect which you get on the cornea, staining effect on the cornea. The patient could have had a pre-existing dry eye also, but my first choice would be a conjunctivitis or a keratitis medicamentosa. And I would stop every medicine. And if I had unims, I would just use single dose lubricant drops, preferably just carboxymethyl cellulose lubrication for at least 24 to 48 hours, and then reassess the patient.
Thank you. Anu, stop your screen share so that the faculty can be seen. Now I will ask Namrata to answer. Namrata ma'am.
Sir, I think I would agree with Dr. Kuresh Maskati that we need to rule out medicamentosa, but at the same time, I would also do systemic investigations to see that it is not any other systemic condition like you have, in rheumatoid arthritis. You have this kind of a picture of elementary keratitis. And of course, I would, for this patient, to give lubricants as well as topical steroids, and lubricants would be preservative free, and acetylcysteine if it is available. It is not always available, but acetylcysteine to take care of the filaments. If the filaments are very painful, then you may have to even remove them.
Thank you, Namrata. Sumit, you want to ask any question to the panelist?
Yeah, I would add what we did in the case. Basically, we stopped everything, like Kuresh sir said, and kept patient only on the preservative-free eye drops. But there was not much of improvement. Meanwhile, we got her investigated, and we found here that her RA factor was 350, which was never been seen. And we had to refer her to the rheumatologist to start on immunomodulators with systemic steroids initially. And she did very well after starting the oral immunomodulators only on the topical tear substitute, she was not doing very well. Now her RA factor has been reduced to 25 and she is doing well with only 2 tear substitutes. Can you go to the next slide, please?
Yeah.
So, Dr. Lane, I'll just wish to add what Namrata has said. I fully agree with her that topical steroids would be something, because as immunomodulators that Sumit has said were given systemically, as also the steroids were given similarly. The topical steroids, whatever inflammation is there, because 100% such cases will have some inflammation. So loteprednisolone twice a day or maximum thrice a day will help. And acetylcysteine for filament works wonders. And you can easily get it as an injection, which comes as mucomist injection, and use that as drops, either 20% or 10%. And preservative-free lubricants, I think that's all that a person has to use for these particular cases, and the medicamentosa does settle down.
Thank you. Thank you, Mahipal. Sumit, now you can go ahead.
Yeah. So this is a 25-year-old male. Basically, he is a medicine resident working in our hospital. Complaints of blurring of vision since 6 months. History of using specs since 2 years, but could not come for a routine checkup. Clinical picture was prominent corneal nerves, ectatic cornea, seizures, reflect, everything pointing out towards ectasia. His best corrected vision was improving to 618 and 69 with the given refractive errors. Next slide, please. This is his topography, and the problem comes here is steep keratometry is 57 and the flat is 52, and the pachymetry here is 372 on the thinnest, and that the apex is 392. This is in the right eye. Next slide, please. Next slide, Anu.
This is the left eye.
Yeah. Next slide, actually.
So you presented the right eye. This is the left eye.
Left has to be presented.
Left again. The steep.
51 apex.
Am I audible?
Yeah.
Yeah. In the left eye, the pachymetry is little better. It's 398 microns. And the point here is, next slide, please.
Sumit is losing connection on and off.
Yes, he is. Go ahead. Anu, go ahead.
Next, in this case, whether you're going for contact lenses, scleral or mini scleral lenses, do you choose C3R as an option in this case, or do you directly jump in for a DALC? What's
I will start asking question from Mahipal. Then I will go to the cornea. Mahipal.
So, sir, I'm also a cornea person. So anyway, I think the thin corneas are no longer an issue at all, Sumit. So the question that you are fundamentally raising is cross-linking in a thin cornea. So there are several and more modalities that have been described. The first modality was to use hypoosmolar riboflavin, which swells up the cornea, but that is a methodology that is now not really taken, because the fibers separate out and the effect of the cross-linking can be different. The second thing that came on was the use of a soft contact lens, which Susan Jacob described, where you're putting a soft contact lens on the cornea and then doing a cross-linking from there. And in way back in 2015 or 16, we described tailored stromal expansion for thin corneas, wherein we would take a smile lenticule. So anybody can borrow smile lenticules from, there are a lot of smile machines. You're taking out a lenticule, and which you know the thickness of the lenticule that you are having. And you just put it on top of the cornea and then do a cross-linking and throw it off as soon as the cross-linking is done. So we have done this with intracorneal ring segment. We have done it with thin corneas. We have done it in pediatric cases. And the results are exceptionally good, and there is no problem, because it is the same corneal tissue that you are using just to expand the thickness of the cornea at that particular time and do that. And the next thing that has come, which we don't have much of us, is a nomogram on the Evidro machine. So basically that is that the doses have been altered for thinner corneas, and you don't need to do anything else. The only thing that you do is that the amount of dose that you are delivering to the cornea, because the cornea is thinner, is altered as per a nomogram. I think Hafizi et al. They have made this nomogram. So that is the other thing that is there. So I think the question today in today's world is not relevant. You have to cross-link young, I think lady you said resident, obviously she's not completed her family, and she's pregnancy is going to possibly precipitate a progress of the keratoconus. So there is no question of not doing a cross-linking. So there are enough and more modalities to cross-link thin corneas, and then you can go on and give a rehabilitation with contact lens or whatever you want. Thank you.
Thank you, Maipal. Kuresh?
Yeah, I entirely agree with Maipal, and he has covered the various possibilities of cross-linking well. The thing is, what does the resident want? There are two things. One is, are we looking at stabilizing the cone, and is he happy with the type of vision that he has? Because with cross-linking, I cannot guarantee improvement in the vision. I can guarantee perhaps stabilization. Or does he desire better vision at any cost? He cannot survive. He cannot do his residency with the quality of vision that he has. If that is so, then I would go for one of the surgical modalities over there to try and improve the quality of the vision. And DAL could be something that I would seriously consider. We are now having so much, I mean, we are routinely doing DALC in 618 plus patients because we're sort of quite sure that we'll get them better results. So it depends on how handicapped the patient is, because he's a resident, he needs to carry on his work or her work. So depending on that, I would decide on C3R or a surgical maneuver.
Thank you, Kuresh. Namrata?
So, sir, I would try to defer DALC for as long as possible in the right eye, because after the keratoplasty, the story starts for lifelong, and otherwise also in keratoconus they have to. I would agree with Dr. Maipal sir that in the right eye, where the corneal thickness is less than 400 microns, we would do collagen cross-linking using alternatives which are described for thin corneas, such as smile lenticule or a donor lenticule, or even a biosynthetic cornea, or do a intrastromal lenticule, make a intrastromal pocket, put a lenticule there, and then cross-link it also. Whereas in the other eye, I would definitely go in for a routine or conventional cross-linking procedure.
Thank you. Sumit?
My question to all the experts here is, what is the thinnest cornea that you have cross-linked with the hypotonic saline solution?
So, Sumit, the dictum remains very much the same as it is for all ectasias. You should not go, I think, thinner than 350 microns, because like we say in LASIK, your ectasia occurs when the residual bed thickness is less than 300 microns, and then you have a flap also there which has been created. So likewise, I think not less than 350 microns should be the dictum.
So Sumit, hypoosmolar is out. That is what I'm trying to say. Is that absolutely no issue in me getting a 100 micron lenticule, right? So basically we are doing epi off, so about 450 cutoff that we are using. So that will be about 380, 390. That is what whenever I want the cornea to be above 400, 380 to 400 with the lenticule on after the epi off. Okay, so that is this thing. Hypoosmolar is something that I'm trying to tell you. Ultimately, you can do a pachymetry at that particular time to find out what the thickness is. And if you have reached nearer to 390, 380 or 400, then you can do it. But mind you, what I'm just trying to tell you is that if the collagen fibers are like this, and if you have put hypoosmolar, they will swell. So there'll be a dilution of the dye, as also the concentration would not be the same. So the outcomes of cross-linking on hypotonic are not too great. Contact lens can be another solution, which I think is about 100 microns is the thickness of the this thing, and there could be some bulking over the steepest area, but you can do that. There's no harm in having a slight extra thickness than having a lower thickness and hurting the endothelium. So hypotonic, I would say, just get that thing out. It's not really, and don't use a dextran. See, when you're using a dextran riboflavin, that deterges the cornea and that makes it thinner still. So use one with normal saline. Okay?
Yes, sir.
Thank you. Thank you, Maipal. I think now, Sumit, we are going for the oculoplastic case, na?
Yes, so I request Dr. Puneet Jain to share the screen. Dr. Puneet Jain is a very good friend of mine and is my senior from fellowship. He did his residency from RP Center AIMS and did his fellowship under Dr. Santosh Unava sir in Center for Sight. He was also with Dr. Paul Finger in New York for a year and now he is working in New Delhi. Dr. Puneet, please share your screen.
Dr. Lahane, sorry, one question. Do you have anything on refractive? Because I need to...
No. Now you can leave. Thank you very much, Maipal. Now we have completed the refractive. Thank you very much. Thank you, Maipal. Thank you. Thank you for coming.
Oh, hi, good afternoon, everyone. Thank you for having me here. Thank you, Sumit, for that extra large introduction. So we're going to move on to oculoplasty and ocular oncology. So basically, the two cases that we're going to discuss today would predominantly be ocular oncology. So let's start with case one. Am I audible and is my screen visible?
Yes, Puneet.
Thank you, sir. All right. So the 60-year-old gentleman presented to us with redness, pain, on and off for about 6 months. He has already visited multiple eye specialists and has been on and off steroids and non-steroidal topical agents. The redness obviously seems to decrease with these topical therapies, but the pain is persistent. This is the clinical picture of the patient. Now, there is no regional lymphadenopathy on examination and was being diagnosed tentatively as a case of necrotizing scleritis. You see that there is some scleral thinning and limbal thinning as well. Looks a very scary kind of case at the outset. So a systemic and autoimmune blood workup was done for this patient prior to presentation to us, and all the tests and all the systemic associations had come out to be negative. Now, the question to the experts here is that how would you manage this case? What would you do next? So I think I will go ahead and cover some basic things. So what we did was we did a simple rose Bengal staining in the OPD, and to our surprise, we found that there was a lot of stain uptake, and as you can see that there were a lot of disc keratotic areas which were not very apparent on the initial clinical picture. So we did an ASOCT, and in the ASOCT also we see that there is an abrupt termination, abrupt transition from a normal to a hyperplastic epithelium over the cornea, which also goes in favor of an ocular surface squamous neoplasia. Now, the question to the experts here is that how do you take it from here with the presumptive diagnosis of probably OSSN? Do steroids mask the obvious presentation of such ocular surface tumors and lesions? And what could be the other masquerades of OSSN in a similar clinical scenario?
Dr. Santosh?
Yeah, Sumit, Puneet, I think it's a clear-cut masquerade of, OSSN presenting as scleritis or peripheral marginal keratitis. It actually looks like peripheral marginal keratitis with corneal stromal involvement already and scleral involvement already. So in such a situation, if rose Bengal stain is positive and if keratin is present and abnormal vascularity is present, then your diagnostic accuracy is more than 95%. In fact, all these three pointers correlate with histopathology to a very great extent. Histopathology is the gold standard. If you really want to be sure, you can do a biopsy, but otherwise clinically it is confirmatory of OSSN. Adding to clinical features, you have a good OCT as well, confirming the diagnosis. Now, since the patient already has stromal involvement and corneal stromal involvement and scleral invasion, if there is no useful vision and if a patient wants one-time straightforward treatment, then that would be extended enucleation. But if a patient wants salvage of vision and vision is salvageable, then plaque brachytherapy would be a very good option. Primary plaque brachytherapy, where you would excise the tumor in flush with the sclera without doing lamellar sclerectomy or corneal stromal excision, and then place a plaque on to cover the entire tumor. If you want, you can use a rotational plaque. And finally, repair the ocular surface. That gives eye salvage to about 80 to 90%.
Right, sir. Sir, my question here would be that if we were to take the patient for an eye salvage therapy and if we were to plan a plaque brachytherapy, let's say ruthenium plaque brachytherapy that we have available with us at your center. So would this patient be requiring, a kind of a scleral graft before we plan the plaque brachytherapy? Because the sclera seems to be very thin and might not tolerate the surface dose. Will that be the case or no?
No, if we do scleral graft or any graft tectonic procedure before plaque brachytherapy, then that is going to alter the dose. So we do the plaque brachytherapy first, and then as a primary measure, you can use a double-layered amniotic membrane, allowing the surface to kind of re-epithelize. And if that doesn't happen, if there is any reason to do something tectonic, then you can do a lamellar scleral graft. But let me tell you at the same time that if you use a scleral graft to cover the area, then your postoperative assessment is going to be extremely, extremely difficult. You'll not be able to see the lesion if it recurs.
Right.
So yeah, you have to be ready for it.
Right, sir. Thank you so much.
Thank you.
Like to question here.
You can go ahead. Ask question, please.
Sir, I want to ask you that can you clear for everyone who treats OSSN that why this is not a case for a topical immunomodulators or topical chemotherapy, despite of being more than 2 conjunctival quadrants involved?
Right. Topical therapy, either chemotherapy such as mitomycin or 5-fluorouracil or immunotherapy with interferon alpha-2b, works very well for dysplasia and carcinoma in situ. For invasive squamous cell carcinoma, it doesn't really work. It may work to a certain extent, but then it is not curative. It can only temporize the situation, and it can work like a chemo reduction or immunoreduction to reduce the size and the bulk of the tumor, but it is not curative. So you should not rely on topical therapy for this purpose.
Thank you. Santosh, thank you. Namrata is there? She left. Okay. Sumit, is there second case? Yes, go ahead.
Yes, sir.
Yeah. That's one more case.
All right. Just give me 1 second. I'm not able to run the PPT. Okay. So moving on to the second case. So this is a 10-year-old child presented to us with history of trauma 2 years back. The other eye is absolutely normal. The left eye shows a anterior and a ciliary body staphyloma with a PL negative vision, and the patient was very keen on cosmetic correction. So looks very straightforward case for an evisceration with implant and simple evisceration. So we as a standard protocol, we do get ultrasound done for these patients, and the ultrasound showed mild echogenic opacity suggestive of degenerative changes, no mass per se. And we also got a CT scan done for this patient, and that also did not show any gross mass. So we went ahead and we planned the patient for evisceration. On table, there was disproportionate vascularization in the superior quadrant, and a firm consistency mass was noted intraoperatively. Now, this kind of scenario does happen, and my question to the experts here is that what would be our first thing when we come across as such a case? Do we abandon the surgery? Do we continue with evisceration and send the these eviscerated contents and the mass and everything, excise some amount of sclera with it and send it for biopsy, or do we shift on table to enucleation and then take it from there? So over to you, sir. What would be your inputs on this?
Santosh, sir.
Yeah, Puneet, what I noticed was that in the ultrasound, of course, posterior segment seems fine, but we haven't done an immersion B scan. And in the CT scan, there is something anterior, which is, I can't figure out, it's not a very good quality CT scan, but there seems to be something in the anterior aspect of the eye. It is not very clear as in the other eye. You can share the scan if you want. So if I encounter a surprise, clinical surprise on the table, then I would not continue with evisceration. I would close the eye with reliable sutures and then go ahead with enucleation. And it doesn't really matter to the patient whether you do enucleation or evisceration. Both are destructive surgeries. And finally, you can give a good cosmesis. That would have redeemed the situation if it were to be a malignant tumor. It does look like medullary epithelioma of the ciliary body, anteriorly located tumor with the posterior segment itself perhaps being normal on B scan. And medulloepithelioma is sometimes not dangerous because it could be a benign teratoid or non-teratoid variant. Only the malignant variant would be dangerous in terms of, say, recurrence in the orbit, etc. So you have to wait for the histopathology to do the final justice to the patient. But on the table, I would definitely convert to enucleation.
Right, sir. So I'll share the screen and share the last slide of this presentation, which says exactly what you've already said, already given the biopsy diagnosis away. So we did do an enucleation. We took a consent from the parents on table. We closed the case and it came out to be a teratoid medulloepithelioma. Now, my question here would be, sir, that if on biopsy this were to come out to be a malignant medulloepithelioma, and since we had already removed the corneal button, and it's kind of like tumor spilling outside the eye. So how would we manage that in that case?
Yeah, if you have not done peritomy, if you have just done the corneal removal, then there is no question of orbital spread at all, right? If you've done peritomy, then of course there will be seeding in the orbit. And medulloepithelioma malignant variant, depending on the cellularity, if it's predominantly round cell variant, then chemotherapy works very well. Suppose it is not a round cell variant, because teratoid medulloepithelioma can have any component, some of which may not be chemo sensitive. In that case, the best option would be to give adjuvant radiation.
Right, sir. So, sir, the usual technique of evisceration, we do a very limited anterior peritomy before we take off the corneal button. Even in that case, we would be requiring a subsequent treatment.
Yeah, but once you're done peritomy, then you can't rule out that the tumor has been spread.
Right. Thank you.
Sumit, is there any other case of oculoplasty, or we are going to other cases now?
No, sir. I had 2 cases only, sir.
Okay. Thank you very much.
Thank you so much, sir.
Thank you, sir.
Thank you. So now I will go to the Anu.
Dr. Anu. Dr. Anu is very good friend. She has done her glaucoma and pediatric fellowship from GNEC, and presently she is working there as a consultant. Dr. Anu, over to you for the glaucoma case.
Welcome, Manish.
Yes, sir. I am still on the other webinar also. So
we are taking glaucoma case.
I am going to see this. I will excuse myself for some time there.
Go ahead, Anu, go ahead.
So I'll be talking about simple cases which need to be known by the practicing ophthalmologists and not just glaucoma specialists. So we had a 7-year-old girl who presented to the OPD with intense itching and redness for the last 2 years. And it was associated with watering and photophobia and mucoid discharge with seasonal variation. And she also had diminution of vision associated with glare. She was on fluorometholone eye drops, Oculest eye drops, and Occupol D eye ointment in both the eyes for multiple visits. And she's been using the same drugs for over a year now. There's no history of any contact lens or use of any trauma, and no such history in the family. On examination, on averting the lids, the palpable papillae was seen, and she also had a posterior subcapsular cataract. She had vision of 6/60, best corrected, with the posterior subcapsular cataract in both the eyes, and the fundus view was slightly hazy, but the cupping seems to be 0.7 in both the eyes. The pressures were high with 35 millimeters of mercury in the right eye and 37 millimeters of mercury in the left eye, with the corneal thickness of 590 microns in the right and 595 microns in the left. So we made a diagnosis of steroid-induced glaucoma secondary to vernal keratoconjunctivitis. Now, my question to the general ophthalmologist as well as the panelists would be, what are the precipitating factors that they need to know, and which route of drug administration predisposes more to cataract versus glaucoma? What should be the minimum dose of steroids or minimum duration that a patient needs to use in order to precipitate this condition? When to expect a steroid response in such children, and when to be more cautious and go in for a low potency steroids? How to counsel these patients, especially when they use off-label drugs and buy it from chemists? What would be the plan of action for the patient and the prevention aspects? Over to you, sir.
Manish?
So generally, we have to be very cautious when we are dealing with giving steroids to anybody, even children or even adults. And as far as the glaucoma is concerned, There are two kinds of IOP responses that we know occur. The one is the acute response, which can occur even with giving steroids for a day or two in a low dose, because they are very strong steroid responders. And these are the most patients you basically have to identify and keep them labeled. You have to inform them that they have this problem. The second is the usually more common is that you see the steroid response after a period of time, usually when the steroids have continued for a very long time, a month or two, and the IOP increasing effect of the steroid differs from the type of steroid, with loteprednol being the lowest and the chloromethalon being the next. The higher IOP response maximum is with the difluprednate and then the dexamethasone and prednisolone. So these are the steroids. So if you are using prednisolone or you are using dexamethasone, or if you are using difluprednate for whatever reason, then you have to be more careful about inducing the glaucoma. So you have to monitor the patient's IOP, and that is a challenge in the younger patients because they are not very cooperative sometimes. And we also tend to overlook IOP. So if you have a patient with vernal kata and you need to give one of these three types of steroids for a longer period, try to minimize the duration. And other experts who have more experience dealing with vernal kata can add in, but my experience says that giving even for a very short duration is effective. So you just give for a week or 10 days and then switch to a steroid with a lower IOP reducing efficacy, and that is, I prefer loteprednol generally in all these cases. And try to use the other non-steroidal agents which are also very good, the F2 blockers and things like that, which work very well in controlling vernal kata. So vernal kata is a disease where you have to keep steroids at a minimum and minimum durations. The second, you asked about which route. So maximum IOP effect comes from the topical steroids. Systemic steroids can, but systemic steroids, that is oral and intravenous steroids, can give a IOP reducing effect, but that is less commonly seen and more, it can evolve after time. You don't see the acute response, which I talked about, where even a single dose or even a day's dose can raise the IOP with systemic steroids. So that is a safety factor. But any patient who is on long-term steroids for pulmonary fibrosis and other diseases, we always advise them to keep coming for a checkup to see their what is the pressure response. The third is even the skin creams which you are applying can cause rise in intraocular pressure, especially when they are used for a longer time. Now, there is a controversy about the inhaled steroids, and all my pulmonary specialist friends insist that the inhaled steroids do not have IOP response. And I beg to differ because I have had patients whom the inhaled steroids over a long period of time, these are all patients who are using them on a regular basis. And if you have had problems controlling their glaucoma for some time, even if you stop the inhaled steroids, I have seen beneficial effects. So here there's a controversy between what I say and what I feel as compared to what the experts say. So I'll keep that open for discussion by other members. But in general, all the other steroids, there's pretty much a lot of concurrence with what people feel. And once you get a steroid responsive glaucoma, such as the one you have presented, the first step would be to wean the patient off all the types of steroids and just add anti-glaucoma medications, observe the IOP response. And if you get a good response, then you are in a good shape. Very few cases, especially the ones who have abused the steroids, generally land up with the glaucoma, which doesn't get controlled even after withdrawing steroids and giving anti-glaucoma medications. And you may need to do a surgical procedure to control these patients. So you have to go step by step. And then once they need, the ones who do not get controlled or the ones who need anti-glaucoma medications, you have to treat like a glaucoma patient. So you have to keep lifelong monitoring and lifelong medications. You cannot say that now it is gone. But those who respond well to withdrawal of steroids, you have to counsel them that steroids are life-saving and eye-saving. So sometime if they develop a problem, they may still have to be used. You cannot say, oh, you can never use these drugs because steroids don't fall in that category. But if you need to use them, then they have to be very properly monitored, and the dose and the route of the steroid also has to be taken into consideration.
So such a patient who's been on steroids for 1 year, so now even if you stop the steroids, how long do you suggest that a person should wait until to see whether the steroids and on anti-glaucoma medications, whether the pressures are all right or not, when to go in for surgery.
So now you have to classify about when you withdraw the steroids, what is the pressure levels? So pressure levels, if you can get them within less than 30 range, say they are in the 20s, then you can easily wait for a month or even 2 months. But if the patient's pressure is going over 30, despite your medications, you have no scope of just waiting and watching and saying that let the steroid effect wear off, because you're going to land up with serious problems, and that patient may, the optic nerve would get compromised. Even worse, sometimes pressure is higher than 30, not in this age group, but anybody who is over 40, 45 runs a higher risk of developing a vascular occlusion. So that is also a problem. So we have to be careful about these patients. And if the patient's pressures, as I said, are remaining in the lower ranges, though outside the normal range, you would be able to observe them for, I generally prefer to see for washout period of the steroids, especially such long-term steroids, for a month. But as you said correctly, many times after stopping steroids and watching it, they still don't respond, and you need probably to do a surgical procedure in these patients.
This patient already appeared to have a 0.7 cup in both the eyes, so the damage had already set in since the past 1 year. Now, another thing I would like to know is that this patient had developed posterior subcapsular cataract also in both the eyes. So in such young patients, what would your approach be? To go in for a trabeculectomy first, or go in for a combined surgery for visual gain?
So again, as you pointed out, this patient has already got damage and the pressures are very high. And posterior subcapsular cataract can vary. You know, if it is very dense, then it is a difficult situation. It will be affecting vision a lot. But sometimes a little bit of posterior subcapsular cataract, and especially the ones induced by steroids, once you stop the steroids, they stop progressing. So if it is not interfering vision too much, I would prefer to leave the cataract alone in a young patient and do only a trabeculectomy. But if the cataract has progressed to such a level that there is a whole layer of the subcapsular and there is no way patient is going to get vision from that cataract, then I would be happy to do a surgery along with it. But generally, you have to understand that combined surgeries, trabeculectomy with cataract, survival rates of the blebs are definitely lesser than when done alone. And on the other side, if you do a cataract surgery in a well-functioning bleb, you have a chance of compromising the bleb. So it is a catch-22 situation, and you have to individualize your treatment. And sometimes you may defer your treatment. One eye, you may go in for a trabeculectomy alone, and another eye, you may be forced to do a combined surgery.
Right. Thank you so much for the feedback, sir. Shall I go in for the next case?
Yes. Before that, if Santosh is there, Santosh?
Yes, sir.
Santosh, in the spring cataract, how will you treat this type of cases? Because we get such type of say glaucoma because of steroid, and what you will advise?
Sir, I don't do that, sir. I'm not an ocular surgeon.
You are not doing it. Okay, no problem. Thank you.
Sorry to interrupt you, doctors.
Huh.
Let's take the discussion at the end as we have less time remaining.
Don't worry, don't worry. Go Anujan for next case.
All right.
Yes, Anu.
Yeah. So the next case is a child who is 1 year old and presented with history of excessive watering in the left eye since birth, and mother noticed the eye to be large in size from 3 months of age. There was history of photophobia. The child resisted occlusion in the right eye, but was following light in both the eyes. There was left increased corneal diameter. There was a central corneal haze, but no half stripe were appreciated on torchlight examination. The child did not allow for a slit lamp examination. The digital tensions were high in the left eye. Now, what differential diagnosis should an ophthalmologist consider in such a case? And should he treat on his own? Should he refer the child to a specialist? If the examination under anesthesia is done by a primary ophthalmologist at a peripheral center, what should be the sequence that she should follow? And how should he start the treatment? Any role of family or sibling screening and advice for future conception to the parents if it's a first child? This is my questions to the panel.
Manish?
So now here you have a patient who is a year old and has presented with enlarged corneal diameter and corneal haze in only one eye. So like you would start suspecting infantile juvenile glaucoma, but when it is uniocular, your differential diagnosis changes completely. And you would have to suspect that it could be a secondary glaucoma due to intraocular tumor, probably retinoblastoma, or it could be other developmental anomalies only in one eye, which are leading to this kind of a situation. So your differential diagnosis changes completely. And in such a patient, before putting the patient to anesthesia, generally I would prefer to do a B scan, which can be done without anesthesia. And that would quickly be able to rule out if there is especially any intraocular tumor. And if there is an intraocular tumor, I would not manage this patient myself, and I would generally advise to be referred to somebody else. However, if there is no intraocular tumor, then the next step would be to take the patient up for EUA, in which case, as you have asked for, what is the sequence for evaluation, and I would generally do the first thing, besides just looking at the whole thing under the microscope and looking out for HAP striae, you said could not be seen, but it may be seen under the microscope, and you look at the lens carefully. Corneal diameter measurements are very, very important, and you have to record them. Then I would like to measure the intraocular pressure, obviously, which was not, obviously could not be measured in the OPD. So measuring the intraocular pressure in the early stages of anesthesia. Then we go ahead and do a fundus examination and a gonioscopy. Gonioscopy I would keep for last, because once you put in the lens and then you can't see the fundus very well. So first see the fundus and then do a gonioscopy and do an axial length measurement also with a A scan, because that would all serve useful for our future reference. And then depending on the findings, what you get, many times you do get developmental anomalies uniocularly also, which are the cause the angle to be closed and leading to secondary raised pressure. And such patients, pediatric glaucoma, you generally need to do a surgical treatment, because medical treatment has a very limited role. And if the B scan has come out normal and no tumors are seen, I generally discuss with the patient that the same EUA only we go ahead and do the surgical procedure if it is indicated. And if it is not indicated, and then we can come out and just do a EUA. So usually I try to combine it so that the number of times the patient undergoes anesthesia is less. However, a very important point is, though the right eye looks normal, when you have given anesthesia, you're going to examine both the eyes in the same manner. So that is one point I did not say right in the beginning, which I should have, is that we do all the measurements and everything in both eyes. It's not that we don't examine the normal looking eye for everything. And even an auto-ref, if it is possible to do it in the EUA time only in the normal eye, because obviously with corneal diameter, you're not going to get those auto-ref readings. I think that is what I would say.
So do you prefer to do an intraocular pressure before the gonioscopy?
Yes, I said I would do gonioscopy towards the end, not in the beginning, because intraocular pressure has to be seen first.
Okay. And do you dilate both your eyes for all the routine EUAs?
Generally, we do dilate the patient a bit, but if you have to do gonioscopy, sometimes dilated people may cause the problem. But in the pediatric age group, it is not such a big problem. So we do dilate.
Okay. And so in the meantime, when the digital pressures are high in the OPD, what would you suggest an ophthalmologist to start for such children? Because generally they start with the adult dose of timolol, which, or, adult doses of oral diamox, acetazolamide. So what do you say?
Acetazolamide is definitely a drug which can be given to children, and the topical drugs, certain drugs are never to be given. Absolutely contraindicated is alpha-2 agonists, because brimonidine should never be given to these babies. So that is completely ruled out. Even the prostaglandin analogs are not going to be very effective in these patients, because the collagen, because prostaglandin analogs work through the collagen modification, and the collagen is of a different kind in the first year of life. So you are not probably going to get very good response to prostaglandins, which you do get in all other age groups. So in the first year of life, you are left with only two things to give. One is the beta blocker, and second is the carbonic anhydrase inhibitor. So you can give them as eye drops. Beta blockers, generally we like to give a lower dose, normally in adults and even in young children, not very young children, but more than 2 or 3 years, we are giving 0.5. But in these babies, you would like to give 0.25. And topical carbonic anhydrase inhibitors, unless they are not available in other strengths, so you have to give the standard one only. But if you are giving oral diamox, and orally if you are giving acetazolamide, definitely it is the dose is to be calculated as per the weight of the baby, and it is a very low dose which you have to give. And offhand, if you can just see, you have to really crush that tablet and just give a small pinch of it to the baby. That is what you'll have to do. You will not even half or even 1/4 is very difficult to make of the tablet. So it is very difficult to actually give the dose, and to weigh that you will have to go to a pharmacy and do it. So what I generally tell in the ICU, these patients many times are in the NICU and or in the pediatric ward, and that time you just ask them to crush the tablet and give only a pinch twice a day or thrice a day.
So what's your cutoff for using alpha-2 agonist? What age do you?
5 years.
5 years. And so any role you suggest for patient counseling for future conception in such
Yes,
babies?
that one point was there in your slide, but in amongst all the points, I missed it. So it's very important as that, all these diseases they have an inheritance, which could be from the mother or the father or whatever. So you have to take these patients and refer them to a genetic counselor. Now there is a separate profession called genetic counseling because it involves so many multiple factors, and there are qualified genetic counselors and there are labs which do the karyotyping and everything. So first step when you have this patient is that you have to prepare the chart. I don't know what it is called, where you point out, I forgotten the name.
Pedigree chart.
Yeah, pedigree chart. Yes, sorry. Pedigree chart you have to prepare, and based on that, you have to advise what genetic tests are to be done. But most of the labs are not doing single gene tests. They are doing panel genes only. And the genetic counselors are the best to advise on how to go about that.
Thank you so much, sir, for such great inputs. Thank you so much.
Thank you. Thank you, everybody. I think Manish, Santosh, then the Namrata, Mahipal, Natarajan, and then my all speakers, Anu, Puneet, Sumit. Thank you very much for joining with us. And I think the session, I think we'll have to give it to other this one. Thank you, Santosh.
Thank you, Dr. Lahane, for wonderfully taking over the session. I would also like to give a vote of thanks to all the experts who shared their visions on each talk. Last but not the least, I would also like to thank all the panelists for the presentation. And by this, I would like to conclude this session. Thank you.
Thank you. Thank you, Lahane, sir.
Thank you. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, everyone.
To begin with our next session, I would like Dr. Atiq Sheikh to please switch on his camera and unmute himself. Dr. Atiq?
Yeah, thank you very much.
Yes, Dr. Atiq, over to you.
Thank you very much. So a warm welcome to our Bullseye biometry course. Cataract surgery of late has been getting more and more refined. It's no longer a simple surgery where we are aiming to give a good vision. We are almost in the verge of making it a refractive cataract surgery, where an error of even 0.75 in today's world is not accepted. 0.5 and below is what we are looking at. A couple of weeks back, we had the honor of listening to Dr. Warren Hill, and one question thrown to Dr. Warren Hill by one of our panelists or speakers for today is Dr. Ramesh sir. He asked him, will we be having 100% result in biometry in future with his artificial intelligence oriented biometry? He said, we are not far from that. So that was a big news which came to all of us. So with that in mind, we are aiming to take this course forward. We've been doing this course for the past 4 years, and every year we are doing this course. We've been learning more and more and more and refining this course more and more. So a warm welcome to all our panelists and delegates who are watching this session. There's a slight change in schedule. To begin with, we will be having my mentor, Arulmozhi Varman sir, who will be talking on optical biometry. Sir is a medical director of Uma Eye Clinic. He's a cataract and a refractive surgeon who's performed n number of multifocal IOL implantations. He's trained thousands of national and international ophthalmologists in cataract and refractive surgery. One thing I really admire in him is he's always updated. A machine is launched in the next few days, you will be able to find that equipment in his clinic. So that is something I really admire in him. He's a pioneer cataract and refractive surgeon. Waiting to listen from Arulmozhi Varman sir. Over to you, sir. Thank you so much for being with us today.
Thank you, Atik. Let me start sharing my screen. Yeah, there it is. My talk is going to be why optical biometry. Simple. Why would you want to do optical biometry? And simple would be to have predictable outcomes. Again, I'll be a devil's advocate. Do you need an optical biometer to have absolutely predictable outcomes every time? Not really. But without an optical biometer, it's far more difficult to achieve that accuracy and needs a whole lot of experience and experienced personnel at every level to do every single calculation or measurement that is to be done. And that's where the difficulty is. With optical biometer, you can achieve high levels of accuracy. But does it score our immersion A scan by itself? Not really. A properly done immersion A scan, particularly one done by a highly experienced person, is as accurate as optical biometry. But the advantage is optical biometry, on the other hand, can be delegated and you can oversee the accuracy on the machine or by connecting it to your own computer and do it remotely and make sure that every single reading that has come is absolutely to your satisfaction. Biometry, we all think, is only the axial length. That's the least of the issues. Its biometry today means multiple measurements. It's axial length, anterior chamber depth, corneal thickness, K value, posterior K, true K, lens thickness, white to white. You need all of this information to get a decent calculation that would give you less than 0.5 plus or minus refractive outcome end of your cataract surgery. And this is the holy grail that we are all looking forward to. Some of us have reached to that and the others are in the pathway. We should actually go beyond it and go down to 0.25 within the next 5 years. So yes, optical biometry does score over A scan because one, the accuracy of AL is slightly better, not very much, but all necessary data come from one single source. That's where it scores definitely over. Today, optical biometry means swept source OCT based optical biometer for reasons that I will describe further. As I told earlier, axial length alone does not suffice. We want to have the axial length. We want to know the anterior chamber depth, corneal thickness, white to white, lens thickness, K value, not just the anterior K. You want to know the posterior K. You want to know the true K, every one of these things. So one of the swept source based optical biometer is the IOL Master 700. I have no financial interest, but I'll be talking more about it because that's the instrument that I use. There are others in the market which probably are as good. First, all the data that you want can be acquired at one go with one push of the button. That's the first important point that you can get here. That's one. Two, all this data can be transferred to the calculation software, thereby avoiding transcription errors. Often, tiny mistakes made on the transcription makes a big issue, which is missed out, and that can give you a refractive surprise. So these two issues are sorted out. All the measurements come off from one source, one single button press one. Two, it is transferred to the appropriate data or to the appropriate formula that you choose without any kind of a transcription error. Most of us think that the axial length is the most sensitive part of biometry and that's the most important one for calculating your refractive outcomes. No, K values are probably more important. Accurate K is probably definitely more important than accurate axial lengths because very small errors on K value can give rise to very large refractive surprises compared to small errors in axial length. Large errors in both, we're not talking about small errors. So K values should be absolutely brilliantly spot on. So one of the advantages of the IOL Master 700 is something known as a telecentric keratometry, which does not depend upon the distance between the lens and the patient's eye. Even if the patient's eye is not placed exactly at the perfect distance, you still get perfect values from 3 zones. Because you get rid of 3 zones, the values are far more accurate than what you would get from a standard keratometer. Again, I would emphasize a properly done manual keratometry by a very experienced person can give you as good results as a telecentric keratometry, but that needs a whole lot of work while tericentric keratometry is done easily and can be delegated. Where the manual keratometer and autokeratometer does not score is SSOCT based machines can look at the posterior K. It can give you the total K values, and it can also now do a central topography. How is central topography important? If you're planning or you notice that you have K1 and K2 that are different and you need to put on a toric lens, you really want to, at one look, know, does this person need further evaluation on a topographer to see whether this is going to be a regular astigmatism, irregular? Are you going to have good results when you put in a toric IOL, or your results going to be suboptimal? The central 3 to 5 millimeter of the topography that you get off from this machine can give you that answer to that question. Yes, you can just go ahead, do your calculations and put a toric lens in this. No, there's something different about the central topography. Please go back and do a proper topography before you proceed with this. So the central topography here gives you the advantage of avoiding another test to be done, probably unnecessarily, in most patients. This is what you get. You would get all the points and get perfect values every time. The central topography will let you know if it's a regular cornea or is it a cornea with regular astigmatism, where you can go ahead with a toric lens, or you want to do more studies before you decide on this. See, the OCT scan that comes off this machine not only lets you have a look at the accuracy, the tilt of the lens, that if it is present, if the crystalline lens is tilted, you would know about it. So you can see these pictures and be aware of the anatomic situation of the lens per se, which is quite important for calculating or understanding any refractive surprises that may occur as you come out of the surgery. Sorry, we just skipped multiples. Another advantage is the SSOCT scan allows you to see the foveal pit. And this is a permanent record. When in doubt of any values, you can go back, look at the scan, and be sure that the scan went through the foveal pit. So you get absolutely brilliant values and you don't get fooled by something wrong. So this is quite important. Though the SSOCT-based biometers are not meant to diagnose retinal diseases, you can catch subtle retinal diseases which could affect the visual outcome. So you can be forearmed or forewarned to do a more detailed examination of these patients, so you would know if something is wrong with the macula. Such issues can be seen, not as clearly as this, but not to make a diagnosis, just to tell you that something could be wrong on the fovea. Again, SSOCT-based scans can penetrate through very dense cataracts, surprisingly white mature cataracts. When they are dilated, it can penetrate through and you can get very accurate values. So this takes away one more issues with a standard optical biometer, where even minimal lens opacities earlier would interfere with the calculation of the axial length. Here you would get axial length even in these kind of cataracts. And of course, the latest formulae are loaded on, but I think that's the least of the issues, because today the best formulae are available on the net to us. So you can go on the net and get the best formula and upload it, calculate it. But again, advantage of transcription errors, all of the latest formula are available there for your use. And if you're using the IOL Master 700 and have the Callisto system, you can do the markerless system to align your toric lenses. So another advantage. So here is a short video of a surgery being done using the Callisto. In situations like we want to put in a toric lens, you want your rexis to be picture perfect. So you can get the overlay that gives you the rexis marking. So that's spot on. Finish the surgery. And if you're putting in a toric lens, you have the advantage of aligning the lens perfectly, markerless. Takes away one more. So to summarize, optical biometer is not necessarily a luxury. It's almost becoming a basic necessary tool. So those who are first who really want to score that small accuracy of achieving less than plus or minus 0.5, particularly in difficult situations and demanding patients. And if you are bent upon using the so-called advanced lenses, particularly a toric lens, or if you're using a multifocal lens or an EDOF lens, and you want your calculations to be spot on, do use an optical biometer, preferably use an SSOCT biometer, choose the appropriate formula to get the best results and enjoy the fruits of your labor. Thank you.
Thank you, sir, for your wonderful talk. I have a question, sir. Sir, of late, the anterior chamber depth and the white-to-white has been playing a vital role in calculating the effective lens position. So with regards to dilatation, how do you do? Do you do your biometry undilated or dilated? Does it play a role in changing the ACD and eventually causing a change in the IOL power also, sir?
I really don't think dilation is going to make that big a difference. We'll probably see most of the patients undilated. Those of them who have media opacities or cataract that is dense enough that undilated does not read through, I do dilate and take it again. But the standard protocol I've been following is undilated so far. But I'm not really sure that simple dilation using tropicamide and phenylephrine is going to make a big difference in the anterior chamber depth.
Okay, sir. Thank you. There is one question from Ramesh, sir, to you, sir. What do you feel is the impact of posterior polar cataracts with the IOL Master 700, sir? Are you able to get through with all cases, or do you use your ultrasound diameter on and off, sir?
No, this, believe me, the IOL Master, I've been using all the models of IOL Master since inception. There were difficulties with simple PSC, not anymore, not with SSOCT. Definitely with none of the machines that are on the market, SSOCT, all of them penetrate through. So that's a big advantage.
Actually, the question was a little different, Arul. Are you using them to find out whether the posterior capsule is patent or are they having a dehiscence in the posterior capsule?
Oh, yes, it would. I'm sorry, I did not catch that. Yes, the scan would show you that the posterior capsule is deficient or not, particularly in a posterior polar. Yes, if that is a gross deficiency, it is visible, just like you would notice a gross issue on the fovea too. So the OCT is clear enough to give you gross pictures, but not fine pictures.
So in the patients where the posterior capsule is even and smooth behind the PPC, we can confidently make sure, we can be assured we're going to have a routine surgery at the. We don't have to be counseling the patient, you have a higher risk of PCR and things like that. Okay. So it helps us to confidently go ahead with the patient. In most patients with bullseye PPCs, posterior polars.
Sir, and then what about the central topography, sir? For post-refractive eyes or eyes when you are planning toric implants, do you do a corneal topography also, or with the central topo, you go ahead with the case, sir?
Okay. Because the central topo is there, all your cataract patients are going to go on the IOL Master. If the central topo is regular, you don't have to put this patient on a topographer or a tomographer to find out more data. If your central topo is questionable, then please do a proper tomography itself. You could have a post-refractive patient, that doesn't matter. If the central topography is regular and you're fine, just go ahead. Central topography, irrespective of post-refractive or not, gives rise to some questions. Then this patient has to be looked into very carefully with a proper topography, preferably a tomography. Ramesh, what did you say?
Arul, what you're saying is absolutely true, Arul. The only thing is that most people have moved to the 2K as far as the post-LASIK eyes are concerned, where you have RK eyes where you're not very sure, and the central the central flattened zone may be very small, especially with multiple cuts. Then it is better to get the OCT-based central corneal power, because it's not measuring a 3 millimeter 2.8 millimeter or a 4 millimeter ring, it is going to give you the actual central corneal power, which is what you need for a post-RKI. So only in that situation, I feel an OCT-based or Schleimpflug-based tomographer is better. Otherwise, for regular toric IOLs, I stopped doing topography. Arul, for toric eyes, are you using doing topography, or you stopped using it?
No, I never was doing topography unless I had an issue about the axis. But now, since I have the central topography on the IOL Master 700, that gives me the confidence that the patients where the central topography is quite regular, you don't have to do anything, just go ahead. If the central topography, as you see it as it being done, is a bit irregular or doubtful, then those patients I would rather go do a proper topography.
Thank you, sir. Jayantan, you have any questions, Jayantan, or can we move to the next speaker?
No, thanks.
Thank you very much, Arul sir, for sharing your knowledge. Thank you so much, sir. So the next talk will be on ultrasound biometry. Does it have a role in today's practice? So this will be done by Dr. Pratibha Devi Nivian. Dr. Pratibha is a cataract and an oculoplasty surgeon at MNI Hospital. She's a trainer. She's trained hundreds of candidates in cataract and in laser-based surgeries. Welcome, Pratibha. Over to you.
Thank you, Atik. Are my slides visible?
Yes.
Okay. Good morning. So I'm Dr. Pratibha Devi Nivian, and I'm here to talk about ultrasound biometry. Does it have a role in today's practice? So today's cataract surgery has become more of a refractive surgery, and the refractive outcomes after cataract surgery depends on axial length, keratometry values, anterior chamber depth, and the IOL formulas. But the key factor we all know is the axial length, because even 1 millimeter difference of the axial length can cause a 2.5 difference of IOL power calculation post-op. So the methods of measurement of axial length have are the ultrasound biometry, which have been used from olden days. It was the commonly used technique. And more recently, the partial coherence laser interferometry and the swept source OCT optical biometry are gaining popularity. However, today I'm going to talk about ultrasound biometry. So ultrasound biometry works on the simple principle of sound waves. The ultrasound probe has the piezoelectric crystal, which passes the sound waves, which penetrates the ocular surface. It passes through the layers of the eyeball. And the energy, the sound energy, is reflected back as it keeps passing through the eye. And the reflected waves are perceived as spikes in the perceived by the probe, and it gives spikes and the readings of the axial length. So the measurement of axial length is from the anterior corneal surface to the internal limiting membrane. Ultrasound biometry can be measured by both contact and immersion method. The contact method was the one which started earlier days. The ultrasound probe was directly placed over the anesthetized cornea, and we get the spikes in this form. We see the interface wave, we see the anterior and posterior lens wave, and then we see the retinal spikes. But the main disadvantage of this contact, so this is the ideal scan wherein we have these and the corneal, the spike, the anterior and posterior lens spike, and then we have the retinal spike and the orbital fat spikes. The main problem when it comes to a contact ultrasound biometry is compression. So it is a lot more dependent on the technician who does the scan. So when there is corneal compression, that can alter the anterior chamber depth, and that can cause a variation in the axial length, which can reflect on the IOL power. So here's one such example wherein here this patient was done a scan without corneal compression by a gentle handling of the probe, wherein the anterior chamber is around 2.58 millimeter, and we got an IOL power of this much. But when there is a slight compression given on the cornea, the antechamber varies, and then we see a variation in the IOL power. So this corneal compression is one of the biggest drawback of the contact method of ultrasound biometry. So came into being the immersion method. So in this immersion method, there is no direct contact of the probe with the cornea. Here we have a scleral shell wherein we put a coupling fluid, a normal saline, and then place the probe on the saline. So here there is no question of compression, and this immersion technique gives more reproducible and more successful results. So the scan obtained by an immersion method is similar to our older contact method of ultrasound biometry, except that it has a coupling fluid spike as well. So the limitations are, it is little time consuming. It can be little messy as we use little solution, and the procedure can only be done in a supine position, and the shell has to be cleaned properly after using for a patient. The ideal recommendations are it to be cleaned with alcohol or hydrogen peroxide at least for 5 minutes, and then it has to be washed with silent salt solution. So what are the potential sources of error that can occur? If we have not calibrated the machine, as all machines, we can end up with error. So we should calibrate the machine appropriately. The positioning of the patient should be accurate. Even a small tilt like this in the head can cause a abnormal reading, because the sound waves go obliquely and partial waves only get observed, and the remaining spikes are reflected away from the probe. So we might get a wrong reading. So ideally, the position should be straight. The patient's head should be in a straight supine position. And the patient should look at the fixation target. Lying supine position, the patient has to keep looking in a target. If the patient's eyes are very dry, we can use CMC, carboxymethyl cellulose, on the probe. We can wet the probe. And coming on to the scans, when we see steps and ridges like this, we saw that the ideal scan has a corneal spike, anterior and posterior lens spike. This is the coupling fluid spike, anterior and posterior lens spike. And then if we see steps and ridges like this in between in the vitreous, that means there are a lot of artifacts. Either we should reduce the gain, or these type of scans should not be encouraged. And if we see correspondingly, the standard deviation is also high in such scans. So we should repeat the scans if we find such scans. And this is a scan which is passed through the optic disc. We find that there are no orbital spikes, and such scans also should not be encouraged. This was repeated again. So coming on to the gain settings, usually in an ultrasound biometer, we keep a gain setting of around 90. But in a very dense cataract, we might have to increase the gain, as the height of echoes might not be, the sound waves might find difficult to pierce the dense cataract. So we have to increase the gain in denser cataracts and decrease the gain when we see a lot of artifacts in the retinal, in the vitreous cavity. And we have to select the appropriate eye type, particularly when we deal with a phakic eye or a silicone oil filled eye. We have to change the mode in the machine. So in case of silicone oil filled eye, it is very important, because if proper sound velocity is not used, then we might get an erroneously long axial length measurement. And the velocity is even different for the 1000 and 5000 centistroke silicone oil. So that has to be seen and has to be changed. So this is a small video of how we do an immersion ultrasound biometry. So first we enter the patient details here, and then we enter the topography reading from the corneal topography which we have measured. Then we explain the details to the patient, and we make him lie in the supine position. We anesthetize the cornea, and by gently retracting the lids, the Prager shell is placed over the eyeball, and the saline is injected, and the scan mode is pressed, and the scans take place. And once the accurate scan happens, the machine detects, and it has an autosave mode, and it stops the scan, and we get the readings, average readings. And here we have the formulas which are incorporated in the ultrasound immersion biometry machine. Earlier days, not many formulas were incorporated. Today's machine is incorporated with all these latest formulas as well. So when after detecting the axial length, we have to choose the right formula for our patient. If it is a long eye or a short eye, we have to choose accordingly. And then the IOL power calculation can be done. So the advantages of ultrasound biometry over an optical biometry is definitely over in very dense mature cataracts, very dense posterior subcapsular cataracts in high myopia when the patient has no proper fixation, and it is very, very cost effective. However, there are definitely few drawbacks. The main drawbacks are in particularly cases with posterior staphyloma and when the patient has macular problems. And these will be dealt with by Jayantan sir later. So I have few case scenarios wherein we have used immersion biometry. So this is a patient who had a short eye and with an axial length of around 20.7. So whenever we see a scan like this, we have to see whether the scans are ideal. As I already told you, we have to see for the coupling fluid spike, the anterior posterior lens spike, and the retinal spike. So this is the ideal scan. Now we have to look in for the standard deviation. So whenever the standard deviation is less than 0.03, it is an acceptable and an ideal scan. So this reading can be taken into account. So these are the things, smaller things which we have to take into account. And then the formula has to be incorporated into the thing. We have to change it into a Haigis because Haigis or a Hoffer Q is ideal for a short eye. So these things has to be trained to the technician, or we should know it when we do an immersion biomicroscope. When we are dealing with long eyes, see, but this was a case of axial length 25.32, but the scans were not ideal. So we have to repeat the scan and then see for the standard deviation and then take into account for IOL power calculation. And this is a very ideal purpose of our immersion ultrasound, where in dense cataracts, immersion ultrasound gives more accurate reading than the first and second generation optical biometers as well. Even they depend on an immersion ultrasound when there is a very dense cataract. This was taken from a KJO written by Arup sir, Arup Chakraborty et al. And they have compared the advantages of ultrasound and optical biometry. Yes, the ultrasound biometry measures the axial length from the anterior corneal surface to the internal limiting membrane. It doesn't take into account of the retinal thickness. An arbitrary of 200 microns is added to the retinal thickness. But optical biometry measures the exact axial length from the anterior corneal surface to the macula, to the center of the macula. It measures along the visual axis, and the parameters has to be changed according to the media. The velocity of the sound has to be changed in cases of immersion, in case of ultrasound, but in optical, that thing is not needed. And optical is not messy. Optical is quite easy to do, but ultrasound biometry is technician dependent. A lot of training is needed for the technician. But even with that, our simple experience with an ultrasound biometry is it can be done. We can get through 97% of patients with the ultrasound biometry, except for very long or short eyes, where we have to do with little caution or take into account of certain important things which we have dealt with, and ensure the technician is very well trained in that aspect. The third generation optical biometers are definitely much better, except for the cost, which is way far ahead than our ultrasound biometer. And we did a small survey for our Madras City ophthalmic members, and we found that still 77% are using ultrasound biometry. And to conclude, applanation ultrasound is common in developing countries due to the familiarity of the technique and its low cost. And our survey clearly says the technique is still not obsolete. Thank you for the patience.
Thank you, Pratibha. So what I get to learn from your presentation is still about 3/4 of the population is with ultrasound biometry. If you know which case to avoid, you will be on target most of the time. So that is what I get to learn from what you're saying. So one doubt I have, an open question to all the panelists. At times we get silicone eyes filled eyes for cataract surgery, and the consistency or the thickness or the viscosity of the silicone oil most of the time is not known by the cataract surgeon. In case the surgery is not done in our center, we don't know what type of silicone oil they have used. In such cases, how do we go about?
According to literature, it is the velocity is different for the 2 centistroke silicone oil. But when we are not sure about that, I think we can use
myopic shift and
maybe the
Denton, Ramesh sir, any experience with this? I had a personal experience and I was kind of clueless, didn't know what to do. What silicone oil was pushed in by the VR surgeon who's operated prior.
So please do share with us about how you managed, Atik.
Yet to operate, sir. Patient is waiting.
I think there are only 2 or 3 people who make it. So if you know who the previous operating surgeon was, you could call up and ask him whether he's using the Alcon, the abortion arm, or whether he's using one from one of the Indian suppliers. There are very few people who are making particular oil.
And one more thing is, usually the retina people use the 2000 centistroke silicone oil unless they feel that it has to be there in the eye for a longer period, particularly HIV, or that is my learning. I mean, it has to be there in the longer for a longer duration. Then they prefer 5000. Otherwise, mostly they use 2000 centistroke.
Ramesh sir, you had a question, sir.
Yeah, do you make any changes in your final power when you have a patient with a very thick hydrated white cataract? I ask this question because these patients, most of my patients are getting a low degree of myopia. So I generally go for a plus 0.5. If I want to have a plano target, I generally choose a power which is slightly less. If I choose, as per the calculation, I tend to get a more myopic post-op result. So I just want to know whether you are also seeing the same kind of results.
No, sir.
Your feedback on this?
No, sir. I didn't get. I mean, at least I'm not getting anything like this. I'm not sure why this is happening. Also, Jaintan.
Because of the ELP calculation. Because than a normal lens, definitely the hydrated lens is going to have a different ACD. So that's what changes. The ideal would be to have 2-3 formulae. It's always better to calculate the 3 formulae. If all the 3 formulae gives the same value, like a formula which is independent of ELP calculation, or if it is using multiple parameters for ELP, so you can go with that. And in case if it is completely different, you can actually err on a side where we can aim for a slight hyperopias side.
I thought it is probably because when you have a very large lens with a hydrated cataract, the speed of sound is slightly more through the cataract than through the vitreous. So it falsely gives you an eye which is slightly it goes faster. So
sir, can you repeat, sir? I didn't get what you were trying to tell, sir.
Yeah. So I personally felt now when you have a large lens thickness, the speed of sound through the cataract is faster. Because the optical density, because the density is more, so it gives you a false short eye, and so we tend to give we put a stronger lens into the eye. So most of us don't separately calculate for the lens. We just have one particular formula for the entire lens. So I felt that swollen lenses are likely to give a shorter eye than the true axial lens. But I've been seeing this for 15 years or so. I always aim for a plus 0.5.
With the ultrasound and the optical, you are getting the same error, sir?
No, I think not with the optical. Only when I use the ultrasound.
Okay, sir.
Optical is not a problem.
Okay, sir. Thank you, sir. So thank you, Pratibha, for a wonderful talk. The next talk will be on keratometry, then and now. So that will be me. So keratometry has been evolving over time, and it has been changing every time we do this course. Last year we do, the content is slightly different. This year we do, the content is slightly different. And as Arul sir rightly said, the role of keratometry in biometry is becoming more and more significant. And this was a fact which I was surprised to see. I was under the impression that presbyopia correcting lenses are used more and more with time. Then later I came to realize that the usage of toric implants is actually increasing by our surgeons. Keratometry all started with this great man, von Helmholtz, who devised the ophthalmometer. But however, this equipment was not practically usable. The practical usable equipment came or was invented by Dr. Jawal and Shiotz, where they measured the anterior surface, and based on certain assumptions on the posterior surface of the cornea, they got the keratometry values. This works on the principle of doubling. Because the eyes have micro movements, they used this principle to negate micro movements and calculated keratometry values. This keratometer, however, even now it plays a vital role in many practitioners. There is a small disc which is available in our manual keratometer, which allows us to ensure and see whether the keratometer is working fine. That needs to be done on and off. Most important thing with regards to keratometry, be it manual keratometer or a topographer-based keratometry, it has to be done on a virgin eye. Preferably, even before an NCT is done, it is better to take the K values and then proceed. This was a case of some amount of dry eye. As the patient keeps staring, you can see that the Myers are getting distorted and we will get wrong values. So the take home here is keratometry should be done on a well-hydrated cornea. In patients with dry eye or with ocular surface disturbance, the ocular surface has to be treated for about 2 to 3 weeks, and then we should do the keratometry so that we don't end up in erroneous values. Speculum is a strict no for manual keratometry. You should encourage the patient to keep blinking so that the tear film is proper and we get good values. However, the manual K has certain limitations. It calculates only the central cornea or the central 3 mm. The peripheral and the paracentral cornea gets ignored. And another major drawback is it is meant to align the cornea only 90 degrees apart. So subtle irregular astigmatism can be missed with manual keratometry. Till about 7 to 8 years back, this equipment was believed to be terrific until this great man, Douglas Koch, opened a whole new phenomenon and started talking about posterior corneal astigmatism. He found out that all the equipments available in 2013 either overestimated or underestimated keratometry values. This made us to actually understand the fallacies seen in keratometers. But then, again, when I was preparing for this talk, I was actually surprised to know that the Pandora's box was not actually opened 7 or 8 years back. It was done way back in 1890. Dr. Jawal that time had spoken that the posterior cornea contributes to some amount of changes in astigmatism, or in other words, it plays a significant role in corneal measurements, in the total corneal power. However, this data was ignored and we kept concentrating more and more only on the anterior cornea till Dr. Koch and Koch et al. Came up with this study where they found out that with the rule astigmatism was in general overestimated and against the rule was underestimated, for which Dr. Baylor came out with the nomogram where we could use it for toric implants. And then there were lots and lots of other myths which were there. One common myth which existed was when there is a steepening of the cornea, if you incise, there will be flattening. This was made to be a total myth by Dr. Warren Hill a few years back, where he said that SIA is not only from the cornea, it is also from the lens. The lens also plays a major role in SIA, or in other words, the ELP. So when an incision is made, it is not necessary that flattening has to happen on that axis. Flattening, yes, can happen, but it can happen on axis as well as off axis. If you are not sure of your SIA and if you have done a good incision, it is better to use a vector value of 0.12 is what Dr. Warren Hill says if you make a proper good incision. This was again emphasized by the great man himself, Dr. Barrett, who's again changed the way we think of keratometry in today's world, in biometry in today's world. You can see here he's used an SAA of 0.13 and there's not much of accuracy. When the SAA is changed to 0.12, the readings get far more accurate and the number of patients in the 0.5 error is much higher. Today, we are talking of true K and predicted K. Arul sir already gave a good explanation of how the true K works. I would like to talk a little bit on predicted K. So what is this predicted K? We can go to the Barrett toric calculator available for free in the ACRS website. Go to this K calculator, click on it. It'll give us options to enter K from three different equipments. Say, for example, our manual K or our optical biometer and our pentacam or our tomographers. If we enter three different values, there are some internal calculations done and then we get the median of the three values. Again, I repeat, median and not mean, so that skewing does not happen. This predicted PCA, as on date, till about a couple of years back, was believed to have terrific value and terrific results. The number of patients with 0.5 error, we are not talking about toric implants, we are talking about regular spherical errors of 0.5 with the predicted PCA is far more accurate than the true K that is actually measured with the with the swept source based OCT biometers. Well, why is this happening? I'll explain in the next few slides. However, the true K or the actual estimation is far more accurate in cases with post-refractive surgery eyes. So this true K with the IOL Master 700 is measured using swept source based biometry. The anterior surface, however, even now is calculated only using reflectivity. So using reflectivity from three zones, they calculate the anterior surface of the cornea. And then in those points, swept source based readings are taken or the corneal thickness is calculated. And then some amount of extrapolation happens and a toric surface is created. So here also there is some amount of assumption. However, the assumption is less, but some amount of assumption and internal calculation is done to actually estimate the posterior surface of the cornea. There is less extrapolation, but yes, some amount of extrapolation happens. That is the reason why the mathematical method even now is scoring over the Barrett, is scoring over the actual true K values. This is because the internal calculation which are done by Dr. Barrett, we are not actually aware of how he actually gets the values, is a little more accurate than the actual measurement. Maybe in future, when we have better scanning protocols with lesser extrapolation, we will be able to get better true K values. As I said earlier, true K, however, is more important for post-refractive surgery eyes and it gives much better results. So what is new to us? Again, this information was shared to us by Dr. Warren Hill during his Madras Icon talk in 2021, which is yet to be published. He said using the Hill RBF 3.0, with the true K, he's able to be on target in 95% of eyes. However, this data is yet to be published. This is courtesy of his talk, which he delivered a mind-boggling lecture to us on the Hill RBF anterior in artificial intelligence formula. And the new kid in the block, which is the Anterion, which is another swept source based biometer. One advantage of this, theoretically speaking, is this biometer does not play on reflectivity for measuring the anterior surface. Even the anterior surface is measured using swept source based biometry. The posterior surface is also measured using swept source based biometry. And another advantage with this equipment is this gives K values at 2, 4, 6, and as well as 8 mm, and also a topographic image of up to 8 mm of the cornea. So we get to have the anterior and the posterior elevation best fit sphere, and also the tangential pachymetry map, as well as the corneal wavefront map. So this, theoretically speaking, has an edge over the IOL Master 700. Because we are using swept source based images from the anterior surface also, the role of tear film can be negated. However, as on date, we need to have more data to actually understand if tear film is actually negated with these sort of biometers, which do not rely on reflectivity. They rely only on swept source based images. However, I went through this article published in JSCRS 2021, which says that there is statistically significant difference in keratometry values between the two devices. There is statistically significant difference in the anterior chamber depth measurement between the two devices. However, with all these changes, there is not much of difference with the IOL power that is calculated. So why all these changes in measurements are happening? That is because different keratometers take values from different areas of the cornea. The IOL Master 700 takes at 3 mm. The Anterion takes at 3.5 mm. This 0.5 itself can cause a change in values. There is good agreement between the devices. The only problem is we cannot use them interchangeably. In other words, we cannot take data from the Anterion, enter it into the IOL Master 700 and try to get good values. That equipment value is meant for that only, because the working principle tends to change. However, the main reason or the main take home from that study, what I learned was the measured mean difference in axial length was only 0.01. And this led to a refraction error of just 0.03. In today's world, we do not have a lens for 27.1 and a lens for 27.2. We are still with a difference of 0.5. So these subtle differences actually do not play a role. Maybe we will need more data, more trials to understand these biometers better. Future of K, we are talking of neural adaptation, non-keratometric astigmatism, which cannot be measured. This was again a study from JCRS 2021, where they say that a person who's used to accepting a particular astigmatism at a particular axis will continue to accept it even after cataract surgery or whatever you do. That is because the brain is tuned to that astigmatism. This again, we will need more data. Maybe in future, we may be looking at it. Just like biometry, here also AI may be playing a role where we'll have to get data from 3-4 equipments, enter it into a software, and that will give us values. Like the HALL RBF, some AI software may come to get us proper K values. So the only thing is, change keeps happening. We need to keep adapting to change. To sum up, manual K even now has a role. We need to use it with caution. SIA, use 0.12. Incising needn't cause flattening at the axis of incision. Standard K with the predicted Barrett's PCA still holds good for virgin eyes. However, the true K stands out in post-refractive surgery eyes. Thank you so much.
I think just a comment, I think.
Yes.
The Kane toric formula takes a default value of 0 for your SIA.
0, sir?
It accepts a default value of 0. It doesn't force you to enter some other value. They find they get very good results if you enter 0. The 0.1 doesn't make a difference.
Personal experience with that, sir?
Nowadays I see a printout with both Barrett toric as well as a Kane. Most eyes is almost the same. There's a difference of 2 or 3 degrees. 4-degree difference is very rare.
Okay, okay, sir.
I've been entering 0 for several years, I think.
Maybe we are not that gifted surgeons, sir.
No, I think you'll find that very few of your patients are overcorrected. By entering 0 and a 0.1 or a 0.12, you don't gain anything much. The mistake is to enter a 0.3 or a 0.5.
Okay, okay, sir. So can we move to the next talk, sir? So the next talk will be on recent formulae and upcoming formulae by Ramesh Thorirajan, sir. Sir is a director of Sundar Eye Hospital. He is very keen and his talks on biometry are well appreciated. In fact, a couple of days back when I was preparing for my talk, I was trying to YouTube certain videos, and one video which came up and it had more than 12,000 views was Ramesh Thorirajan, sir. sir's video and I shared it to him. It was around night 12 o'clock. His talks on biometry are always well appreciated. And sir is one person, as I said, who's fully updated. Any trial comes, before most of us know, sir will be able to guide us on those things also. Thank you so much, sir, for joining us and sharing your knowledge. Over to you, sir.
Atik, can you see the screen?
Yes, sir.
Okay. So a few years ago, in 2007, you had this 60 odd different formula if you want to calculate the power of the lens in a patient who had a LASIK or a PRK done. But today, when we talk about biometric formulas, we are only concentrating on these few formulae. The most important thing to remember about them is that the first three of them are only of use if you have a normal anterior segment. Currently, in 2017, the EVO formula was first discussed in the Portugal ESCRS, and in 2019, we all became aware of the Kane formula. This is a modification of the previous slide, which is from Dr. Warren Hill's site. Now, but for both the EVO and the Kane formula, we don't have sufficient data as to know how good they are with the extreme short eyes, and we are not sure about whether they are applicable only to Caucasian eyes or all types of eyes. As of 2018, if you're using any one of these formula, you'll be doing what is best in the world. In the Royal College of Ophthalmology 2018 guideline, they said, when you have a short eye, you can use either a Haigis optimized or a Hopper-Q. Between 22 and 26 millimeters of axial length, you can use Barrett's or a SRKT. And if you're having more than 26, you can use an SRKT or a Haigis. So if you're using an axial length-based formula, like most people with an ultrasound are using, you can expect to have 80% of your patients within 0.5 diopters. And if you choose to convert to OCT-based biometry, you will get about 92% within 0.5. This is what is currently possible today. In the year 1988, about 30 years ago, SRK2 was first published in JCRS, and 2 years later, we had SRKT. Today, most of us are using both SRK2 as well as SRKT, 30-year-old formula. Although we have stopped doing ICCE, we have stopped doing ECCE, we have stopped putting 7 sutures and 5 sutures, we have started doing foldable lenses, but we are still using the older formula. Why should we not use the older formula? Because we have different eyes. There are actually 9 kinds of eyes, as explained by Dr. Gills as well as Dr. Jack Holliday. The majority of us have normal or average axial length and anterior segment, and any formula will work in these eyes. But many of us also tend to see patients with smaller corneas, larger corneas, axial myopia, shorter eyes. So in these kind of eyes, a standard 2-variable formula like SRKT or SRK2 is not sufficient. So when you have a normal anterior segment, you can use any formula. But when you have an anterior segment that is not normal, you have to choose between a Haigis, Holliday, Olsen, Barrett's 2, Hill RBF, EVO, or a Kane formula. You have to move to the current generation formulae. We should not be using SRKT and SRK2 for all your patients. Doing this will be a disservice. I'm sorry. So in a 2008 JCRS, we had this wonderful presentation article by Savak and Nosby, who said a third of the error is from position of the lens. That is, formula errors contribute only to 1/3 of the post-op refraction errors. And another third is a result of errors in refraction that we do in our clinic. And a third is errors due to measurements of K as well as the axial length. 2 years ago, Bulk and Haigis said that axial length measurements have reached a very high level of accuracy, and we can now measure the changes in axial length with the pulsation of the heart as the choroid gets vascularized and devascularized. The pulsations can cause changes. We can measure changes in axial length between the morning and the evening. We have diurnal variation in axial length. These minute measurements can now be measured with the current generation of machines. And axial length measurements are no longer going to be the factor of limit, but K reading is still a factor. So the improvements as far as measurement technology will be from measuring better quality K. And also we can do with improvement in the formula. Till recently, there is no perfect formula, but as of 2 years ago, most of us converted to Barrett's suite of formulas. We should realize that Barrett's suite is available free in both APS-CRS as well as AS-CRS. The version we have in our biometry is an older version and it should not be used. These get changed every 3 months or every 6 months. So a 1-year-old version or a 2-year-old version, what I got with my old IVL master, should not be used today. This article by Mellis, Jack Holliday, and co-authors 3 years ago confirmed this feeling in most of us that Barrett's is the best. So this particular article, which was published in AFO in 2017, said overall, Barrett's Universal 2 was the best formula as far as postoperative refraction was concerned. This is one particular diagram which comes from there. It shows on the bottom different intraocular lens powers, right from 6, 9, 10, 11, 12, and up to 29. These are the different powers. And here is a mean prediction error. Now, if you see the mean prediction error, this is a zero error. And if you see a plus or a minus 0.25 variation, you will find that all these various formula will give you a mean prediction error within 0.25 for the normal intraocular lens that we use between powers of somewhere about 16 and 23. So between the commonly used powers, any of the formulas are pretty good. But when we tend to use abnormal, very long eyes, when we have very low powered IOLs, or when we have a short eye with a very high powered IOL, we'll find that there's a very big variation between the different formula. So this is one thing we had to realize. When you see the K and when we see the axial length, if it's not normal, we should not use SRK2 or SRKT. One interesting thing is the Barrett's, though we call it a Barrett's formula, it's a suite of formula, and it contains the basic Barrett's Universal 2, the RS outcome formula for exchange of IOL and for piggyback lenses, the toric calculator, which Dr. Atik took us in great detail, and we have the Barrett True K formula for post-myopic LASIK and for patients with keratoconus. So when we have a patient like this with a dislocated lens, which is in the AC and an after cataract, using an SRK2 or a basic formula will not give us good results. So what is the main issue with the new generation formula and where is the scope for improving them? All these modern formula are a group of formula and they have different sub-formulas for different kind of eyes. The keratoconus patient has a different formula. The patient who needs a toric re-rotation will have a different formula, though they still call the Kane formula or the Barrett's formula. The oldest formula, the older versions are all present online and we can see them. Here's the SRK formula, here's the SRK2 formula, here's a Hopper Q, here's a Haggis. All these are available to us. But the current generation modern formula are all mysterious black box solutions. So you just go online, you enter your basic data, it does some work at the back end and then it gives you a number. We don't have a clue as to how they actually work. How they seem to work is they collect a large amount of data and they keep improving the results. Please see this yellow line. Here it shows the mean corneal power, and they have a series of patients showing that as the corneal power changes from 43 to 53, as the corneal power increases, the patient tends to have a hyperopic refractive error. So what they will do is they'll find out cutoff point somewhere about 48. They will add a minus 0.5. Somewhere at 52, they'll add a -1 or a -2. So they tend to adjust the formula so that each part of it is tweaked. Depending on the corneal power, the formula will be tweaked further. See this particular circle in green. Here's the lens thickness. Here you can see the red, which is the Barrett's formula. Somewhere about 5.5, between 5 and 5.5 lens thickness and 6, the red Barrett's formula has become flattened. So they have tweaked the formula so that it doesn't go like this and give a more of a hypermetropic result like the older generation formula. They have tweaked it so it flattens. So they tend to constantly correct the formula and make it come towards a zero mean. So they will do the same for the anterior chamber depth, for the axial length, and for the various formulae. So here you can see the evidence of tweaking. Here they have made a change. As they get more data, they will make a change there in the proximal end. And here distally, you can see where it is trying to go up, but they have turned it down. So as they get more of the data, they'll find that between 28 and 30, as the IVL power increases further, they may have to change the curve and make it go up again. So this kind of constant fine tweaking of these new generation formulas seem to be taking place behind the web page. We're not informed about the changes. Now, the sex or gender of the patient is it a factor for our calculation? This paper in 2017 by Hoffer et al. Analyzed over 200,000 eyes which are reported in literature from various racial groups. And they found that males have a statistically significant longer axial length, they have a lower corneal power, and they have a deeper AC when compared to females. So there is a systemic difference between the eyes of ladies and gents. So gender is a factor, and both the Kane as well as Hill RBF fine-tune their formula depending on the gender of the patient. So look at this. This is a Kane formula, and most of us became interested after seeing this article in 2019. The same group, Ronald Mellis and co-authors, found that the Kane formula is superior to the Barrett's formula. And they also went through a large, about 10,000 plus patients in Bristol from one single surgical center in UK. And they found that overall in each axial length subgroup, the Kane formula was more accurate than all the remaining formulae. We also found that when you have a patient with keratoconus, the Kane formula is currently the best option if you want to find out the power in keratoconus patients. The Kane formula front end is like this online. It just captures the same data, axial length, K, and the ACD. Optionally, you can give them the lens thickness as well as the central corneal thickness. Kane formula will only give you toric, non-toric, and the keratoconus. At present, they don't have formula for LASIK patients. Another new formula is the EVO formula. This is the brainchild of Dr. Tun Kyon Yeo of Singapore. He was actually a fellow of Graham Barrett, and he found that the Chinese eyes do not do so well with Barrett's formula. So he found out what is the difference, and he has optimized his formula for his kind of patients. Now, all the remaining formulas are based on lens-star measurements and Alcon lenses. EVO is the first formula which is based on Technis lenses. So EVO formula also gathers the same kind of data, axial length, K1, K2, and optical ACD. Optionally, it will also capture lens thickness and CCT values. It also has the option of getting data from IVL Master 700 for post-classic eyes. It doesn't have a keratoconus option. Now, this next slide is from the talk given by Dr. Warren Hill, who said that currently we will get about 92% plus or minus 0.5 if we add somewhere, and he's talking about adding a surgeon's factor. So he feels that every surgeon will have a small individual factor which will make a difference in the overall result. Now, where are we headed? We know that race makes a difference in the K, in the axial length, and as well as in the lens thickness. We know that, for example, Indians are more prone to get to become more myopic when compared to the Caucasians. And we also know that Indians have a steeper K and a thinner lens when compared to the Caucasians. All the formula that we use, whether it's SRKT or whether it's Barrett's, are all optimized to Caucasian eyes. They are not optimized to our eyes. But we have to start looking at formula, fine-tune them so that they are more optimized to our own eyes. Now, this is not a new concept. As far as 10 years back in the Hague's site, we used to have A constant only for India. So we used to have one particular A constant for Alcon IQ. Japan had their own A constant, and the Caucasians had their own A constant. All these were different. For example, in Japan for Alcon IQ, they used a 119.1. The Scandinavians used a 119.2, while Indians used a 118.9 as a A constant for this particular lens. So A constants will change depending on the gender as well as the race of the patient. So we need to have India-specific A constant in future for each formula, whether it's Hill RBF or whether it's a Barrett or a Kane. So this I see as a future. So in summary, careful measurement after optimizing the corneal surface will give us good reproducible results. Please follow the Royal College advice for ultrasound biomicroscopy. Use the Kane Evo Barrett Hill RBF formula, but please understand there are some limitations as all of them are optimized to Western data sets and not from the data from India. So I think we are at the cusp of understanding how better quality measurements and large population-specific database will improve power calculation in different ethnic groups in different parts of the world. Thank you.
Thank you so much, sir, for your wonderful talk. So what I get to understand here is we need to collect data. We need to give data to the great minds who are working on biometry. In fact, Dr. Hill was saying that his formula was not working so great in Chinese eyes. And then he took all the efforts to take data from them, and then he was able to get better results. So as sir said, all of us do quite a number of cataract surgeries, but the problem with us, at least with me, is my data is not so great. So we need to start collecting data. We need to start giving data so that we get better values. And one more message which I could take from R.D. sir's talk was, there is no competition among these great minds. Dr. Barrett's student came out with a formula which was supported by Dr. Barrett. So that again is something great. And for Dr. Hill's formula, Dr. Barrett is giving information on Australian eyes, and he's contributing to make Dr. Hill's formula better. So this healthy competition is something that is amazing, and we Indians should give Indian data to get better values or better results from our biometry. Thank you so much, sir, for this amazing talk.
Thank you.
Jayantan, would you like to add something or any questions to Ramesh, sir?
Perfect.
Thank you so much, Jayantan. Ramesh, sir. So the next talk will be on biometry in special situations by Dr. Jayantan Soundarpandian. He's a head of refractive cataract surgery and pediatric ophthalmology at KSI Hospital, Erode. He's presented many papers in state, national, and in international conferences. He's a very good speaker. His talks on topography and the biometry and dry eye have always been great. I've always had the pleasure of troubling Jayantan for my personal queries with biometry. So three people whom I always go on to are Ramesh sir, Jayantan, and Arul sir. So thank you so much for all that, and thanks for being with us today, Jayantan. Over to you.
Thank you so much, Atik. So good afternoon, everyone. My talk will be on the biometry in special situations. So this is the same article which Ramesh quoted, the JCRS article by Jack Holliday. It says that only 74% of the eyes in general are considered to belong to a category of normal axial length and anterior segment. The rest 26% are what we are going to see right now. So the first of it is the posterior cephaloma. In eyes with an axial length more than 30 millimeter, a posterior pole cephaloma temporal to the fovea was very common. The source of error in case of a posterior cephaloma is mainly because of the irregular shape of the ocular wall. When I do a ultrasound biometry, we'll have an inability to display a distinct high retinal spike. The deepest portion of the cephaloma may be located eccentric to the macula. So when you're doing an ultrasound, it will give an anatomical axial length, that is from the corneal vertex to the most posterior portion of the macular region and not to the foveal center, which is the refractive axial length. So the resulting IOL power is going to be lower. Mind you, if you're going to use a contact ultrasound, these patients will have low scleral rigidity and any compression will lead to a highly erroneous value. So the solution for all these would be to do a vector A-B scan, where a B scan is done, the macula is located, and a corresponding A scan has to be done. And the other point is to use a probe with the fixation light, because as a patient looks into the fixation light, you can look at the macula and you can go with the calculation. So the best of it would be to use an optical biometer, that to an IOL master 700. We heard a lot about it. The reason is that it can measure the axial length by directly visualizing the fovea on the OCT image during every measurement. So coming to the formula for an axial myopia, traditionally in SRKT, the third generation formula is thought to be an accurate formula for patients with a high axial myopia. But the reason concept is that the fourth generation formula, including the Barrett, Universal 2, Holiday 2, Olsen, are all doing good, of which The Barrett Universal 2 has the best value of refractive prediction in myopic eyes, especially when it comes to the lower power IOLs. This article in HAO in 2019 by Van said that both Hill RBF and Barrett were more precise than Haggis offer qualitative. But only Hill RBF2 formula was independent of the axial length that is being measured. Coming to the extreme hyperopia, the main concern here is that even a smaller error will become highly magnified. For an axial length change of 1 millimeter in a normal range will change a power between 2.5 to 3. But when it comes to an axial length less than 20 millimeters, the change is going to be more than 5 diopters of IOL power. A small shift in ELP can lead to a bigger surprise because the lens is thicker and it's closer to the fovea. So the solution is, it's preferable to go for an optical biometer, but you can use a ultrasound, but always try to use the immersion technique, because with the contact, if there is an indentation, the error is going to be magnified. Make sure it is repeated multiple times and a repeatable measurement is taken in an ultrasound mode. So once you have an ultrasound mode, use a Hofer-Q formula. If you're using an optical, use a Barrett Universal formula. But if the ACD is going to be less than 2.4 mm, it's preferable to use a Haggis formula. Macular lesions, when a patient presenting with a mature cataract where the fundal view is not good, and if the patient has got that consecutive edema, that is a macular diabetic macular edema or tumor or a hemorrhage sitting on the macula, it will prevent the display of a distinct retinal spike, causes a shortened axial length and an erroneous IOL power calculation. These patient has to be warned before. So to know that, we have certain identification clues when you're doing an ultrasound mode, some of which are an unexplained spike along the vitreous base, an inability to display a distinct high retinal spike in spite of repeated measurement, an abnormal separation of the retinal spike from the scleral spikes, an inconsistent axial measurement inter-observer and also intra-observer if it is more than 0.2 millimeter every time, and an inter-eye variation of more than 0.3 millimeter in a patient who doesn't have a previous significant refractive error change in both eyes. So these signs has to be a warning sign, has to be informed to the patient about the other visual prognosis and need for a further intervention. So patients with an asteroid hyalosis or a vitreous hemorrhage or a gas present in, you'll see that abnormal spikes along the vitreous base. To have a high retinal spike, increase the gain setting to the maximum so that the retinal spike is high and the value is going to be right. So silicone filled eyes or the vitrectomized eyes, we heard it from Dr. Pratibha. So I'll just repeat it. The low sound velocity leads to apparent noise attenuation, leads to a difficulty of identifying the retinal spike. So all this is because of the change in optics of the eye due to the refractive index change of the silicone oil. So the ultrasound travels very slowly in the silicone oil. It gives an impression that the axial length is larger and gives a lower IOL power calculation. So usage of standard ultrasound velocity can give an error of up to 8 millimeters. So go for an optical biometer because change in refractive index by the silicone oil is less affected in case of an optical biometer. In case if you are using an ultrasound mode, always choose the silicone oil mode, know the centistroke of the silicone oil and then use the appropriate method. Try to increase the gain and get a good retinal spike and then do the calculation. To compare the values in case if you are using a routine mode, you can just use a correction factor of 0.72 to get the rough estimate of a power that you'll get with the silicone oil mode. So denser cataract where it is not possible to get the values by an optical biometer, when you're using an ultrasound, have the maximum gain setting that is required to have the sufficient height of the posterior lens caps of the retina. You can use a semi-automatic mode. This situation will be complicated if you have an inadequate patient fixation due to a low vision, nystagmus, blepharospasm, or strabismus, where a multiple reading has to be taken and an appropriate value has to be chosen. Coming to the piggyback IOL, it depends whether it is a primary or a secondary. In a primary, use a Haggis or a Hofer-Q formula and divide it into two IOL. One is going to be the full power with a single piece acrylic IOL into the back. Second will be a 1 diopter reduced 3-piece acrylic IOL into the sulcus. When it comes to secondary piggyback, the IOL power is purely based on the refractive error. No need to know about the knowledge. You don't need to have a knowledge about the primary implant or the axial length. All that you need to have is whether it's a myopic or refractive hyperopic correction. Know the refractive error. Use a Holiday's refractive formula or a Barrett Oryx formula. A rough calculation is myopia correction into 1. For hyperopic correction into 1.5 would be the IOL power that needs to be put into the sulcus. Okay, the next one would be the challenges of keratometry. The first of it would be the keratoconus. The issue here is that the keratometry is going to be inconsistent and less repeatable. And the biggest issue is that with multiple measurements, multiple instruments, you'll have multiple values. We never know which is going to be reliable. So the repeatability between the same instrument and among the instrument is going to be very, very high. Keratoconus will produce an irregular astigmatism, we all know that. And because of the steepness of the cornea at different zones, an unusual ACD calculation will lead to an erroneous ELP calculation. The visual axis is not going to be on the apex, will be on the slope of the cone. Normally, as age increases, a cornea will have a positive spherical aberration. But in case of a keratoconus over the cone, you will have a negative spherical aberration. So the cornea will act like a multifocal cornea. So choosing the formula and choosing the right IOL is also very, very important here. So to overcome this, you need to use a K value from the topography and never use a sim K values. Use an axial length from the optical biometer. It's preferable to use SRKT formula and a Barrett Universal 2 formula. But as I mentioned, more than the formula, it's a keratometry value that is going to be very, very, very important here. So toric IOLs are indicated if you are able to get a very precise, repeatable keratometry value. So it's indicated in case of a mild to moderate keratoconus with much regularity in the central 4 mm, where the predictability of IOL power is going to be very good. It's okay to use in cases of a severe keratoconus, but the prediction is going to be high, but the patient can have a little bit of spectacle independence postoperatively. Okay, the more sought eyes, that is a post-refractive eyes, the reason of getting inaccuracy in these eyes is because of the keratometric index error, the radius error, and the formula error. When I meant to say about the keratometric index, so most of the calculation assumes a fictitious keratometric index of 1.3375, because this is here the anterior cornea and the posterior cornea sum together, they use a refractive index of 1.3375. It works well in the virgin eyes, but if it comes to the post LASIK or post PRK eyes, where the anterior cornea is altered, the posterior cornea is unaltered. So here the ratio is disrupted, the KRA is going to be invalid, because it's going to have a calculation based on the anterior and the posterior correction. So it changes according to the attempted correction. So in these cases where there is a post LASIK or post myopic eyes, if at all if there is going to be a myopic correction, it overestimates a K power, and finally it underestimates an IOL power, resulting in a post-op hyperopia. So the higher the attempted correction, higher is going to be the change in refractive correction post-operatively also. The solution is to use a technology that measures both the curvature using a Scheimpflug imaging or a swept source OCT. The radius error is mainly because the instrument extrapolates the central corneal curvature from the paracentral measurements. Imagine if there is a post-myopic ablation, the instrument measures the paracentral cornea that is going to be steeper than the central cornea. So the K is overestimated. So this is more relevant in eyes where there is a smaller optic zone or a decentered ablations. So solution is to use the central values from the tomographers or the recent onset IOL, the optical biometers, rather than the SIMK values. The formula error is mainly because the keratometry, what we are going to calculate is wrong. So when you are going to use the keratometry values for the IOL power calculation, these formulas are also going to give an erroneous value. So if this is wrong, in a post-refractive surgery, there is a reduced corneal power that is calculated, an underestimation of the ELP occurs, and an IOL power will be underestimated. So the solution is to avoid formulas that uses a K and go for a solution, go for a formula that uses a value that is other than the K values, like the Haigis formula, or use a double K method. The double K method works with the data that is available preoperatively, the refraction or keratometry and or keratometry. But what if all these preoperative data are missing or is underlabeled? That's going to be the case in most of our patients. You can use a Shamas no history method or a Melonage method. And the reason concept and the reason accepted now is to use a Haigis L if you're using an IOL master, or a Barrett True K formula online in the online software. The future is going to be a Gaussian optics formula, the best T formulas, and the corneal tracings, which uses a Snellen's law. This is an online calculator. You can feed in all the data that is available and you can get the values. So we'll just wind up with the short case. This is a 40-year-old female who was actually denying any history of refractive correction. For an axial length of 30, she ended up having a correction of, IOL power calculation of 17.5. This prompted us to do a topography, and she had a myopic ablation with a small central, slightly decentered optic zone. We calculated using a EKR value. To our surprise, both the lens chart, the post-refractive surgery calculation, and the ASRS calculation gave the exact same value,
both for Shamas and Barrett true K. We went ahead with the Barrett true K history and no history formula and ended up with an emmetropia. So to sum up, understanding the science of IOL calculation is very, very important when it comes to these extremes of eyes. There is no one size fits all or a universal formula for all your cases. The formulas are evolving. We need to accept and understand that. And of course, adapting, updating, and accepting the newer technologies is a must when it comes to these extremes of eyes. Thank you.
Thank you so much, Jayantan, for elaborately explaining each condition in detail. So just one query I have. You had shown that in extreme eyes, you wanted to choose certain specific eyes. That is, you were saying Haigis when the axial AC depth is 2.4 and a different formula in a different setting. Any explanation on why those changes, whether if you can share that slide, if you don't mind, and explain that, please. Or just explain it, because I think the next team is waiting. We'll have to wind up in a minute or two.
The reason is Haigis uses a formula, uses a conversion factor that is completely independent of the ACD. It doesn't use an ACD. I mean, like the ELP calculation for an Haigis is not dependent on the actual ACD that is being calculated. That's the reason why if it is less than 2.4, you're using a Haigis formula. Other than that, Hofer Q works well for all these eyes. It's mainly because of the ELP calculation and the parameters that is used for calculating the ELPs.
So a post-refractive, when you do a cataract surgery, do you take wavefront into consideration? I want Ramesh sir and Jayantan's opinion on that.
Generally, when it comes to wavefront, it's either corneal or it is a total. So when you are going to do a cataract surgery, naturally you're going to remove all the aberrations what we are having with the lens. So it's only with the cornea.
I'm only talking of post LASIK or post refractive surgery, as Jayantan. Do you routinely do wavefront analysis?
No, I don't do.
You don't do.
So yeah, I just go with the topography, see for the ablation zone and the keratometry values from the topography, and then feed it. I don't go for wavefront ablations.
Ramesh sir, you're there?
Yes, Atik, I'm here. Atik, I normally will not check unless I find something wrong with the flap. Suppose there are flaps striae or there is some epithelial ingrowth. If there is some problem, I will check out the wavefront, or I will not be concentrating on that.
Thank you, sir. Pratibha, you'd like to add something, or thank you. So thank you so much. It was a wonderful session. Thank you, Dr. Jayantan. Thank you, Dr. Pratibha, and thank you, Ramesh sir. I'd like to thank Team DOS, Subhash sir, and Namrata madam for this wonderful opportunity. Thank you so much.
Thanks, Atik. Thanks, friends. Bye-bye. Bye.
Thank you.
Thank you, doctors, for ending the session on time. Thank you, Dr. Atik, for the wonderful talk and session. And I would now like to conclude the session. Thank you.
Excellent.
Hi,
Everything is going on in time. Wonderful. Jatinder, great teamwork. Great time management.
Hi, sir. How are you?
Yeah, good, Chatra. All fine. So this is one of the more uninteresting subjects in the whole. You don't have videos to show. You don't have videos to show. You don't have the excitement. You don't have OPL stuff. You don't have court martial stuff. But in real life, it becomes a court martial if you don't adhere to these principles of research methodology.
Jatinder has given us such tough topics, sir. I was telling him, my God, these are things that we speak about, but we don't really, give as much attention as required.
Yeah,
I hope I've done justice to whatever he wanted me to do.
So, Jatinder,
with your permission, sir, we have 2 more minutes to go, sir.
Yes, Jatinder. So, how are things, Jatinder? What is the physical numbers you have at the halls?
Sir, people are coming and going, and a lot of people are joining in virtually.
Yeah.
And right now it's like lunchtime. So this session was actually aimed at things which are really important, given that we had this Lancet fiasco which had come up. So I thought it was very appropriate, and I wanted to get the best research minds, but it to speak on it, and we have a very eminent panel here.
Yeah.
So that was the basic idea for it, sir.
No, I think this is very important, and to getting it down to the state levels also is quite important, because there are researchers all over, and people wish to do research. Institutions are there, so a proper guideline needs to be adhered to. We are at times faced with difficulties of in the publications or even in presentations. So it's a very
So
valid
actually,
topic.
what happens is that daily, if we start doing a bit of advocacy on this, this is a very important area. You see, we've done fairly well on bioethics, and this Wuhan episode probably opens up some Pandora's boxes. So we really need to enlarge the gamut. And I thought, who better than the people on this panel? So Dr. Gopal would be joining a little later. So I think we'll start with you, sir.
Good afternoon, doctors.
We have the.
To begin with the session, I would like Dr. Jatendra. I guess Dr. Jatendra is already unmuted himself. Dr. Jatendra, over to you, doctor. You can take the session ahead.
Thank you so much. And give me the Zoom meeting.
I've shared my screen.
I don't need a share screen. We've changed the order.
I will stop sharing. Yeah, you go ahead, Jatendra.
Good afternoon, ladies and gentlemen. It gives me great pleasure to welcome a very eminent panel today in the Scientific Research Colloquium. And in this, we left out a U. The basic idea was the only thing missing in the colloquium is you. So that was the tagline. And basic idea behind it was that we, last year in 2020, on the 19th of February 2020, several virologists signed a letter stating that, the origin of the virus is natural, and it was published by the Lancet in February 2020. And 1 year down the line, what happened was we realized that one particular gentleman amongst them, a gentleman called Peter Daszak, who was heading something called the Eco Health Alliance, had actually not told us the entire truth. He had taken some money from some governments and had been funding some research in some institutions. And by and by, the world at large started feeling a little cheated about it. And the editor of the Lancet came under fire. Our processes and procedures came under fire, and a lot of questions started being asked. So I have with us Dr. Partho Biswas, who is the chairman of the scientific committee. We have Professor Namrata Sharma. We have Dr. Chaitra. We have Dr. Santosh Honawar, and we'll also be joined by Dr. Santan Gopal in a short while from now. The basic idea is we want to focus on the processes and the procedures that are involved there. So with the permission of Dr. Biswas, could we start, sir? Sir, I'll request you to start the proceedings.
Thank you.
And thank you so much, sir.
I must thank DOS and I must thank Jatendra for actually giving this important subject in one of the sessions. And it's so important a subject. It's when we realize that we are in trouble, whether we are researchers or whether we are people from institution leaderships, then we know that yes, things should have been better, things should have been more organized, and the research integrity and the obligations of institutions then actually comes into play. So when we think about this, it becomes a little too late at times. So let us look at what integrity in research means, what is the obligation of institutions. And Jatinder has given me a tough task, and I just hope that I'll be able to make some amount of idea about this subject. So research is to see what everybody has seen already and to think that nobody else has thought. With this very, very beautiful words, I would like to say what would be the principles of research. It has to be excellence. It has to be coupled with honesty. There has to be integrity. There has to be accountability. Training and skills have to be imparted, and it has to be safe. So science and scientists are two aspects, and here we have to talk about the integrity, which science is more and more getting intertwined with major social, physiological, political, economical, and philosophical issues. And scientists are becoming more and more accountable to the larger society for which they are a part of, and they are answerable as well. So the integrity in research for individuals and for institutions, there has to be a hand-in-hand coordination, cooperation, and thus it goes on. So what about the range of practice for one individual scientist? The individual scientist with science in his mind, with an innovation in his mind, with that fire in him, wanting to do something beyond the ordinary. He has to be intellectually honest in proposing, performing, and reporting the research. There has to be accuracy in representing contributions to research proposals and reports. At times, these can be lacking. People can be carried away. There has to be a fairness when it goes in for a peer review. Again, at times, and there is multiple examples that peer reviews have been doctored. Collegiality in the scientific interactions include the communications and sharing of resources. Here, how far to share, with whom to communicate is important. Transparency in conflict of interest or potential conflicts of interest have to be determined and have to come into task. Protection of human subjects and conduct of research is one of the most important criteria. And by, lot of laws have come in, enforced by governments of different countries, that this has to be a well-protected human subject, not only humans, but also animals in which the conduct of research is. There has to be a human care of animals, and it has to go through the particular protocol, and we have to adhere by it. At times we feel that, oh my God, if so much is to be done, if so much of paperwork has to be done, if so many things have to be adhered to, then how do we go ahead with the research? But let us keep in mind that the research is for the people whom we have to serve. And thereby, these human subjects, again, and the animals have to be given their due respect. Adherence to mutual responsibilities between investigators and the research team. At times, the PI does not disclose many facts and figures to the research team, which actually is mandatory. Now, let's look at the conduct at the level of the institutions. Most institutions, not only in India and abroad, but in most of the countries, are actually doing good research. They have to provide, they have to encourage, they have to promote, and they have to advocate. So provide what? They have to provide the leadership and support and responsible conduct of research. To encourage, at times research can be extremely fatiguing. It can go into difficulties of finances, it can go into difficulties of different factors associated. The encouragement has to come from the leadership of the institution. It has to promote institutions, large institutions, which have the money power, must promote productive interaction between the trainees and the mentors so that the inspiration from the research comes on. And it is the youngsters with their vibrant mind who actually think of that one idea that can really make a difference. The advocate adherence to the rules regarding all aspects of conduct and research, especially with human subjects and animals, is definitely the level at which institutions have to pay great attention. Anticipate, reveal, and manage, and institution conflicts of interest. They have to have an arrangement of time. The time factor in any research is extremely important. There might be 3 or 4 researchers all over the globe working on similar lines, but it is that one who strikes it first, gets the research through and gets it. The educational opportunities pertaining to integrity of the conduct of the research has to be offered. At times, different faculties have to be pulled in. Faculties which are not possible in one particular institution. For example, in an ophthalmic setup, we do not have microbiologists of that level or engineers of chemical engineering of a level. It has to go hand in hand with other institutions. Monitoring and evaluating. At times, this again becomes the institution's great importance because the research at every step has to be monitored and evaluated on its continuous quality improvement. So general guidelines on good practice in research, organization and researchers have to comply with all the legal and ethical requirements and other guidelines that apply to the research. And that is not only a state requirement, but it's a country requirement. And by, the countries come up with different legal requirements, and they have to be adhered to, even if a particular research has taken place a little earlier or has been initiated a little earlier in time. So insurance and indemnity prior to the research being conducted has to be there. Organizations to provide training, resources, and support to the researchers to ensure that these policies and procedures are complied. And this demands a huge amount of work, a huge amount of paperwork, as well as compliance with the government and the statutory requirements. So the organization has to guide the good practice that is required. Training and mentoring. A bright young fellow might have a great idea, but he has to be mentored, he has to be trained if that has to go on, and it should support the researchers by the unmet needs of the training and development. For this, again, finances are important. There has to be a responsible design, a conduct, and dissemination of the research. The research design, when designing such research projects, both the organization and the research should ensure that the proposed research actually addresses a pertinent question. What is the question of research is very important, because at the end of that research, that question has to be answered. And there has not to be a gray zone between the answer and the question. The design of the study is appropriate for the question being asked and addresses most of the potential sources of bias. Conflict of interest is, again, a very important aspect, and institutional considerations or personal considerations have to be taken into account. And these have to be identified, these have to be declared, and these have to be addressed. Again, if it involves human participants, human material or personal data, the organization and the researcher should make sure any such human participant or material has complied with all the legal and ethical requirements. Dignity, rights, safety, all the definitions are changing every month, maybe every year, and we have to be assured that we are doing the right thing there. Animals. At times, the animals, at one point of time, researchers were taking the animal research for granted. But now there are very, very important guidelines where you have to be ethical. One has to be has to have a peer review of the research projects involving animals and what actually happens to these animals, and because we as researchers are responsible for researching on these animals. The health and safety. Again, the health and safety has to be fulfilled so as the safety legislation and good practice pattern has to be adhered to. So this involves any hazardous or harmful material that might cause harm to the environment, and it has to again go through legal requirements. Intellectual property, and this again is a very important aspect. We have had webinars on this. Organizations and researchers should ensure that contracts or agreements relating to research include provision for ownership and use of intellectual property. Finances. Every research has to be well financed so that it gets to a conclusion at the end of the research. And researchers should ensure that the term and condition of any grant or contract is adhered to. The collection and retention of data has to be maintained. Confidentiality has to be done. And if there are third parties, protection of intellectual property rights are mandatory. Publication and authorship. But before this, I must say patenting a research is again a more important aspect. We need to patent the idea, and there are regulations both in India as well as abroad on the patents. One needs to pay attention that it's not just a bright idea culminating into a good research, going on to a good publication, getting peer reviews. No, patenting is important. So publication and authorship and organization and researchers should accept their duty to publish and disseminate the research in a manner that it reports the research and all the findings as accurately as possible. We have to address all the issues of publication and authorship, and no person who fulfills the criteria of authorship should be excluded from a submitted work. Thank you. Thank you very much for your patient hearing.
Thank you, sir. It was a fantastic presentation. And actually what we did was we jumped the order. Dr. Partho's presentation was to come right at the end, but he would be in another session at almost the same time. Thank you so much, sir. It was a fantastic presentation. So one small question. You see, we've held very high standards in biomedical research when it comes to research involving human beings. Now, given the fact that there is a lot of translational research and research, for example, biotechnology is also having an impact on human beings, and maybe even let's say the computational sciences and artificial intelligence, is there a need to actually enlarge the scope of our regulatory environment? Because a lot of things are actually affecting the human health at large now.
Exactly. Yeah, Jatinder, you've raised a very important question, and we've had to answer this question time and again over the last 1 year. So as we were, we had come into a difficult situation where there was a researcher and the ethics committee had actually said yes to the research, but then there were different protocols in place which came in, and those protocols were not adhered to fully and finally. So we have to keep updated on the government regulatory protocols of anything that is going on with our research, which is pertinent to it. And that protocol has to be actually understood and determined. And these are not something that, a particular researcher, Dr. Chaitra would know, Santan sir would know, Santosh would know, but it has to come also, the legal aspect is also there. So it has to be a culmination of both the scientific as well as the legal aspect, and the government, which actually institutes these protocols, which have to be taken into consideration.
So basically what sir is saying that, you see, it is not only in letter And it is also the spirit in which we should actually be adhering to our interactions with our environment and the way we understand environment by way of research. Thank you so much, sir. Sir.
Thank you. Thank you so much. Thank you, Jatinder.
And now I'll call upon Dr. Chaitra to tell us more about conflict of interest. And after that, Dr. Santan Gopal would be joining us.
Thanks, Jatinder, for the opportunity, and to DOS as well. This is a very different session where we have a lot to introspect. Are my slides visible?
Yeah.
Okay. So today I'll be speaking a little bit on conflict of interest. You know, we know it very matter of fact. We don't really go into thinking about it so much, which is why this particular slide has a lot of importance. You know, everybody wants to, keeps asking, why do we have to put this? So why I'm putting this slide is to say that I have no financial disclosures that can affect or influence what I'm going to be presenting in the next few slides. This is particularly important for a lot of people who are advisors for certain companies because they might be receiving, an honorarium, or they might be receiving a fee for their consultation where they're advising the company per se. So whatever that person presents will obviously have a bearing on their inherent interest. So that's why when we need to put this slide, it basically means that we have no financial disclosures. Now, for example, now DOS or even Jatinder has not, asked me to specifically mention anything in their favor. So therefore, no disclosures. Now, what is conflict of interest? A conflict of interest may occur when a clinician, it could be a researcher, it could be a public official, an IRB member, an author, a reviewer, or an editor. If you see many a time you're asked to declare your conflict of interest when you're even reviewing a paper, that's probably because you could be working in that particular field and you will have conflict of interest if somebody else has already written up that paper, which may give you a bias to reject the paper, which is why that's again very, very important. It basically allows a secondary interest. That could be a financial gain, a publication opportunity, a career advancement, outside employment, personal considerations, relationships, investments, or gifts. All of these are the so-called interests that we talk about, the conflict of interest per se. And that will basically allow it to interfere with the primary interest. The primary interest here, particularly in our field, being patient welfare, it could be research validity, it could be publication of the research, like the paper you are reviewing. But your secondary interest is that you want to publish it before this person. Obligation to act in the best interest of another. So these are your primary interests. You should not allow the secondary interest to become a conflict. I don't know if I've made myself clear. So this is basically conflict of interest. In research, it exists when the individual has interest in the outcome of the research that may lead to a personal advantage or disadvantage, and that might actually, in appearance or in reality, compromise the integrity of the research. So we should not have any conflicts when we're either participating or analyzing or reviewing any sort of research. Now, going back to history of conflict of interest, it was there even prior to 1940s, where basically there were foundations who were the primary funding source. So obviously when they had, such a huge influence in terms of funding, they would definitely have, a secondary interest outcome from the research conducted. By 1940s, the conflict of interest meetings began. By 1950s, we saw industry sponsors retaining publication rights and restrictions on the data that was produced of the research that they sponsored. By 1960s, academia and industry started addressing drug safety, especially when a trial was sponsored by the industry. In 1970s, the conflict of interest had reached even environmental and occupational exposure. This became very important with respect to industry, especially when there were waste produced or the way anything was produced itself. 1980s, COIs managed according to special circumstances and traditions wherein some sort of leeway was given. By the 1990s, the COI reporting starts, and by 2000, there were actually 8 reports on the guidelines or recommendations for COI. Now, different categories are there. There are actual, potential, or they could be perceived, and financial and non-financial. Now, coming to the types of conflict of interest per se, it could be institutional, individual, family, household, or other. Now, if I have to go into some of the specifics, let's go into the institutional conflict. Now, you have an institutional conflict with a proposal. Basically, if, for example, you hold a current position in the institute, it could be a permanent or a visiting position. You have a financial arrangement. You were employed by an institution in the last 1 year, or you're seeking employment in future. So you may want to favorably mention some outcomes that have come out of a particular institute, or you have a formal or an informal re-employment arrangement with them. You could also have it if you serve on the visiting committee or on a similar body where you do manage some parts of the running of a research. You serve as a trustee on the board. You have received or retained money from the organization. It could be honorarium, it could be travel expenses, or you own stocks or securities in that particular organization. As an individual, if any particular proposal involves a spouse or a family member, a business or a professional partner, a former employer within the last 1 year, or a present or past PhD advisor, or even a student or a collaborator in the past 48 months, all these can give rise to potential conflict. As part of a family or a household, you may have it if the employer or a school of the spouse or of a child. It could be a person living in your household, the employer of such a person in your household, or even your parent's employer. So if you have anything to do with any of them, you definitely have a potential conflict of interest. Others could include, a lot of other things which can, where you're actually questioning the impartiality, whether, any reasonable person with adequate knowledge will question your impartiality itself. And do you share a close personal relationship or a strong personal rivalry with one of the PIs or the principal investigators in the proposal? So all these are very, very important. They go to a personal level, but they are nonetheless important. So simply put,
Dr. Chaitra, we've lost the audio. We've lost the audio.
No, I haven't done anything. Can nobody hear me, or it's only?
Yeah, we got you back. We got you back.
Yeah, okay. So simply put, it could be either financial gain or when the treating physician and the investigator are the same at an individual level. And when you look at institute, it's a lot of financial
Dr. Chaitra,
gain.
could we go back to the previous slide, please? We lost you on that slide, actually. Momentarily, we lost you.
Yeah, so this is a few other examples that I spoke about, like, if you have a PI who's a very close personal friend, or it could be a strong personal rivalry between them, it will definitely, affect the outcome or the, the results or the involvement. It could be so many things, the recruitment of a patient, anything. So therefore you have a conflict. So to put it simply, it could be either financial gain, or it could be at an individual level and even at an institute level. When you're doing particular research, you could have probably higher donors. Now, suppose I'm doing research on retinitis pigmentosa, and there is somebody who's a big donor who's had a family member suffering from RP. They might probably put in more money into the institute. So I'm just giving you a very, very simple example of how there could be conflict of interest. So now the consequences are important, because that will actually judge the validity of the study, the integrity of the study. So the safety of the participants in the study also is very compromised when such a situation arises. Therefore, we have to be very, very wary. And now, therefore, there is a lot of government intervention in the US itself. Both NIH and FDA have laid out very, very strict rules to reduce the impact of conflict. And the provisions that they make is to disclose any significant financial interest that can impact the study. So this is now mandatory. Even beyond the US, a lot of institutes and a lot of organizations do make it mandatory that you have to disclose any. When you're looking at industry sponsorship, the pitfalls are it can influence the study design, analysis, interpretation. They tend to suppress negative results because they don't want to speak poorly of their product. And results can be sometimes made public even without peer review in the form of non-peer reviewed journals or the so-called magazines, like we like to say. With respect to professional societies, we do have pharma supporting meetings and CMEs. We have biased CMEs and group meetings where we're only talking about one particular drug or a particular device. We have media presentations over scientific facts, and the biased articles also can sometimes come when we're pushing for something, that we probably believe in, but it may not truly be an unbiased view. So as Drummond Rennie said in the JAMA, this is all about bypassing science. Medicine is becoming a sort of cloud cuckoo land where doctors don't know what papers they can trust in the journals. So this was a very strong statement that came out. And if you also look at this particular publications on treatment guidelines by the so-called expert groups, it showed that 33% of guideline authors had some sort of financial interest in the drug. 50% had no CROI documentation even. 34% stated that they had no conflict. 50% had at least one author receiving research support. And 43% had at least one author who was a paid speaker for the company. So what solutions do they have? At an individual level, if you think you have conflict of interest or any other circumstance that could lead to question about your impartiality, contact the project or the program director or the principal investigator. And if you yourself, the principal investigator, go to a higher up authority before you actually submit it for review or conduct the study. Also, there should be some amount of assurance from the institute wherein they obtain financial conflict of interest from all investigators, create a process of review and report so that, even if there is one person who seems biased, there's another who can probably, justify or clarify. And investigators must comply with this particular institute policy. How do you reduce COI? It could be disclosure, prohibition, and some strategies. The goal of disclosure is to basically, bring objectivity in research, prevent harm to the patient, and increase public trust. Because as so many patients now go through your papers on PubMed before they come in to see you, so they should trust you before you start even treating them. Prohibition, eliminate activities that have any inherent conflict. It could be gifts, it could be equity, samples, speaker bureaus, industry controlled educational programs. As far as strategies go, peer review of study design, independent oversight of research should be there, insulate subjects of study from the potential conflict of interest investigators in the crucial part of the study, and also disclose financial interest even to the subjects or the patients on the consent form. You can actually mention that this particular investigator has this. With respect to the industry, we should ensure consultant agreements, publication of the results, even if it's negative, and intellectual property rights. That's again a different topic by itself. Now, I had two quick scenarios. Do I have time or can I skip this?
We have time.
Okay. So this is basically about applying knowledge. Just two quick scenarios and then I will summarize. So Kirti is a project coordinator supporting research work led by a principal investigator. In her staff role, she'll be monitoring tasks, submitting administrative paperwork, documenting progress, and scheduling meetings. So do you think Kirti is an investigator for the purpose of considering financial conflict of interest with this project? What do you think, Jatinder, since you're hearing it? Do you think Kirti could have potential conflict of interest, yes or no? Yes or no?
I'd say doesn't look like.
Pardon me, I can't hear you.
The title says she's a coordinator. She is not a primary investigator.
Exactly. So the answer is no. She's not an investigator because she's not responsible for the design, management, reporting of research, etc. So now let's go to the next question. Okay. So Raju is a data analyst for a pharmacy department. He is assisting the PI. In his role, he will provide identifiable data to the PI, listing patients being treated for high blood pressure. Whereas Rani is a pharmacy student, the PI provides Rani the data from Raju. In her role, she reviews each person's records and against inclusion, exclusion, and to determine if they're possible candidates for the study. And if yes, she contacts them to explain the potential risk and benefit of the study. So are Raju or Rani investigators for the purpose, again, do you think any of them have conflict of interest? So we'll ask Jatinder, do you think Raju has potential conflict?
No, Raju has no potential conflict of interest, while Rani may have.
Yes, so that's right. Because Raju is not an investigator. He just basically handles the paperwork and gives the information that's required. Whereas Rani is an investigator. She basically gets involved with the study subject. She's responsible for explaining potential participants the risks and benefits or alternatives. So this is just simply to bring about and to summarize, increase in academic activity has definitely increased the potential conflict of interest. The compromise of conflict of interest can affect individuals, institutions, subjects, organizations, all of us, because we're all professionals involved in research some way or the other. All this should be disclosed before the study, and institutes must have a protocol and even an ombudsman if required. We must understand that conflict of interest can never be eliminated. What is important is to mitigate its influence on the impact of science and at the end of the day, protect our patients from this potential conflict that can harm them. Thank you so much. I would like to acknowledge the help of my friend and colleague, Dr. Anand, in preparing some of these slides.
Thank you. Thank you, Dr. Chaitra. I have a fantastic presentation, very lucid and very informative. Well, I have a question. Like in the US, they have defined it as significant and non-significant, and they've kept the cap at the original cap was, I think, around 10,000 US dollars. Now,
15 now, I think.
It's how
now
much
it's,
is
I
it
think,
now?
around 15,000 now.
Now it is
15,000
15.
US dollars. Yeah.
So now it is 15,000 US dollars. Now, my question is, since we do not have, do we have something like that in our country? So
really.
we really do not have something like that in our country. And the other question that arises is that, you know, we've had very high standards for the authors and the principal investigators. And, you know, the standards keep on getting diluted as the value chain changes. And you see, research is being consumed. All knowledge today is based on the research that is being conducted. So you did talk of institutional oversight mechanisms. Do you feel that there is today a need to redefine it, and probably is there a need for all professional societies and organizations to come forward and talk to the government that, you see, there are other aspects of it which need to be looked at and have as high standards as we are having in, say, the biomedical research?
Okay, so your question would probably not have any concrete answers as of now, because we don't have a central governing body for research as such. Though we have ICMR, it does not apply to all institutes. It does not apply to private establishments and government establishments. Though they have set guidelines, they do not enforce all of these guidelines. Now, having said that, I think till we actually have something like NIH, you know, coming in and saying that this is how you have to do it, or something like an FDA which says this is how it should be done, at an individual or an institutional level, I think we should take care, and most of us are doing it. But then what happens is everybody does not have access to those rules and regulations or governing bodies. We have an Institute Ethics Committee which takes care of it. We have the chairman of the Institute Ethics Committee who will ask us, what way are you benefiting as an individual? What way is the patient benefiting? What way is the institute benefiting? And then he or she weighs the pros and cons and then gives clearance for the study. But that does not happen day to day, right? Sometimes every single patient we treat, we are not weighing the pros and cons like that. That is only with respect to research. But even clinically, sometimes when we are giving a particular drug, are we actually looking at whether it's the best for the patient, or whether it's best for me, or whether it's best for the industry? You know, we don't really do that. So I think that has to come from within, and nobody can enforce that. So there are some things that are enforceable, some things that are not. And I think at the end of the day, we all should let our conscience work for us.
Yeah, thank you, Dr. Chaitra. I think that answers the question in a very lucid manner. And going forwards, of course, nothing can be perfect. So what we've done in this presentation is we've defined what a conflict of interest is, and we've made broad outlines of what is actually available. Now, with that, we'll thank you, Dr. Chaitra, so much. And now we'll go to what was originally the opening speaker. He's one of the most creative minds in Indian ophthalmology, with a device for amblyopia treatment to his name. I welcome Dr. Santan Gopal. Sir, and sir will be sharing his. Is sir with us? Is Dr. Gopal?
Not there, sir. No, doctor. He's not there. He was here till a bit back. He's not there now. Yeah, he's in the attendees. Can you please elevate him
please
to
promote him to
panelist?
panelist.
He's there in the attendees.
Oh, that matter.
We need to make him a panelist.
We have Dr. Honavar is also there. We've got him back.
Yes, we got Dr.
Yeah. We thought, sir, we'd lost you.
No problem. Some problem happened.
Please promote Dr. Honavar to a panelist also, please.
He's already there.
Yeah, okay, good, great. Dr. Santan Gopal, let me again introduce him. He's one of the most creative minds with an amblyopia treatment device to his name. Dr. Santan Gopal, please.
One second, I'm sharing the screen. Can you see the
Yes, sir,
slides?
we can. Yes, sir.
Yeah. So my talk is about the credibility in scientific research and the value of public oversight mechanisms. Now, both the talks take a long time, but Jatinder has made sure that I keep quiet within 10 minutes and has combined both the talks. It's not very easy, but I'll do my best. The public oversight mechanisms, Chaitra has already talked about, and there's going to be a lot of overlap between the various talks because that is the nature of the research. It's not going to be just finished in 1 second or finished in 10 minutes given time, and everybody understands everything that is told. That's not possible in research. You must remember any research, when it's published in a journal, serves as the narrow borderline which separates the known from the unknown. So when you do the research, if the integrity and the honesty is missing in research, and a wrong research applied to a large population is going to cause severe problems and can cause loss of lives also. For example, during the Second World War, the Germans did a lot of research, perfectly recorded and perfect.
I think we've lost Sir again.
Yes, I believe too. I think he has some network issues.
Do we wait for him to join back or?
Yes, we'll wait for 5 minutes. If not, then we'll continue with Dr. Santosh and then we can have him speak after Dr. Santosh.
Right. Is Dr. Santosh? Good afternoon, Dr. Honavar.
Hi.
Nice to have you on the panel.
Mm-hmm.
And we have somebody who's handling conflict of interest issues on a day-to-day basis. So I welcome on board the current editor of the Indian Journal of Indian Journal of Ophthalmology, and a very renowned researcher across the world. He was the person who actually inspired a generation of youngsters and young ophthalmologists to do research through his very valuable and very acclaimed work in the ARVO. I think Dr. Gopal has joined.
Yeah, he's back.
Yeah, he's back. So let's have him back. Dr. Gopal, sir.
Can you hear me now?
Yeah, we got
yes,
you
sir.
back.
Yeah. See, some problem with the connection. That's why it got...
Yeah, sir. That's the problem with India. The bandwidth.
Yeah. So let me continue with that. Can you see the slides now?
Not yet. You can share.
So research is the narrow borderline which separates
so
the
we
known...
can't see you or the slides.
You can't see me or the
Sir,
slides?
you've actually you've switched the video off. You'll have to...
That's okay.
The video
that
stream
will
is
save
off.
his bandwidth, at least slides.
Yeah, let's get the slides, sir, please.
Okay. I am sharing the video. Why it's not being seen? Okay, hold on.
Now you can share the screen.
Can you see it now?
No, sir.
No? Oh, it's showing it is on my computer. This thing, it is showing that it is being displayed.
So it's saying that you.
Nothing is being shared, sir.
So the video stream is stopped, sir. So are you joining from the app or are you joining from the browser?
iPad. I'm joining from iPad. Hold on 1 second.
So the video stream is off, sir. Yeah, we got it now, sir.
Got it now? Okay.
Slides
now
are
you share screen, sir. Share screen.
Yeah.
Sir, actually the button that you're toggling is not the share screen button. That's the video button which is being toggled on and off.
Oh, okay. Share. Okay, hold on 1 second. This is the problem with Apple.
Very small icons.
Okay, start broadcast. Can you see it now? It will come in 1 second. I'll cut short my this.
Now we got it, sir. We got it. We got it.
You got it now? Okay.
Yeah, yeah.
Can you see it now?
Yes, sir. Perfect.
Yeah, okay. So now, how do you assess the credibility of a given scientific research? Well, when you are reading a research paper, you need to look at who has written that paper, number one. Number two, from which institute that research paper has come from. And once you know these two aspects, you know the credibility of a research paper to a large extent. The third important thing in this is the quality of data acquisition. Now, nowadays, there are a lot of laws regarding the data acquisition, data storing, data sharing, etc. The laws have become mind-boggling, because if you are a primary investigator, that is your duty to ensure that there is proper data acquisition and there is proper data storing, and also sharing is only for the restricted people, not to everyone. And most importantly, the quality of the statistical methods used. Just because you use a Russian name doesn't necessarily mean that it is the correct statistical method. People cleverly, what they do is, if it is a parametric data, they use non-parametric tests, or if it is a non-parametric data, they use parametric tests and can bring out by number crunching p-value, because everybody looks at p-value rather than actual method used in the statistics. So now people are asking for the original data from the researchers to analyze how far it is correct. So how do you identify a credible research? Apart from the two I have already mentioned, the researcher and institute, the third thing is the clarity of thought in the presentation. When you read the first few lines of the research, the aim, you will get to know whether it is a prospective study, whether it's a retrospective study, cohort study, or it's a multicentric trial. Everything should come out in the first few lines of the research, because you know that the evidence is of different levels. And since the research value depends on what type of evidence you have collected over a period of time. If it is a multicentric RCT meta-analysis, it has highest value. If it is just a case presentation, it has lowest value, although you cannot disregard the value of case presentations, as we saw in case of the babies born without arms. The prospective blinded studies often have more value in contrast to retrospective studies, and meta-analysis of the multiple RCTs has a better value than other studies. So nowadays, you don't find single author studies. You always find multicentric studies. The moment you make it multicentric studies, the problem arises about the data transfer between the various centers and the data analysis, data storage. That's why there are many laws which have come into existence because of the difficulties of a given study because of the data manipulation. So who should see the data, who are the staff allowed to look at the data, all these are very essential methods which decide the credibility of a study. Then the statistical methods, what exactly are the statistical tests they have used? I think nowadays everybody is declaring all the details about the statistical person and the statistical methods used for the study. They are declaring it, and there will be a small paragraph in many reputed journals about the statistical methods used in the study. Then you need to look at the quality of journal and the impact factor. Well, there are some issues with impact factor. If you keep on quoting your own studies, your impact factor can be very high. So what is important is not just the impact factor. What is important is the value of that research to the other clinician. That is even more important than just the impact factor. A basic science journal will have an impact factor of 48, 50 and things like that, but not clinical journals. In clinical journals, never ever reach that level. Then what is important is also the track record of researcher and the clinical research organization. Now, any clinical research organization cannot function without adequate funding. Now, adequate funding comes from where? It should be government funding or it should be non-governmental funding. If it is non-governmental funding, you will never find people who will throw money for a research which gives you negative research. They always want positive results. So that is the bias induced by the funding. But the government funding is not always available because our health funding for the whole country is about 1.5% or 2% of the GDP, which is negligible. And most of it goes for paying the salaries, etc. of the staff rather than research. So for India, research is a big problem. We have been conducting research in a small setup. And I will tell you, research costs a lot of money. We have designed 2 instruments and both of them have cost more than ₹1 crore just on research, paying the engineers, paying so many people. So if nobody supports research, no credible research will come out. So government should make allocations for funding of the research in big institutes who they can then decide what funding goes to which person, etc. Now, declaration of conflict of interest and funding of the study has already been told to you by Chaitra. I will not go into the details of that. Now, reproducibility of the research is very essential, and therefore the multicentric studies nowadays have better acceptance than one single center study, because one single center study has chances of manipulation of data, whereas multicentral studies generally do not have chances of manipulation of data. Now, peer review is another important part of the research method, and peer review can never be unbiased. Your personal liking or disliking of the researcher will always show up in some way or the other. But anyone who is reviewing must be honest enough to keep his personal feelings apart from the scientific thought. If the scientific thought is good, and even if he is my staunch enemy, I'll accept it. That is important. That is what builds the credibility of the journal and credibility of the reviewer also. Now, assessing scientific temperaments in the department and getting the colleagues' concurrence is very essential. Supposing you are having a big department with people involved in research. Some people may be good researchers, but they may not be good in the surgical skills or in clinical assessment. Some people may be good in clinical skills, but they may not be good at surgery. They may not be good at research. So it's important for the person who is heading the institute to isolate these 2 people or to separate these 2 people and use the clinical skills and clinical surgical skills of the person to feed into the research group. Because the clinical skills and clinical surgery then generates enough funds. And that fund, you need to divert part of it towards the research material. Now, sometimes it is important also for the journal editor to inspect the raw data and analytics, particularly the methods and cloud computing and non-patent algorithms, etc., that has to be carefully analyzed. Now, conflict of interest, if there is any, should be declared honestly by all the authors or primary investigators or others. Now, more the funding needed for the study, more will be the conflict of interest, which has already been discussed. Now, comply with Helsinki regulations as much as possible. Each institute will maintain its own ethics committee, and standards and periodic unannounced inspection of the research by the ethics committee is very essential part of the credible research. Now, the ethics committee should also inspect the facilities and the labs and the instrument available to confirm the capacity for the study. Now, genuine informed consent is obtained from the patients and check with the random patient. For example, you can bring a patient and say, did you have stem cell taken for this study? You will say, what is stem cell? I don't even know anything about it. Then you know the credibility falls flat. So all these things are part of the study, improving the credibility of your research. Now, what does the improved credibility to do with day-to-day life? Well, it has something to do with day-to-day life, because what is the conclusion drawn from the study is applicable to many patients. And if it is a wrong set of data and wrong set of conclusions manipulated, then you will get wrong results. And if it is applied, because the statistic shows that the study is good, p-value 0.5, whatever, then you will lead to a lot of problems. The most important point in any credible research is to make sure that this research has not been copied. See, we have seen a number of cases where they have cooked up reports, they have copied other research, they have copied their own research from other already published papers. And all these things, it becomes very essential to improve the credibility of the journal also. So not just a plagiarism check, which only checks by looking at the number of words that are written or type of words that are written, but also it's important to check whether the whole research concept has been copied from somewhere else. And for example, in smaller journals, you may get away with publishing something which is not properly checked. But that does not mean that it cannot be checked. It can be checked nowadays with proper plagiarism check for research. Now, all these things, as I said, is essential because the important point is research separates unknown from the known. So you don't want to cause a lot of damage to the unknown people. So that is why it's important to have credibility of the research, which is dependent on a number of factors, not just one factor. It's dependent on the funds, it is dependent on the institute, it is dependent on the researcher, and it is dependent on the integrity of the researcher, and the integrity of the entire department is also dependent on this, because the research can be interdependent. One part of the ophthalmology sector may send the same patient to a different branch in ophthalmology as a part of research. And it's important that both of them should have the same thinking. Otherwise, it will lead to a lot of conflicts. So a proper, credible research is essential for improving the standard of treatment. Otherwise, we would have all been doing couching even today for cataract. Thank you.
Thank you so much, sir. I think very valid points raised. And in fact, let us go back to the basic premise that we had started with. It was for 1 year, we didn't really think in terms of what it was till, Nicholas Wade wrote this rather famous or infamous article where he says that, Yunnan is 1,500 kilometers from Wuhan. That's half the length of India, and there's not a single case in between. And then, inside Wuhan, there's a Russian scientist who points out that, there are these cases which initially appear to dot along the metro, which is connecting the Institute of Virology with the airport. And then Nicholas Wade talks in terms of, there being no other variants being there. So all these were smoking guns, and they were all, dismissed as conspiracy theories. We still don't know what is true and what is not. But yes, what it has actually gone on and done is that it has blown the lid of, because science today is no longer limited to, what is being done in one institute or being replicated in another place within the same country, or it is, across the globe, and the organizations are getting connected across the globe. So you have, an institution in US getting connected with another institution in Ireland, with another institution in China. And I think, yes, we are talking in terms of, so for biomedical research, yes, the standards have been good. And by and large, they have actually served the purpose for which they were. Now, the question which has started arising is that, are they adequate? And the way the world has suffered over the past 1 year, Do you feel, sir, what do you think is the way forward? I think we'll ask the way forward. I think Dr. Honawar is.
Yes, I think he is doing the.
Yeah, how to handle it, the transparency and the way forward. And then, sir, I'll come back to you over a panel discussion over it. Dr.
See,
Honawar,
this
please.
is where this is where the conflict of interest and bias in the viral epidemic, in the viral pandemic, we saw the conflict of interest and bias both. So that is why the research was meaningless.
So I think that is what we need to address. We need to look at credible mechanisms. Dr. Honawar is the editor of the Indian Journal of Ophthalmology, and he handles conflict of interest, research integrity on a day-to-day basis, and that is why he is today the best person to answer some of these rather complicated questions that we have. So, Dr. Honawar, over to you for transparency in handling these conflict of interest cases.
Thank you, Jatinder. Am I audible? Is my slide visible?
Yes, sir. Yes, sir.
All right. So transparency is supposed to be the new objectivity. It was always so, but then the realization has happened very much in the recent past. This is something that William Stead has said. Judgment and integrity are the two hallmarks of professionalism. Conflict of interest, bias, and dishonesty represent a spectrum, spectrum which is ranging from conflict of interest to dishonesty. That's sometimes a very wide spectrum, sometimes it's a narrow spectrum, and you don't know when you're treading from a mere conflict of interest or mere small bias to dishonesty. And if you tread into the zone of dishonesty, then everything becomes bad. I would, as an opening statement, say that every professional has a conflict of interest. If we didn't have, we wouldn't publish. Why are we publishing after all? We have conflict of interest. But then that should not be dishonest, or that should not create bias in our work and in our results and what we progress. There are internal conflict of interest, which are personal interest, reputation, or career advancement, which are all obviously part of life, and external, which are generally financial and business interests. So this, if you consider this as a weighing scale, professional responsibility on one side and personal interest on the other side, bias comes somewhere in between. So you can always, little bit of bias can tilt it in this favor, personal interest. So that is where you have to tread a very thin line. As Chaitra was pointing out earlier, conflict of interest may be present or perceived. Sometimes just because a particular researcher is from an organization which may not have good reputation of being fair, conflict of interest may be perceived, but the researcher himself may be very honest. So you should always take it from case-to-case basis and not generalize between researchers and organizations. Bias may be conscious or subconscious. That means I may not even realize that I'm biased, but I may be biased because the article may be written by one of my friends or by an institute which I value very much. And dishonesty also can be sometimes very unintentional. You may not even realize that you're being dishonest. The spectrum is actually from being very benignly innocent to extremely criminal, and very mild bias to something that can cause harm because of the results of your research with others adapting. Now, how serious is this issue? This is a very nice publication which analyzed how many authors actually know about conflict of interest. Only about 12% knew about it. And of those, only 50% provided that information. That means less than 1% of authors actually provided correct information about conflict of interest. And what about the reviewers? Only 30% knew about it. And 92% of those 30% actually bothered about conflict of interest, and others really didn't bother. And editorial committee board, about 75% knew a little bit about it, but not really bothered. So it can happen at any level. Researchers, organizations which sponsor research, editors, reviewers, readers, publishers, and advertisers. So it's a kind of a multifactorial issue. And readers are generally in the middle of all this. They get ultimately affected by conflict of interest by any of the stakeholders. Among researchers, it is former, current, or future commercial interests, sponsorships that they may be receiving, or some of the support that they may have received, directly related or unrelated to grants or to individuals or organizations, and business interests of individuals and the family. So at the level of the researcher or the person who is writing the manuscript and publishing it, or the institute that is publishing it, complete disclosure is the key. You can have conflict of interest, but unless you completely disclose even the minute of your conflicts of interest, you're not being transparent. So what has come about is this new form, ICMJE form 2021 COI form, which has integrated all the areas that are perceived as conflicts of interest during the phase that the work was done, over 3 years prior to submission, and other relationships and activities over 3 years prior to submission. But that doesn't mean that if you had some interest 5 years ago, or you may likely have such similar interest 5 years hence, it is not conflict of interest. But even the most recent ICMG recommendation limits it to a window period of 3 years. So that is something that needs to work on. And what they have come out is a harmonized COI disclosure. This involves almost all the data that one can gather and submit. And there is also now a website which publicly reports payouts. Even if you have received $1,000 as a travel grant, and if a particular company which has provided you that grant has not provided it in cash and it has accounted it, that means a public limited company or a private limited company which has robust accounting system in place has to account the money that has been paid out. It's not been paid in cash. Then you can use this Conway, which is a global disclosure system, to know how much a particular author or how much a particular researcher has received and whether it is in the limits. $15,000 is a current limit. They are talking about raising it to $25,000 because of inflation. But in India, there is no financial limit. There is absolutely no rule to say that if you have received an amount which is less than a particular ceiling level, you will not come under it. There is absolutely no rule. So we're not governed by any solid laws. And as far as the peer reviews are concerned, there is obviously going to be some bias in peer review, which may be positive or negative, depending on if you know the authors or the institution. Sometimes it is easy to guess the authors. For example, if somebody looks at an article on topotecan in intravitreal injection in retinoblastoma, they would guess only 2 or 3 people in the country might have written on that topic, because it's not something that everybody does. So it is easy to guess authors and the institutes, even if it is double-blinded review. But at the same time, by not having double-blinded, you would have given everybody an open kind of information about the authors and the institutes. The bias may become stronger. So what we do is a double-blinded review. Now, as far as the editors are concerned, again, there could be a positive or a negative bias on the study topic itself, bias against the authors in the institute, which is very easy to not guess. Editors know about it because it is not blinded to the editors, at least the editor-in-chief, it is not blinded unless he wants to blind himself to it, to that information. That is possible. But at the time of submission, you know who are the authors and which are the institutes. So it may give an unfair advantage by substantive advance information to some of the members of the editorial board who may have conflicting research interests. So ultimately, it may affect the assignment of reviewers, speed in which the review is conducted. Sometimes the reviews are stalled by several months so that people who have conflict of interest within the editorial board can gather enough data and publish it even ahead of this particular publication in a different journal maybe. So it may even affect the final decision. So all these members of the editorial board have a shared responsibility. It is a collective decision making, but at the same time, if the editorial board knows that a particular member of the editorial board has a conflict of interest, he or she may be asked to recuse himself or herself from the review process. Ultimately, we have to separate commerce and science. If I have commercial interest, for example, in IGO, we are asked to raise funds for the journal, which is part of the editorial responsibilities. But at the same time, if I'm asking a particular company for money, and if that company asks me to publish, would I have zero conflict of interest? Well, that situation hasn't arisen so far, but it is something which is a question that that may come up very soon. If some company is paying me 50 lakhs, would I be totally immune from having conflict of interest? Well, that is something that we need to think about. So we have to actually separate science from commerce, and advertisement should be in the domain of the publisher, which we try to do without much success. But AI has to change to do it. Advertisements have to be governed by a separate section of individuals, whereas science should be left to the editorial board. Now, resolution of conflict of interest, obviously, it is an arbitration board which has to hear all the sides. It is not one view. It is not a bilateral view. It is not even a trilateral view. It is a 360-degree view, because what authors may think is justified, editors may not think so, and some of the other stakeholders, sometimes it's the readers that complain to the editor, may think totally differently. So unless a 360-degree view is taken, resolution may not be possible, which fair resolution may not be possible. So there has to be a scientific arbitration board that has to be looking into it in a very transparent manner, and then giving its decision. So till then, we have disclosure statements, conflict of interest policy, which is transparent, and double-blind peer review, which take care of most of these conflicts. But if something happens which passes through all these stages and still is going to affect the results of the study in a big way, then arbitration board and withdrawal of the study, etc., has to happen. So finally, I would say that transparency is the key, and we need to provide factual and complete information and let the readers take a decision. If somebody has a conflict of interest, it doesn't mean that the review will be unfavorable or the manuscript will not be published. It will be published with all the due information provided to the readers, and readers will have to take all that into consideration when they make a decision about the change in management or change in diagnosis. Thank you.
Amazing, Dr. Anawar. You spot on time. Fantastic presentation. So is it that it is just the disclosure statement and the way we are handling and the double-blinded peer review? Is it the easiest way out that we have evolved? Because the lowest lying fruit, so to say, we disclose it, we leave it to the reader to decide.
Yes. I mean, there is nothing else we can do at this point in time without complicating the process of publication. The process of doing research is very, very complicated. In fact, if I want to write a grant, I need a whole department to help me. Otherwise, as a clinician, I can't write a grant currently. Whereas 10 years ago, I could write a grant very easily overnight. Now, that is not possible because you need at least 10 registrations for individuals and institutes to write a good Indo-American grant, right? So that has become very difficult. Now, after having passed through all those stages, final aspect is publication. If there are so many difficulties in the process of publication itself, nobody would want to publish. I struggled submitting an article to BJO just because patients' 2 eyes had to be shown. That was a manuscript where 2 eyes had to be shown. This had passed all the stages of review, but final phase of acceptance, they said that they need a ink-signed consent from the patient, which was impossible to get because the patient was lost for follow-up. One particular patient, rest of them, we had it, right? So
that was actually part of their anonymization guide, and that anonymization guide was exactly what we copied for artificial intelligence. And then we realized that, you see, the machine can segment the data in so many ways that what we're trying to say as blinded and anonymized is not anonymized any longer. Dr. Santan Gopal was about to make a point.
Yeah, I have 2 points to make actually. Now, because of this number crunching, has it put off people from genuinely conducting a research? Because the number crunching will always find a fault in what you have done. it's easy to find the fault. But to what extent that particular fault will affect the final results and will change the direction of treatment is important to understand. Okay, before 1990, 1991, that time, this number crunching wasn't there. There was no question of evidence-based medicine, this evidence-based statistics, this should be fast, this should be, there was nothing like that.
There was only eminence-based medicine.
Huh?
There was only eminence-based medicine.
Medicine.
He said no evidence-based, only prominent.
Yeah, but that did not mean that they were genuinely honest researchers. You understand the point? So, to an extent, the statistical probability of the study being correct has put in your research path a lot of hurdles, which has increased the expenditure on any particular research. And therefore, it has become imperative that everyone applies before even research for a research grant. Now, the research grant application itself takes 2 to 3 weeks to prepare and make the relevant data available to them. We have applied for so many research grants from our company. It takes a lot of time to apply for research grant and for them to grant. And they don't give you the money immediately. They will say, do it for 3 months, we will come and inspect, and after 3 months, we'll give you this amount of money. Now, but we may have more expenses during those 3 months than during the entire research project. So these are all the issues which will put off a normal person with a lot of research interest to conduct any research. Even though there should be some kind of research grants available for genuinely interested researchers, which should be identified by the various editors of the journals who have seen them work before. And they can say, yes, he does relatively honest work.
Some sort of a rating system you suggest, sir?
I think it should be there.
And so the funny thing is that no matter what we've, the number of protocols that we've brought in, see, it is statistically, if you're looking only at the statistical analysis and reading the report, it is not possible to identify whether it is, fabrication of the results, whether it is, falsification of the results, or it is, okay, plagiarism we can detect. But that is why you see the entire gamut of transparency and research integrity has become so important, that you see the person who is doing it, we should have faith in what he has seen and what he is reporting is true. I think Dr. Chaitra wanted to make some point.
Yeah, so just one quick point from Dr. Honava's presentation. I think all of us are very fearful of disclosure. We worry that the minute we disclose something that we worked on, or we are, on the panel of something, we worried that, the paper will not go through or our research will not get published. I mean, that's some fear that all of us have, and, we still live with it. I think what he brought about is a very important point that irrespective of what you're working on, if it does not have a direct bearing on what you're writing, or if you have disclosed everything and come clean, I think both readers and reviewers are quite, intelligent enough to take that into consideration and take it forward. I don't think we should be fearful. Worse is hiding. I think coming clean is much, much better.
I think I absolutely agree with you, because in the past, the golden rule, they used to say that, the rule of the thumb is, if you are in doubt about a disclosure, you should disclose it. And if you feel that, and the test for it was that, any reasonable reader, having read your report and later he comes to know that, there was this particular association or a financial obligation that you had, then he would feel that you had misled or you had cheated that person. Then that is where you should disclose. Now, then I really had a query about, about actually, I used to wonder why they came up with this idea that let us have, a particular limit put to it. I think we have Dr. Namrata. We have with us Professor
So
Namrata
sorry.
Sharma.
I'm very sorry for joining in late.
No, ma'am. Thank
You
you
can
so
take your
much.
mask off.
I am sitting in a place where others are also. Who's this? Take your mask off.
Me.
So, ma'am is going to talk about publication misconduct. Ma'am, I'm sorry we took the liberty of starting the session.
No, I'm sorry that I joined in late because.
Ma'am, we had a very fruitful discussion. So, let us talk about publication misconduct, and we come back to our discussions immediately after that.
I think we are done with time. Namrata has time to speak.
Ma'am, publication misconduct.
I am sure you would have already, talked about this. And I would be very briefly touching on this because I know everybody knows about this over here, especially learned people like Dr. Jatinder Bali, Dr. Chaitra, Dr. Sugandhi Gopal. I can see everybody, I'm sure.
That's Dr. Santan Gopal, ma'am. Alter ego.
I was wondering. I thought
his screen name.
No, he named himself as he's a feminist now.
Yeah, a feminist to the core.
That's madam's name. He's using her Zoom account.
So I'll be talking about. I will be talking to you about publication misconduct, how to deal with it, and publication misconduct. If you see, I think who knows it better than all of you sitting here, because you've all dealt with the journals day in and day out. And I'm sure Santosh would have given you examples, real examples, of all these, and he can tell us also about them. So there can be data manipulations, there can be problems in manuscript preparation and authorship and conflicted interest. And data manipulations can be restricted to fabrication, falsification, image manipulation, manuscript preparation to plagiarism, self-citations, salami publications, and the theft of an idea or a concept, and authorship and conflicted interests to inappropriate authorship, duplicate or multiple submissions, overlapping publications, and conflict of interest. I'm sure even the best of the journals which are there in the whole world, even though they might be checking for everything, still I'm sure they may be missing out something as far as the misconduct part is concerned. How common is it? 2% scientists admit to having falsified or fabricated data at least once, and 34% scientists admit to questionable research practice. And it puts all at risk, whether they are co-authors, because there's a risk of being barred from the journal, institution, because it brings disrepute to the establishment and risk of being barred, journal editorial board, because there's a liability towards the rest of the scientific community itself, because it can get misled to build on someone's erroneous research, wastage of time and funds, and also because the funding agency also loses confidence in you and doesn't want to fund some similar projects because of misconduct which has been done by others, and patients, because it puts all the patient at risk of harmful medical practices based on publication. So falsification and fabrication can be there. For instance, this is the Excel sheet and somebody wants to change the data. So you put higher figures here so that you skew your averages or your medians to the side that you want to. So this is populated by extrapolation to suit the desired outcomes, and selective omission of data of entry occurs and inflate the statistical results to give false impression of a significant outcome. Then this is just to give examples of how studies have been retracted because fabrication can ruin lives of many. Study on the hot debate of COVID-19 management regime published in Lancet on May 22, 2020. And authors were unable to provide the source of data to the editors when asked, so this article was retracted subsequently. And by this time, it had impacted the management of many COVID-19 patients all over the world, right in the middle of the pandemic, including, I think, almost all of us who would have taken chloroquine. And management guidelines are heavily influenced by this study, and they changed overnight. So many clinicians, they raised doubts based on independent internal data from their respective hospitals worldwide, and that is why this study was retracted. Now, another example of the study, New England Journal of Medicine, which was retracted, and this was on cardiovascular disease, drug therapy, and mortality in COVID-19. Subsequently, an article that used data from the same SurgiSphere database and which was authored by some of the same individuals was also retracted from the New England Journal of Medicine. Now, image manipulation can occur, and in a study of 20,000 published papers in a decade, 3.8% were found to have potentially fraudulent images. Any editing that selectively changes a part of the image is potentially causing manipulation. So you can crop the image and change it, or brightness and contrast can be adjusted to change it, or selective enhancement can be done to support the proposed hypothesis, or color adjustment can be done. And what to talk of anybody else, I would have made this presentation from somewhere on the internet only. So even that you can say is taken from bits and pieces from here and there. So color adjustment can be done, and then cloning can also be done, which is not there previously. So again, the implications are that it affects the research integrity and is considered a misconduct, impacts the reproducibility of the outcome, and may result in paper retraction, damaged reputation, career, etc. So tackling data and image manipulations, technology, I think there is another whole new technology which can tackle this and can find out about the image manipulations. And this is a separate field again. Then there are tools to pick up the data manipulation. Always ask for the raw data files. I'm sure Santosh must be asking them in Indian Journal of Ophthalmology. Always reapply appropriate statistics when looking at questionable data sheet. Then there are statistical tools to detect falsified, fabricated data. And who would know it, who would know it better than Dr. Jatinder Bali, how to do this? And of course, there's a role of artificial intelligence. And there are tools which can detect data fabrication. Then there are forensic tools also, like forensic droplets, which actually pick up quickly after examination of these scientific images if there are any falsifications that have happened. Then you have Adobe Bridge and ImageJ software, which can also pick up these image manipulations. Then what are the punitive actions that can be taken? It is mandatory that retraction be published on a numbered page of the same journal by the editor. And there are other actions like debarring the authors, debarring the institution, notifying the institution, flagging their subsequent submissions for thorough review, and notify the trial registry or the regulatory body regarding repeated misconducts. Then plagiarism, according to one study, was most rampant in the low-income countries. Lack of resources and manpower leads to callous literature review and poor manuscript writing, and includes others concepts and ideas, appropriation, and self-citations. This is one study which showed the same, that from the lower income group countries, plagiarism chances are higher. Then, of course, there's salami slicing, and there are even several big institutions and several big groups who publish, who do big data analysis, or who do studies with randomized control studies with large numbers, and then do salami slicing of the publications. So one you would get would be, the preliminary results, then you will get the long-term results of the same, and then you would get bits and pieces, various parameters. They would discuss visual acuity in one publication, and they would discuss, for instance, if it's related to graft survival in the other. So finally, the study is sent for publications in different journals, and it has been split basically. Of course, we do realize that when you do the salami slicing of publications, the whole importance of the study goes away. It loses its importance, it becomes weak. But yes, people do this salami slicing of publications, which is quite rampant. Then self-citation is another aspect of plagiarism. I think there's nothing wrong with it, but it is done to increase the impact of own published work. And if I think suitable and appropriate, it can be done, but sometimes may give erroneous impression of being well-read author when you take it in totality, and helps the author falsely show validation of the own work. So you conduct one study, then you do salami slice publication of multiple articles, then cite one article in the other. And this is a vicious cycle which goes on, and it gives the impression of work being well accepted by peers, which actually may be one single work, even when you are trying to increase your citation. Then tools to keep plagiarism in check is always self-check with 2 or more plagiarism softwares. Keep zero acceptance for the percentage of plagiarism. Cite others' authors' work appropriately and adequately. Self-citations may be picked up by the editorial team. And there has to be action from the editors. When you think that it is their article should be sent back for revision. I think Santosh can tell us how many he has sent back and how many he has rejected for the want of plagiarism. Tackling authorship and conflicted interests is also another aspect. You have gifted authorship when it is given to a person who has not contributed enough. Ghost authorship not awarded to a person who has worked significantly for the study and manuscript preparation. And there may be conflicting interests, which may include associations that may be deemed to influence and bias an author, which include financial associations, direct gain from the study, consulting honorariums, share in a company involved with the medical equipment or devices being evaluated, or intellectual property rights. So tackling authorship and conflicting interests is also important. So as corresponding author, always give authorship in order of degree of contribution, outline role of everyone involved, ensure all authors contribute adequately, personally ensure that all authors disclose their conflict of interest, and always err on the side of disclosing more. As editor, I think Santosh will be able to tell better. I will not elaborate on this. So thank you very much for your kind attention.
Thank you so much, ma'am. Ma'am, actually, we've also run out of time. It's 3:30.
Okay.
We actually wanted to carry
You would have already covered all this, I'm sure, in your session.
Ma'am, we had a very interesting talk going on at that moment in time, and I think we'll carry it on sometime later, because the next session the people are already here. So I beg leave, and I really apologize. It was a rather interesting talk going on. We still have to hear Dr. Gopal and Dr. Honavar on the issue. Thank you so much, sir. Thank you, Dr. Chaitra. Thank you, Namrata ma'am.
Thank you.
Thank you, doctors, for the wonderful session. Thank you, Dr. Jatindra, for chairing the session so well.
Warm welcome to the speakers.
We now begin with our next session. To begin with our next session, do we have Dr. Subhash? We'll wait for another 2 to 3 minutes, and then we'll begin the session.
बाकी ऑनलाइन ज्वाइन कर रहे हैं सर, डॉक्टर किरण धनोट। हाँ
सर, इसमें कौन से?
ये हॉल है
Good afternoon, ma'am. Ma'am, where's doctor? Good afternoon, sir. Ma'am, unmute करिए, Dr. Bhanot.
Okay, should I start?
Good afternoon.
नहीं, ma'am, अभी. And is that Dr. Goswami there?
Sir, good afternoon, sir.
सर थोड़ा सा ये फेस के ऊपर लाइट ऑन करिए सर, मतलब फेस द लाइट.
Okay.
थोड़ा सा डार्क आ रहा है सर फेस.
तो काले लोग हैं.
Okay, and ma'am, where's Dr. Farooqi?
Yes, good morning. Good afternoon, Dr. Jitendra. Can you hear me?
Okay. Yeah, we can hear you, but we can't see you.
Okay, you want to see me also? Fine.
Obviously.
So you're there. Yeah.
Program है इसमें?
Yeah, it's okay.
Yeah, perfectly okay. So let's start. कौन है first speaker?
Does anybody have the program, the copy of the program?
Actually, we have just got the program, but not the schedule at who are the speakers. So I will request that we can start one by one. We can start with
Dr. Bhanot.
Yes, Dr. Bhanot. So it is basically we are addressing here the issues related to government doctors. That part is there, but it is not like that. Everyone can have the advantage to listen and to applicable in their life and their practice. So can we start, Dr. Bhanot? Please start your. Thank you.
Good afternoon. So principal theories for pathogenesis of glaucomatous optic neuropathy have been mechanical, vascular, and biochemical. The existence of NTG cannot be explained by the theory alone, and reducing IOP is 100% not effective in halting the disease. The vascular etiology attempts to explain on the basis of reduced ocular perfusion pressure, faulty vascular autoregulation, and loss of neurovascular coupling. In 1970, Harry defined glaucoma as a disease wherein the normal balance between the IOP and the blood pressure and the choroidal vessels supplying the disc and retrolamina part of the optic nerve is disturbed. So vascular concept is supported by association of glaucomatous optic neuropathy with arterial hypertension, oblique hypotension, CVD, migraine, vasospasm, and other circulatory disorders. OPP refers to the pressure available to drive blood through the intraocular vasculature, the degree of perfusion being influenced by resistance to flow, which is a function of the vessel caliber or the vessel tone. Now, ocular perfusion pressure is equal to difference between the pressure in the CRA and CRB. In the eye, the venous pressure roughly equals IOP. So OPP is arterial pressure minus IOP. So OPP can be defined as mean systolic and diastolic OPP. Mean ocular perfusion pressure is measured as 2/3 of the mean arterial pressure minus IOP. Mean arterial pressure being diastolic blood pressure, 1/3 systolic BP minus diastolic BP. Similarly, SOPP is systemic systolic BP minus IOP, and DOPP being systemic diastolic BP minus IOP. DOPP is especially useful in displaying the lowest OPP values. Now, a good perfusion pressure, a good perfusion pressure depends on complex regulation process that balances both BP and IOP. Decreased OPP is a risk factor for prevalence, incidence, and progression of glaucoma. Death of the retinal ganglion cells appears to involve primary and secondary insult by the reduced OPP, and abnormal autoregulation and neurovascular coupling may lead to the RG cell death. Several studies have suggested association between vascular factors and glaucoma. Accordingly, hypoperfusion of the optic disc contributes to the glaucomatous damage, and of several studies indicating vascular risk in glaucoma, BP and IOP are the most studied. As such, dealing with the concept of OPP and BP at the same time is pertinent. So a number of studies have been done regarding this subject, and most of them have concluded there is strong association of OAG prevalence with low ocular perfusion pressure, low diastolic BP less than 60, a high systolic BP more than 170. So low diastolic BP in this patient suffer from low OPP at the optic nerve head, and individuals with less than 30 mg DOPP are at 6-fold greater risk of developing glaucoma. With the high systolic BP, there's a decrease in the vessel diameter, leading to arteriosclerosis and compromising the vascular autoregulation. So the hypothesis indicates that low OPP can occur secondary to a high IOP, low or high BP, and atherosclerosis. Although clinicians have known for decades that IOP varies throughout the 24-hour period, only recently have circadian patterns been detected for other factors like systemic BP, OPP, and the ocular blood flow. Now, systolic and diastolic BP decline or dips during sleep between 2 to 4 a.m. due to decrease in the sympathetic systemic activity. In nocturnal, physiological dipping can occur in 2/3 of the healthy individuals. Non-dippers, if the nocturnal decline is absent or blunted, and they are extreme dippers where the fall is more than 15 to 20%. So excessive dipping is associated with development or progression of glaucoma. Now, a reduction in both OPP and ocular blood flow occur during sleep. There's significant lower diastolic blood pressure at 4 a.m. and significantly lower DOPPs were seen in POG patients during the whole night from midnight to 6 a.m. So circadian MOPP may another be an important risk factor, and it is hypothesized that chronic repetitive circadian ocular blood flow changes could result in accumulative ischemia and reperfusion, manifesting in the form of RNFL damage and visual field deterioration. So understanding circadian variation in OPP is important for assessing the risk of glaucoma progression. Hence the importance of 24-hour monitoring of BP and IOP simultaneously. And Choi et al. Have identified circadian OPP fluctuation as the most important risk factor for glaucoma severity. Now, blood flow is autoregulated to maintain a constant flow despite fluctuation in perfusion pressure. Vascular dysregulation is hypothesized to be involved, at least in some cases of glaucoma, especially normotensive glaucomas. In an autoregulated vascular bed, changes in perfusion pressure do not translate into changes in blood flow, but in a non-autoregulated vascular bed, even small changes in perfusion pressure may lead to changes in the blood flow. So a low systemic BP combined with elevated IOP will reduce the OPP at the optic nerve head, reducing blood flow in eyes with an impaired autoregulatory system, leading to ischemic damage to the axons. So reduction in OPP below critical level, structural changes in arterioles due to hypertension, nocturnal dippers, and effect of antihypertensives add to the glaucomatous damage. The American Heart Association recommends aggressive control of blood pressure in patients with CAD and in patients with left ventricular dysfunction. However, aggressive treatment of systemic hypertension was deleterious for glaucoma patients, and over-treatment could worsen the glaucoma. In addition, a compromised vascular system can also influence glaucomatous damage because inability of the eye to maintain consistent and adequate perfusion during pharmacologically lowered BP in susceptible individuals. The topical beta blockers plus patients on systemic beta blockers, it was seen they had greater nocturnal IOP dips. The Rotterdam eye study also revealed increased risk with calcium channel antagonist. So in AGMs, they decrease IOP, they should increase the OPP, but the effect was found to be variable. So subgroups in which the OPP measurement should be considered are normal tension glaucoma, eyes with optic disc hemorrhage, patients with progression at low IOP, history of low BP, multiple systemic antihypertensives, and patients with nocturnal hypotension. So although IOP is considered the main risk factor in development and progression of glaucoma, decreasing IOP is not 100% effective in halting the progression of disease. OPP as a risk factor for development and progression is an important current topic in glaucoma research. Balance between intraocular pressure and BP, influenced by the autoregulatory mechanism, is partly what determines if an individual will develop optic nerve damage. Relevant clinical history, 24-hour BP and IOP monitoring were indicated, and identify and treat the systemic factors which contribute to development and worsening of the neuropathy, like systemic hypertension, postural hypotension, low DOPP, hyperlipidemia, and sleep apnea. So despite limitations on reliability in measuring OPP, There is continued interest in measurement of this parameter due to potential therapeutic intervention in patients with documented low OPP and continuous disease progression. Thank you.
Thank you, Dr. Kiran, for this wonderful session. I would like to call upon Dr. Anu for the next session. Dr. Anu, do we have you?
Okay, I'll be.
Yes, Dr. Anu, please share the screen.
Is it Dr. Goswami there?
Yes. Just a minute.
Good afternoon.
Good afternoon, sir.
If there is an issue, we can start with Dr. Anand. I welcome Dr. Anand, who is the session chair here. And okay, have you managed to share, sir?
Yes.
Okay, so we'll go on with Dr. Goswami.
Is it visible now?
Yes, please.
So, good evening, chairpersons and esteemed colleagues. Today, I thank DOS for including this topic, which is but in general also. Now, all know mucormycosis management involves multiple clinicians, chiefly physicians, ENT surgeons, ophthalmologists, and often dental and plastic surgeons. And we also have microbiologists and intensivists in the background. Now, how does an ophthalmic service doctor fit in the scheme of things? See, most of service doctors are working in a multi-specialty setting. And this setting means that the patient is either referred to eye surgeon for opinion regarding COVID-related issues, or the patient directly presents to the ophthalmologist and has to be appropriately referred on timely basis for management. So let us do a background check on the established facts on mucormycosis and explore the involvement of eye surgeon in the management. Mucormycosis is not a new disease and has been first described by Poltoff in 1885 and has wrongly been popularized as black fungus by Indian media. It has a prevalence of 14 cases per lakh individuals, and worldwide, India has contributed to 81% of COVID-associated rhino-orbital cerebral mucormycosis. The term black fungus is used for demataceous fungi. As we can see in this chart, this is a different group, while mucormycosis is caused by Rhizopus and mucor, which are part of Mucorales group. And this Rhizopus is responsible for 90% of all rhino-orbital cerebral mucormycosis cases, which is introduced into the body through inhalation of spores. We all know the risk factors. I will not elaborate. Then the recent spurt in mucormycosis cases in COVID-19 setting, multiple theories have been put forward, and hypoxia, acidosis, hyperglycemic state are thought to be risk factors for this kind of presentation, along with increased use of voriconazole, broad spectrum antibiotics, and decompensated pulmonary function. Mucosal injury due to prolonged mechanical ventilation, high flow oxygen also leads to endothelial damage and helps in spores getting attached to that endothelium. Although a study by Sen et al. In 2021 has shown that 13% of mucormycosis associated with COVID-19 did not receive any form of steroids. Pathophysiology tells us that as after the spores are inhaled, they are lodged either in the lungs or in the turbinates, and in a healthy individual, they are neutralized by phagocytosis and neutrophils. But in an immunocompromised person, from the paranasal sinuses, they reach the central nervous system through the cribriform plate or the orbit and the eye, or via the blood vessels, causing morbidity and mortality. Now, this condition can have varied clinical presentation depending on the site of involvement, and it can be in form of rhino-orbital cerebral mucormycosis, pulmonary, cutaneous, GI, disseminated, or a localized variety. We are mainly concerned with the rhino-orbital cerebral mucormycosis, and typically the symptoms It starts with non-specific symptoms such as nasal congestion, blockage, along with dark blood taste or purulent rhinorrhea, along with sinus tenderness and headache. Late symptoms are facial or periorbital pain and or swelling, blurred vision, redness of eye, chemosis, diplopia, and proptosis. Loss of vision, dental pain, and fever and malaise, they appear late. Now, in the COVID-19 associated rhinoorbital setting, what we have found is that orbital or the facial pain can be primary symptom. And this has been found to happen in 23% of cases, followed by orbital or facial edema as a symptom in 21% and loss of vision in 19%. So eye surgeon may be the first clinician to encounter this kind of a presentation or rhinoorbital cerebral. And once the patient is seen by an eye surgeon, immediately the patient should be referred to ENT for confirmation of diagnosis by deep nasal swab and QH or a calculated void staining. So there lies the importance of eye surgeon, and vice versa. If a physician who is treating a COVID-19 patient or a person who a COVID-19 patient has been discharged but is in the critical period of 6 weeks, he develops any orbital or facial pain or orbital facial edema, a loss of vision, and reports to the physician, the patient should be referred to ENT first for diagnosis of ruling out mucormycosis rather than to eye surgeon. And after it has been proved that does not have any mucormycosis, then comes the role of eye surgeon. Similarly, the signs which are typically described are black eschar around the nose, palate, or around orbit, and periorbital edema, proptosis, and ophthalmoplegia. These once disappear means their involvement of orbit along with apex, and oral cavity also may show blackish discoloration, numbness of teeth, loosening of teeth. Mental status changes once they occur indicate the intracranial invasion. Now, the point to remember is that by the time signs of orbital apex involvement develop, it is often too late to save the patient's vision or even the patient's eye or life. And another important point is that time from onset of initial symptoms to late symptoms and signs may be as short as 1 day. So there lies the importance of quick diagnosis and referral. And similarly, in a COVID-19 associated setting, we found that the primary sign may be periocular or facial edema in 33% of cases, followed by loss of vision in 21% of cases. And any of these signs, if a physician finds out while he's treating any of the patients, should alert for possible development of rhinoorbital mucormycosis and appropriately should be referred, and vice versa. Now, this is just a summary of how the things unfold in case of ophthalmic involvement, where from the nasal mucosa or turbinates, normally these spores and the fungus reaches through the maxillary sinus or the ethmoid, but even it has been reported to directly come from nasolacrimal duct or the blood vessels to the orbit, and leading to proptosis, painful ophthalmoplegia, and deteriorating vision. This classification has been posed, which is likely to help in the management. It is simple. Stage 1 is involvement of nasal mucosa. Stage 2 is involvement of paranasal sinuses, followed by stage 3 involvement of orbit, and finally involvement of CNS. So as the clinical symptoms and signs unfold, you can always figure out how to manage. The importance is that every clinician should know the warning signs in a patient who is being treated or has recently been treated with COVID-19, that is within 6 weeks. And the warning signs are unilateral nasal block, nasal discharge, redness of eyes, orbital and retroorbital pain, reappearance of fever, headache associated with nausea and vomiting, and altered sensorium. Now, whenever these signs are encountered either by an eye surgeon or by a physician, the role of ENT surgeon is of prime importance, because many times a deep nasal swab is the most important modality for a quick diagnosis. And management approach has to be very aggressive. Otherwise, this disease can progress rapidly, leading to morbidity and mortality. And for quick diagnosis, always we have this swab staining. And CT and MRI also help in delineate the extent of infection and guide the surgical debridement as per the needs. Then once mucormycosis has been ruled out, eye surgeon should rule out the presence of any orbital cellulitis, cavernous sinus thrombosis, or a rapidly growing orbital tumor. Treatment we all know, So the take-home message is that ophthalmologist in a multi-specialty setting is a vital link between different clinicians in the appropriate referral and management of a COVID-associated mucormycosis. Then clinicians from different specialties should be sensitized about atypical presentations and keep high index of suspicion for quick diagnosis of this condition. And physicians and ENT surgeons and ophthalmologists should work in tandem to reduce the morbidity and mortality, and timely ENT or ophthalmic consultation by physician and vice versa is crucial for management of this condition. Thank you.
Thank you, Dr. Anup, for the wonderful session. Begin with the next session, I would please request Dr. Faruqi to unmute himself and share the screen. Dr. Faruqi.
Okay, I'll be speaking on the hard cataract, the degree and conquer technique with the difference. Now, virtually every step of cataract surgery is more difficult in the setting of a mature and Bunsen cataract. The three main concerns to enhance and improve our safety with the challenge in the hard cataract cases are the thermal damage to the incision due to excessive heat production, the endothelial trauma, and the capsular rupture. To prevent the incisional wound burn, the longitudinal ultrasonic frequency power modulation has to be used in hyperpulse mode with the reduced duty cycle, or the burst mode with the reduced burst rate, or one can use the rotational ultrasound modality in the continuous mode, such as OZL IP and the ellipse, which generates lesser heat and prevents the frequent blockage. For reducing the endothelial cell loss, one should maximize the anterior chamber depth. Dispersive retentive viscoadaptive device such as Viscoat is more likely to be retained as a protective layer against endothelium. The cohesive viscoadaptive device of high molecular weight hyaluronic acid often are flushed within seconds. Repeatedly recoating the endothelium with a dispersive OBD during the FICO is a necessity. Now, conceptually, Chang has divided the chopping technique into two general categories: the horizontal or peripheral technique, of which the Nagara technique is a classical example, and the vertical or central technique. Now, the limitation of horizontal chopping for the hard leathery cataract is there's a relative inability to transect thicker luminescent nuclei. In the absence of an epinuclear shell, there will be insufficient space in the peripheral bag for the chopper. The horizontally directed path of the chopper may not be deep enough to sever the leathery posterior plate of an ultra-luminescent nucleus. In the conventional chopping techniques, although they are popular, but there remains a challenge in certain cases. The complete fragmentation is not easy because the posterior leathery quality in the hard nucleus prevents fragment separation. And the separated nuclear piece is hard and pointed, and with minimal or no epinucleus, this can result in PCR during its maneuvering and emulsification. Now, to offset the limitations of the conventional nucleus divide technique, the nucleus splitting 6 to 8 pieces is performed all around the circumference, circumferentially separating the epinucleus from the dense endonuclear core, isolating and emulsifying the endonuclear core, thereby decreasing volume of the central nucleus and conquering the remaining. And this technique is called the decrease and conquer. Now, nucleus splitting is usually done either by the direct chop from Nagahara or by the FICO quick chop by Dillman. But however, in these both techniques, the chopped fragment remains tightly wedged like jigsaw pieces, and it is difficult to separate. So, however, in the technique of the Critter quick chop by Dillman or Critter chop technique by Vanati, this is my preferred technique in the cataract. Approximately 5 mm central Critter is formed. Debulking central portion of the nucleus allows additional space. It prevents jamming of the nuclear fragments after chopping, and it becomes easier to separate the remaining hard endonucleus core. The Fico-quick chop technique by Dillman using the sharp vertical chopper is the preferred technique for splitting the nucleus. And I prefer this Chang vertical chopper. It's a sharp vertical chopper and the tip stays central to the capsular axis. It obviates the need to move the chopped instrument out of the periphery. For splitting of the nucleus, in this step, the complete fragmentation of the nucleus is not required. Separation of the epinucleus from the nucleus core is enough to proceed to the next step. In the conventional chopping, complete fragmentation of the lens by cracking of the radial suture line is done. However, in this technique of decrease and conquer, the separation of the loosely adhesive laminative structure isolating the endonucleus is done. Now, circumferential separation of the epinucleus from the endonucleus is done all around. And after doing the circumferential separation is completed, the unfragmented hard nucleus core is lifted up, separating from the epinucleus. And this isolated core is then emulsified. The remaining nuclear material usually stays within the epinuclear shell. Remaining nuclear material is separated from the epinuclear shell and emulsified step by step all around circumferentially. And finally, the epinuclear shell is easily removed. Unlike the conventional chopping, no sharp edges of the Brunson fragment are present. Hence, the fear of tearing the PCR is not there. Now, for prevention of the post-ocular surgeon, for the last phase, the last Brunson nuclear fragment is removed under viscoelastic injected behind the nuclear fragment. To prevent the post-ocular surge, one should decrease the pre-stick vacuum. And this is the small video which I'm showing. Here, already the creta has been done, and the hard nucleus is being separated from the epinucleus. One needs to note that we are not cracking down to the center. The posterior plate is not being cracked, and the epinucleus plate is being allowed to stay in place. This lets the bag remain distended, and it becomes very easy to separate all the hard nucleus circumferentially, piece by piece, and not bothering to separate or crack the posterior plate completely. It's not required in this case. Now just note the whole of the epinucleus plate is present circumferentially like a bowl, and this lets the capsule remain distended. So it prevents the posterior capsule from coming into the port of the Fico probe, thereby decreasing the chances of the PC tear. Also, there are no sharp edges of any nuclear or hard nuclear fragment. This again decreases the chance of tear. And after this is done, the whole nuclear plate, the epinucleus plate will be, now this is the final hard nuclear that is being done. Now all that is left is the epinuclear plate. Now this is just lifted up and very easily aspirated and emulsified. Now, since there are no hard nuclear fragments left behind, there is no fear of the posterior capsule tear occur. So it's about to be completed. Posterior capsule is continuously being protected by this epinuclear plate, and this is being aspirated and emulsified. Now, the advantage of decreasing concave does not require complete fragmentation. The separation is quite easy even in the dense Brunson nucleus. It is performed along the loosely adhesive laminative zone. Now, instead of the radial suture plane, which is often densely packed at the posterior epinucleus. Now, because of the different cleavage plane, it is free from entanglement with the leathery posterior bridged nucleus. It reduces the risk of the posterior capsule disruption because of the epinuclear cushion protecting the posterior capsule continuously. And it minimizes the lateral movement for separation of chopped nuclear fragment and reduces the mechanical stress to the zonules. Thank you.
Huh. It was really hard to place, and I think your chopper you are using, what kind of the bend is there? It is 1 millimeter or 1.5 millimeter or 2 millimeter? I mean, it looks like large.
For a hard nucleus, 1 millimeter will be too small. 1.5 is the minimum that you should use.
Okay. Fine. So you feel it is okay. There is no danger to touching the endothelium with this in any case.
1.5 will not touch anything neutropenia.
Okay. And PCs also remain protected.
PC is continuously remaining protected because of the epinuclear plate being continuously there right till the end. And there are no hard nuclear fragments. We can really pose a threat to the posterior capsule at any stage.
Okay. Fine.
So what is the vac you're using, sir?
I use 450 vacuum to hold. That's enough.
Okay. Thank you, Dr. Farki. Our next speaker is Dr. Naveen Neeraj. Is it here? Dr. Naveen Neeraj?
Yes.
So Dr. Naveen is going to speak on the urban and rural divide on ophthalmic services delivery. I think it's very important. So Dr. Naveen Neeraj, please. Can I share or have you shared your slides over here?
Yes, sir. I'm just sharing.
Yeah. Next speaker is Dr. Anil Tamar. Anil Tamar is here? Okay, fine.
And I'm able to share the screen, sir.
You have to go on share screen, green button. And
now we can see you.
No.
Yeah. Now go full screen slideshow.
Yeah.
Either you can do an F5 or a slideshow. Yeah, good, great.
Yeah.
That's it.
Yes, sir. Good afternoon, dignitaries on the dais and the friends. I'm grateful that DOS has given me this opportunity to put forth my views. My today's topic is urban-rural divide in ophthalmic services delivery. Why and what, and is there a solution? As you know, visual impairment is a major global health concern and is associated with the diminished quality of the life. And even the Andhra Pradesh eye study has indicated that it leads to decreased survival expectancy in middle-aged and elderly populations. Recent global data shows that there are 36 million blind all over the world and 217 million medially visually impaired and severe visually impaired. And rapid assessment survey of 14 districts in the country has taken the cover of eye services at around 70%. The ophthalmic population ratio in rural area is less than the urban area. But the cataract surgery rate looks promising at 5,000 because WHO recommends 3,000 to 6,000 as an ideal. But the matter of concern is the cataract surgery coverage, which includes the percentage of the operable cataract patients who get operated. It's only at 75%. So the recent challenge is that we have improved CSR, but absolute number of blindness or visual impairment cases are increasing because of factors like aging populations, increased growth spurt. There is changing trend in the causes of blindness, and there is increased prevalence of non-communicable eye diseases like diabetic retinopathy, ARMD, glaucoma, etc. And there is increased prevalence of cataract and refractive errors as well. There are certain barriers which prevents population to even attain the existing eye care facilities, which the table has been shown the different causes in the table on the right. The table below indicates that the surgical outcome in the rural area is poorer than the urban area. So we need an universal eye health coverage, which has been defined by WHO as ensuring all the people to have access to needed promotive, preventive, and curative rehabilitative health services of sufficient quality, and at the same time ensuring that the people do not suffer financial hardship when paying for these services. WHO Global Action Plan 2014 to 19 plans to reduce prevalence of visual impairment by 25% by 2020. So the Global Sight Initiative has come into action. It is an international network of hospitals and international NGOs working together to scale up the sustainable eye care services. There are mental hospitals all over the world. In India, there are 6 mental hospitals which have been given there in the name, namely Arvind Eye Care, LV Prasad Eye Institute, Dr. Shop, etc. They have established 321 vision centers at the end of March 2018 and have ensured an annual output of more than 1.3 million outpatient. So the primary eye care services may be an ideal services is ensures equity, community participation, intersectoral collaboration, and long-term sustainability for wider impact on the health communities. But its scope varies with the regions. As you see in the screen, in most of the part of the Africa, PC is managed by primary health workers. It is PC is their additional work while managing this. In developed countries like UK, USA, etc., it is managed by a specialized person like optometrist. While in Indian government sector, it is managed by paramedical ophthalmic personnel, which is posted at the PHC, and it works in the lab with the medical officers there. The private sector in India works through vision technicians. And so the main purpose of these primary health workers or specialized persons or PMOs is to do refraction, dispense spectacles, early diagnosis of the common ailments, and referral of the cases. So primary eye care may be of two types. It may be fixed centers or it may be mobile PC. Fixed centers may be integrated with the PHC as we see in Indian government sectors. There are standalone PC centers also by the private sectors like LVPI, ACS also. The integrated PHC system work through a PMO, I already told you, through PHC, but these standalone PC work independently and they are supported by the village health guides. The another type of PC is the mobile PC, which includes mobile vans, which may be used for reaching underserved areas, and it is managed by ophthalmic technicians. It is basically used for identify diabetic retinopathy cases, and even they provide laser therapy. Teleophthalmology, as you know, helps in the patient to consult the specialist without traveling. So the concept of vision center, the NPCBVI as well as the mental hospitals or GSI recommend a permanent eye care facility in the community, which serves as the first point of interference between the population and the eye care delivery. This is usually managed by a locally recruited, well-trained technicians, and they follow all the core works like refraction, dispensing spectacles, etc., diagnosis of common eye diseases and referral cases. There is another staff who looks after the administrative activities and carry out the outreach programs. The target population has been fixed at 50,000, and it is networked with the secondary eye care institutions, preferably within the distance of 50 kilometers to take care of the referrals. So the recommendation is the vision centers, the target population. The existing recommendation is the 50,000 population, but it has been appreciated that it should not be fixed, and it should be open to all the villages around the vision centers who have ease to access the vision center within the time frame. The human resource is also important to be managed and their training. Basically, the PC is managed by the vision technicians. Their course has been accredited by National Skill Development Council, but there is no definite policy for their training. Many hospitals, they use 3 months, some use for 12 months training post vision course. So a definite policy needs to be formulated. One most important aspect is the retention of the staff, and the different strategies must be there, like career progression and to the motivated visual technicians, recruitment of female staffs already established in the community, etc., as taken by the Arvind Ike. Important aspect is the leveraging of technology. Technology always ensures efficiency and improving quality. So how we can use it? In maintaining the EMRs and sending reminders, SMS will help in follow-up in the glaucoma and ER cases. Mapping software may be used. It helps in the outreach and awareness raising activities by mapping critical patient statistics, and teleophthalmology is obvious. So another recommendation is the financial sustainability, which is a major factor in any program to financial sustainability usually means that the expenditure must be equal to or less than the revenues. The expenditure is usually from the rent of the facility, the salary paid, and the consumables and utilities. Sources of the revenue include the consulting fees, spectacles, medicines, etc. So it has been recommended by the NPCA to take a nominal user fee. Prescription and sales of spectacles may be considered as the major source of revenue in the financial sustainability. Supply chain management is another aspect. So one key factor for successful supply chain management is the knowledge of the customer's socioeconomic status and his ability to pay. Mapping software will help in this direction also. Proper selection of suppliers is also help in reducing the cost. One component of the supply chain is also the transportation of the patient. The patients who are transported from the vision center to the referral centers. So their cost is to be managed, and in the private sector, it is managed by the payment of the service. Monitoring of the quality control is also important. Different KPIs has to be developed, like
Dr. Neeraj, your time is up.
Okay, suggested this is last slide. Coming to patient records, etc. The monitoring of the quality control maybe have clinical factors and non-clinical factors as well. The clinical factors like review of the records, and the non-clinical factors like review of the finances, etc. So at the end, I conclude that there are solutions to bridge the gap of the urban-rural divide, but it needs a committed and leadership with the vision. Thank you.
Neeraj, and I think we'll shift the discussion to after the presentations. I call upon Dr. Anand, who's heading the railway. He is a well-known retina surgeon, and he is also heading the operations of the railways in Delhi. And he's going to be talking to us from immense clinical experience and immense administrative experience about purchase procedures and development of specifications. He has been a star speaker in many of our workshops on purchase procedures, and people consult him from across the country for ophthalmic equipment and specifications. Dr. Anand, please.
Thank you. Thank you, Dr. Bali. Hi, sir. I think, friends, I'm actually talking about the problems faced by the doctors working in the government sector. And I have purposely selected this topic. I mean, the things are like that every officer working in the government sector has to purchase some kind of equipment. And ophthalmologists are number one because technology is changing every day and is getting advanced every day. I will request you that if you find anything, you can interrupt me in between. A specification for any equipment is important government sector in one way. If we compare to the private practitioner, that in private practitioner, the practitioner doctor is the whole sole authority to decide the kind of equipment to purchase, the cost, the specification, everything, and he is not supposed to give explanation to anyone. In government sector, the basic problem, the basic fact is this, that we are spending government money, and government had its own way to explain and justify any procurement. Either we spend 1 rupee or we spend 1 crore. So what is the specification? Suppose you have to plan to procure any equipment to your hospital. You have to define one thing, the cost, which you have to project on the basis of market, on the basis of last accepted rate of that equipment in any of the government hospital, or like the what you call the estimate submitted by the company, is, if at all it is a very new item. Say what kind of estimate with the undertaking that this is the lowest quoted rate in any of the government. So specification required to all purchase. Sometimes we call statement of work. So agar hum puchenge what is the definition of specification, it is a statement of work what you are going to get it. It should be clear, it should be complete, It should be unambiguous. It should contain the technical and essential characteristic of your requirement. I mean, you should not leave anything beyond the scope of specification writing. Specification can be defined as a statement of need also. What you really need. You need a angiographic camera, or you need a camera along with the ICG facility, or you need only a camera which can give you the color photograph. So it has to be very clear about the need. We can simple, or it can be simple, or it can be complex. Your requirement may be different. Success of procurement relies on specification. Forget it that this things will come on after the tender process, and only at the last the specification has to justify it, explained, and finalized. So specification is a part of goods or service or any future contract. Like, it's not like that you procure the equipment today with the said specification, but if you want any services from the supplier, you have to include that in the contract. Now, who can make it? So, person who is familiar with project or equipment. Suppose you are procuring equipment, government wants that only ophthalmologist should make it, not an store officer or not an IS officer should make it. Expert in technical and scientific matters. The person, we suppose that he should have the total knowledge technically and scientific use of that equipment, and he should be a required qualification, because that can be challenged. Suppose tomorrow I reject one equipment on the basis of specification, it can be challenged by the party, that the person who is assessing and giving the specification is not well qualified. And third, the willingness. The person should be ready and he should be available. The writing of a specification include 4 things. It should be clarity, accuracy, repetition, and logic. So these are the 4 parts any specification you design. Clarity. It should be simple language. Like, you should not use any complex language or the word which have too many meanings of it. So it should be absolutely simplest language you can do it. Avoid any legalized or complex scientific jargon. I mean, it should be avoided. So the person who is supplying you the material, dealing in the trade, is not be a qualified scientist. So the matter should be totally understandable to him, that what material he has to procure, supplied, and for what he has to quote the rate. Selected words should be ensure clear meaning and unambiguous. Avoid alternatives. I mean, आप oblique करके कोई specification ना लिखें. Accuracy. You should ensure consistency and accuracy by using some simple terms throughout. You have to, like, the terms should be like that. It is to point out the total accuracy of a requirement. Avoid generalization, unclear words, broad spectrum. ये सब की जगह specification नहीं होती है. You should be very accurate, very directly pointed out your need and requirement and the functions. Repetition. It should not be done. Repetition is inadvisable. Like, you should not use one kind of thing repeatedly in second paragraph or fourth paragraph or other part of the specification designing. It is legally dangerous. Avoid erroneous information. So whatever information you are submitting, you are designing, it should be correct. You have to ensure first. If an issue is covered at one place, don't repeat it in any other space of specification. Logic. Logical numbering system of all headings. ये तो हम लोग हर फाइल में चलाते हैं कि your all page should be numbered well. It should be in the priority list, that all high priority items should be marked at number 1, number 2, and that, like that. No cross reference. No brand name. Mind it here. You cannot go, I want Mercedes Benz. You have to write a car if you want to have purchase. Not tailor-made. Tailor-made means you should not make the specification designed to point only one kind of product that I can purchase only Jais because they have this particular kind of specification. It is illegal. It is illogical. So specification can be functional. You have to see the equipment functionality, define the function required of equipment, will be used for narrating the scope of work. This enables the supplier to provide a solution. So once you write the functional specification, you require ICG, you require OCT, you require the FFA. So if you write all these function requirements, the supplier will understand what kind of machine you are looking for, right? So it is very important. Performance, you can definitely look the effectivity of it. There are a lot of way how to get the performance from the old supplier, from the market background, from the users. I mean, that's up to you. So it defines the task, and do not desire the method of achieving the desired by result. I mean, this desired is wrong. You should take the performance at your own, and you are ultimately solely responsible for if at all it is not performed in future. It happened. So then the technical specifications, they come, they are very important. Technical and physical, both. I mean, it requires weight, color, size, shape, 1 piece, 2 piece, 10 piece. So they all are technical specifications. Measurement dimensions, you have to look for the measurement dimensions because the ultimately machine has to install somewhere. You should not have a very bulky machine to be installed in a small room. So all these things you have to technically specify. You have to make the design. You want a compact machine, you want a multi-piece machine or whatever. And requirement of energy etc. आपके यहाँ कैसी बिजली आती है, आपके यहाँ किस तरह की सप्लाई है. अगर कोई देता है कि मेरी मशीन 6 वोल्ट पर काम करती है, आपके सप्लाई नहीं है. So all these things you have to make it very clear, right? So in conclusion, we can say the specification writing is a crucial step in procurement. It should cover all your needs. Vital parameters should be highlighted. It should not design to a particular equipment or brand in your mind. So specification should be broad. Certification should be avoided unless it is properly justified. And I mean to say that you cannot write that I need a machine which is FDA approved or US FDA. So they are the some of the sheet on in the heads you can design and write down the specification. And here I have just given an example. Suppose you are looking for a car, what I was talking to you, how you made the specification. That you will purchase a Mercedes. So what kind of specification you will design, that you will point out in broadly the Mercedes requirement and not the Maruti. So one of my boss normally told me, Dr. Bali, I will just narrate you the story. He said, suppose specification writing is that you are looking to purchase a guy, लेकिन आपने उसको लिख दिया कि sir, I need an animal who can have the capacity of milk, 4 legs, tail, must take grass, 2 horn. Mind it, we are not going to purchase a guy. You are going to purchase a bakri. So this is the things which happen. So you should be expert in writing and expert in designing the specifications that what you are thinking you purchase. Thank you very much.
So that was what was passing through my mind. Normally it is that, your size ki machine ka ya us machine ki specification bana do. So really, we'll be discussing more about it immediately after we're through with the presentations.
Yeah. So the next speaker is Dr. Bali, and I request he should come with his presentation. Can you you have the presentation, Dr. Bali? Just share his slides over here.
Good evening, ladies and gentlemen, the chair, the co-chairman, and the speakers and everyone who has joined us. Thank you so much for joining us. I want to thank the Delhi Ophthalmology Society, its office bearers, the executive, to have given me this opportunity to talk to you about some things that they did not teach us in the medical school. And the topic is today reading into data and understanding data to make decisions. So far as financial disclosures are concerned, the only thing related to this particular presentation is a book that I have written on biostatistics and research methods. Now, why are we talking about taking decisions based on data? Now, normally what happens is, as professionals, we take decisions. Suppose I were to ask you, which of these ones would you choose to be the most dangerous? 3 deaths less than the other group, a 75% reduction in mortality, 300% or a 3-fold increase in mortality compared to the other group. So suppose I were to ask you, which is the most dangerous amongst them? Would you go with the third one? So that is exactly what we would do. All of us would do that. Now, whenever we are looking at, I will take you back to how we've been reading our research and how we've been taking decisions in our files. The first thing we read is the abstract, then we go to the conclusions, then some of us will come back to the discussions. Fewer still will come to the materials and methods. And the last thing, very few will really go into the results. In the files, you will look at the first paragraph, you will look at the third paragraph, and then you will be looking at the last paragraph. That is how we take decisions. Now, I will explain to you why it is a little fallacious. Now, look at the data that is there right at the bottom, 4 deaths and 1 death in 2 groups. And now I'll take you back to the previous one. 3 deaths less than the other group. So there are 3 deaths less than the other group. 75% reduction in mortality. Look at it. What has happened is there is just a 75% reduction in mortality. But if I look at it from a low base with respect to group B, so it is a 300% or a 3-fold increase in mortality rate. So what does it tell us? It tells us that it is very easy to change the way we explain the results. And that is part of marketing, that is part of product monograms, and that is why you need to look at the figures, because figures don't lie. And I'm not talking about the figures on top, I'm talking more about figures at the bottom. It does not hurt to look at the figures. The question that comes to our mind is it really difficult to read the figures? And because most of us stopped, working with mathematics in class 10, we feel that statistics is difficult. But day in and day out, you're using biometry, you are using corneal topography, you're using visual field analysis. All these are extremely advanced statistical analysis. Do you ever feel out of place when you're using them? And of course, the question would be no, isn't it, sir? Yeah. So it is simply a question of getting used to looking into the results. Now, whenever we are looking at any study, suppose, why do we conduct a study? When we want, the purpose of any scientific work or any study is to find out some truth which is there in the population. Now, suppose I'm the principal of a particular school and I want to install some sort of a door or some swing in my school, and I want to know, what is the height of kids in my school and whether they're right-handed or left-handed. So what do? I simply stand at the gate of my institution and I close my eyes and I randomly pick up, out of 1,000 kids, I pick up, maybe 40, 50 kids, and I measure them. That's exactly. So what have I done? I've actually designed a study, I've implemented it, and now I'll draw some inference out of it. So when we do a study, what we do is we make some measurements, and from those findings, we will get some truth or some values of these 50 people. And then I want to use some tests to understand whether or not this is reflective of what is the truth in the general population. Now, suppose in these 50 kids that I had, I've measured their height. So I have 50 values of height, and then I have right hand, left hand. So basically, data can be of 2 types. It can be qualitative based on name. Left-handed or right-handed is based on name, nominal. Or it could be in some order, mild, moderate, severe, grade 1, grade 2, grade 3. Or it could be discrete, that is, it takes whole number values, number of deaths, number of births. That means it cannot be, you cannot have half a death, you cannot have half a birth. Or it could assume some values which could lie between those numbers and go into decimal places, like the weight or like the height in centimeters or something of that sort. Now, why that is important is because today we are using computers to calculate all these, and the computer would say 0 and 1 for left and right-handed. And if I say, give me the mean, it will tell me the mean is 0.4, but it is absolutely meaningless and it is incorrect also. So you have to understand that whenever there is any data, now you have these 50 values that you have. How do you explain it to somebody else? Or suppose you have to pick up a phone and tell me what is the height of kids in your school. So you will obviously want to describe the data to somebody on the other end. That is what we do in all scientific things, and that is what we are required to do even in our day-to-day decision making. So whenever you have to look at any data, you need one value to describe all those 50 values. So what do? You want to pick up the most central value, which is representative of the entire data set. So the first thing you want to see is, do we have some sort of a laser pointer? So, okay, great. So, so I pick up a central value that tells me, that describes the data. That could be average, mean, median, mode, whatever. Then I want to see how far from this central value is the distribution of all those values. Is it between 1 and 10, or is it between 0 and 100? So that is going to have a bearing on. So if this spread is more, and in another situation the spread is less, then don't compare the two situations, because that means the data is different. Then you want to look at the shape of the data. How do you look at the shape of the data? You draw something called a histogram. So in the computer, there is something called a histogram function. It will give you the histogram. And then, of course, look for any outliers. That means all these values are, 0, 1, 2, 3, 4, 7, 8. And then you have one value which is 200. So it is lying somewhere out here. Now, if you were to take because most values are actually your average, otherwise would be something like, 6 or 7. But if you take this 200 into account, now your value is 28. So it is erroneous. So you want to look at the outliers also, because there are ways and means of neglecting or overcoming the effect of these outliers. So we've already described, to describe our data, what have we used? The central value, which could be the mean, the median, the mode. And then, of course, to see the spread. The spread could be, minimum to maximum, which is the range, or it could be something called standard deviation, which is one of the particular, it is in that what we're doing is we take it from the center to one of the side and we square it. And then we take a square root of it after dividing it by n. Now, depending on the type of variable we had, you see, if it is a nominal variable like right, left, pick up the one which is most common, mode, and describe it as most common thing was this. If it is following an order, use the median and interquartile ranges. If the data is not skewed, then you use mean. And if you have an outlier, again, what you do is arrange your data from top to bottom in an ascending or a descending order and pick up the centralmost value. That is going to rule out the effect of the outlier that is there. So now what we have done is we have described the central value, which is the mean, and we have described how far from the center it is spread. Next thing we want to define is, of course, this is one of the ways of showing it. When you have multiple studies to show, then we prefer to use something called box plots. This is the median. This is the top 75%, bottom 25%. And these two whiskers are drawn to the most extreme points that are there. Longer the whisker, more the skew, right? Now we want to look at the shape. How do you look at the shape? You draw something called a histogram. And for our purposes, just look whether or not it is normal, a bell-shaped distribution, or it is not a bell-shaped distribution. There are other types of distributions also, which I have listed in my book, and they are not really very, we don't have time to actually cover them. Now, so a bell-shaped distribution simply means it's a normal curve. Then look at it whether most of the values are on one side of the mean or the other side of the mean. This can be given by something called a coefficient of skewness. Sometimes it will be mentioned. Not really necessary. At this level, you can decide which statistical tests to employ. And if the two histograms look similar in shape, you can actually compare one against the other. And then, of course, is something called the kurtosis, which simply says whether all the values are bunched up close together. For example, it is 4, 5, 6, 4, 5, 6, 5 is the mean, and 4 to 6 is the range. Or it could be 0, 1, 2, 3, 4, 7, 10. Again, 4 is your mean, but it is really spread out. That is a platykurtic. That means lower the kurtosis means it is a flat curve. Higher the kurtosis, it is a leptokurtic. So whenever you have to describe data, you have to look at 4 different parameters. We have the central sterile supply unit, CSSU or CSSD. So you look at the center, you look at the spread, you look at the shape, and you look at any unusual features that are there. And when you read the reports, using the statistical methods, you can only understand what is there in the data. You cannot understand whether the validation is correct, whether it is original, it is relevant, and all these require assessment using other means. And then, of course, is the question of, the primary and secondary outcomes. In most of our studies, what happens is it says that, something was done for measuring the IOL power. And then it says we also found that the effective lens position was this. Now that is a secondary outcome. The study was powered to answer the primary outcome. So if the secondary outcome may or may not actually meet the level of significance, the level of statistical rigor that is required. So look for studies which are answering your question as a primary outcome measure, not as a secondary outcome measure. When it is out as a secondary outcome measure, you have to go back and calculate the power of the study and its significance. And then, of course, is this table that we have, which all of us are already aware of. What you need to do is you need to look at it whether it is before and after analysis. That means it is paired data. And if it is not before and after, they are independent groups, then it is unpaired data. Then see if there are 2 groups or more than 2 groups. More than 2 groups, ANOVA or repeated measure ANOVA. If it is parametric, that means if it is a normal, it is a bell-shaped curve that you've got. Otherwise, go and use Kruskal-Wallis or Friedman test. And for two groups, you can use Z-test, T-test, or Mann-Whitney. And for paired data, what we have is the paired T-test or the Wilcoxon matched pair signed rank test. Association simply means how X changes with Y, and there are different type of correlation coefficients. So I think with that, I come to the end of my presentation. And basic idea is when you have to take calls on whether it is significant, whether the usual questions we'll be answering is whether 2 types of data are equal to each other, whether one is better than the other, whether one is more than the other group, or whether before and after there has been a change. And all that is going to be covered using this simple descriptives and the set of tests that we've talked of. Thank you.
Thank you, Dr. Bali. Gallery चला दिए? सुनो dear.
Gallery on करिए.
So I think with this talk we come to the end of the session. I will request the audience or the participant, if they have any question, I think we have surplus time, we can discuss. So please come forward if anybody have anything to be explained.
So I have a small queries. Normally what happens is when we go out for whatever we need to purchase.
Yeah.
What happens is we've already got one or the other type of machine that we have on mind. So is there any way to ensure that we get only, good quality machines? Because we may make general specifications. How do we ensure that, we get good quality machines which give good results?
this is the common problem, Dr. Bali. I tell you, the all people who are involved in procurement or establishing department government sector, they always have this big question in front of them. Definitely, suppose I will give an example. What you want to say that suppose you are looking for a good microscope. We all know that as far as microscope is concerned, we all look for the Zeiss microscope, right? It is our experience of what we have seen, what we have learned, that we should go for it. But in government sector, you should not forget it is government money. And here you have to design the specification in which you will purchase the Zeiss only. So what I personally feel that, okay, look here, when I was looking for purchase a flax, the machine cost around 4.5 crore. And there are 5 kind of machine available in the market. And we have to look for that. We should have a machine which is hassle-free, which have our best result, which is quite bear a new technology here. And it amount was quite high. So these cases beyond 1 crore are subject to scrutiny at any level by the Department of Vigilance, or maybe few cases file may be picked up by the CBI. So, I mean, that kind of pressure is there. So what I suggest, even a lot of people who are working in my hospital and they are designing these specs, that you should study your requirement first. Fine. Then you should study the specification of equal level of other equipment. Like अगर मैं कहूँ जायज है तो आप देख लीजिए कि जायज के साथ साथ जो दूसरे, जैसे अभी मैं देख रहा था कि एल्कॉन का एक माइक्रोस्कोप था which was almost equal to जायज. So you just read their specification properly. Here a government say you cannot write the brand name, you cannot write the certification. अगर मैं लिखूँ I need जायज microscope, this your application request will be immediately rejected by anyone. So you say, sir, I want a microscope which is having like this picture, which is no other have. Suppose they are having the one specification which is beared only by the Zeiss microscope. They say we have an inbuilt inverter. So if you write that we want a microscope which is not of Zeiss, but they should have inbuilt inverter of inside, this also will not be, because other microscopes are not having it. It means you are targeting a one particular kind of brand without writing it. So it will also turn down. The store department will not be rejected. So what I suggest is you read the specification of equal brand, maybe costlier to that, and make a summary or table of all, and then you select the specification. Take it. It is very time consuming. You should spend maximum time to design the specification after going through the total literature of available instrument and hire to that.
So as I take it, what sir means is basically when you have to design the specification, A, take time, B, read all the alternatives that are there.
Yes.
And then, because most of us are going to face this problem that this is a tailor-made specification,
yeah,
or it is so general that you're going to get something which is going to be of questionable value.
देखिए आप अगर माइक्रोस्कोप डिजाइन करते हैं और आप प्रॉपर उसको जैसे करते हैं कि आपने लिखा कि मिनिमम वैल्यू शुड बी लाइक पिक्सल में कहता हूं कि इट शुड बी, मुझे पता है जायज का पिक्सल मान लीजिए 400 है, यू शुड राइट दैट इट शुड बी 400 और मोर. सपोज यू नो कि इन मार्केट दी माइक्रोस्कोप अवेलेबल जिनका पिक्सल 500 भी है, 600 भी है, बट उनकी कॉस्ट 2.5 करोड़ है. नो प्रॉब्लम. You are having 80 lakh in your pocket. You write that I want 40 pixel or more. So somebody will quote it. Sir, my microscope having the pixel of my say 500, but my cost is around 1.5 crore. No problem. I am not making tailor-made. I am giving a broad spectrum to all the competitors which are existing in the market, but I have to go to the lowest one. So you have to keep in mind that L1 को overlook नहीं कर सकते आप. And for that, suppose कल को आप उस चीज को भूल जाते हैं. Appa Swami make the things in your quote a tender. You specification wise you cannot rule out. You have to purchase it.
So, so there are many intangibles also which really cannot go into. For example, you know, if I were to extrapolate it to, let's say, the camera qualities, so you would have, you know, a Redmi clicking a photograph, and you would have say a OnePlus clicking a photograph, similar sensors but different results, or maybe a Google Pixel clicking it. So how do we define those intangibles? How do we build the intangibles into the specification?
Only one way, that you have to study all similar kind of equipment very deeply. And you have to pick up the specification of your use in that. And that has to be incorporated in your specification designing. Okay, sir, I want these 25 specification in which these things should be existing. ठीक है ना? तो वो उसमें कोई चैलेंज नहीं है. Now the second thing is going on, make in India. आप इसको बोल नहीं सकते. Government wants that maximum things to be purchased from make in India. आपको make in India का डेप्थ नहीं मालूम होगा. I will tell you. Make in India means that you will procure anything made in India only. No. You can purchase any equipment, designed, manufactured, created out of the country, but with one condition, that firm has to submit a certificate that in manufacturing, selling, storing, conveying and transporting, we are spending around 20% cost of this equipment in this country. This is the catch.
So basically the offset clause has to be there.
Offset clause is there. So मान लो उसने यहाँ 20 आदमी रखे हुए हैं, उसका यहाँ वेयर हाउस है, वो यहाँ उसको स्टोर करती है, उनकी सैलरी देती है, तो कहती है अगर मैं 10 इक्विपमेंट बेचता हूँ यहाँ, तो मेरी सैलरी और इक्विपमेंट वेयर हाउस का कॉस्ट और ट्रांसपोर्ट खर्चा मिला के ये मशीन की कॉस्ट का 20% है जो हिंदुस्तान गवर्नमेंट को हम खर्चा करते हैं. एंड योर प्रोजेक्ट इज थ्रू.
So I think that's I think that's a very good there's a very good thing that has been done. So that means the country the company now has some interest in the country.
Yeah.
And the government has some control over the company. So that's a very good.
Government has kept the door open. They are not restricted. Okay, you will go for this only. They have given the free hand. Like in my department, right from the slit lamp, right from the lasers, right from the cameras and the phaco machine and the microscope and the flags, all are imported. Mind it, I am using all imported lens free of cost to my patient. I am not purchasing anything from India. So, I mean, that is possible. In government sector, it is very much possible. Only thing, you have to understand the system. You have to understand the rules existing, what government want. Otherwise, the file advanced stage se वापस आ जाती है कि your proposal is rejected.
No, so that is why, you know, you are the poster boy for all of us, and you are the go-to man. Dr. Goswami wants to say something.
Beautiful presentation, sir, and excellent discussion. I have faced a lot of problems like this.
All of us are, sir, all of us.
Exactly. And one is like, what about proprietary buying? There is another concept of proprietary.
Yes, propriety basically is not my problem. Propriety is the problem of the supplier, the manufacturer. Manufacturer has to submit a certificate along with this code that this product with these specifications no other firm is making in any part of the world. And that is very, very important because proprietary certification is always exist at the higher level. In railway, only the HAG officer can sign the proprietary item. So they will go for all the details, all the Google's material, whether this is any company, we give the, आजकल तो जेम पे होता है सारा आपको मालूम है कि any company having the similar product or not. It's very difficult to define nowadays. So now we have not gone for a single item which is proprietary. We always go for the class laid down specification. We said, sir, we don't need any proprietary item. We need this particular item which has this specification. So that come एक तो power आपके हाथ में रही, दूसरे आदमी के हाथ में नहीं है. तीसरा proprietary item are always subject to be checked by anyone. If somebody complain कि sir this particular doctor has made a proprietary certificate, some firm has submitted wrong certificate, you are unnecessary trapped to answer variety of questions to the higher authority. So basically, I strongly suggest you that don't go for proprietary item. We don't need. Only go for the design specification which are available in that. It may be proprietary or not proprietary, we are not concerned.
And so the best person is here, this side.
Just for your information, I am purchasing the equipment more than 100 crore in my Northern Railway. I am heading the Northern Railway and number of doctors are making not I, every specialty. You may not believe that one of my surgeons sent me a specification and requirement of a robotic surgical robot. And sir, that cost around 56 crore.
Oh.
And consumable 1,50,000 per surgery. हमने उसको बुलाया है डॉक्टर को. हमने कहा आप पहले तो अपनी इंटेंशन बता दें. और दूसरा, आपने कभी असम देखा है? नेक्स्ट मंथ यू विल बी ट्रांसफर टू असम. You will forget what is robot and what is R. So people are having this kind of ambition. Forget this कि सरकार ने देना है तो 200 करोड़ का मांग लो. फिर उसने कहा सर आपने तो फ्लैक्स मांगा था. हमने कहा that is time I had the link with the minister. हमने रिक्वेस्ट किया उनसे. Now I am purchasing Ismail very soon. The only thing that your file, once the file leave your table, it is subject to be studied by anyone, and they will read line by line, word by word, and they can give you 4 question here कि सर आपने ये फाइल बनाई थी, आपने ये लिखा था, प्लीज इनको एक्सप्लेन कर दीजिए. इफ यू आर नॉट एबल, यू आर सब्जेक्ट टू टेकन. सो मेरा कहना है कि पहले तो आप जितने इक्विपमेंट लेना चाहते हैं उस कैडर के, उस रेंज के सारे इक्विपमेंट का स्पेसिफिकेशन पढ़ें और उनकी एक टेबल बना लें 1 से लेके 25 तक. और उसमें से फिर आपको जो जिस इंस्ट्रूमेंट को आप टारगेट कर रहे हैं, कोशिश करें कि उससे हायर वाले का ही स्पेसिफिकेशन उसमें अंदर डालें. आप मान लें आप जायज ले रहे हैं तो जायज से एडवांस जितने माइक्रोस्कोप है उनके स्पेसिफिकेशन आप उसमें ऐड कर दीजिए. यू विल गेट द जायज. दैट इज द ओनली थिंग. और उसको खुद अपने फ्रेंड से खुद भी उसको ऑडिट करिए कि इसमें ऐसा कोई पॉइंट तो नहीं चला गया कि जिसपे कोई लोकल कंपनी भी डाल के हमारे गले में प्रॉब्लम डाल दे.
And so there was this thing we used to use, US FDA approval, CE approval. Now all those are
गवर्नमेंट ऑफ इंडिया ने 400 रुपए निकाले हुए हैं. US FDA approval you cannot quote.
So that one is closed now. That means
इस पे डिपार्टमेंट एक्शन हो सकता है.
So no, this is what had been happening. All specifications they started saying, with USDA FDA approval, with CE approval, with
no. मैं इसे अवॉइड स्पेसिफिकेशन. I mean they are not helpful at all. क्योंकि स्टोर डिपार्टमेंट कहेगा साहब देखिए हम लोग तो, मेरे यहाँ बोलता है साहब आपकी मशीन तो 4 करोड़ की है, मैंने तो पिछले महीने 1100 करोड़ का इंजन खरीदा था. ऐसा हमने तो उसमें भी नहीं लिखा.
सर इंजन 1100 करोड़ का होता है सर?
ज्यादा.
Oh my God.
पता नहीं, बहुत इंजन, टेक्नोलॉजी, स्पेयर्स, सर्विस, कॉन्ट्रैक्ट, बहुत कुछ साथ आता है ना उसके. जैसे आप हमारे यहाँ सिस्टम आपके यहाँ हो सकता है डिफरेंट. तो जैसे मैं एक मशीन खरीदता हूँ, मान लो उस मशीन की कॉस्ट है 3 करोड़, उसका 5 साल का CMC है 2 करोड़, तो मशीन की कॉस्ट मेरे लिए 7 करोड़ हो गई. क्योंकि दैट इज L1. बहुत सारे स्मार्ट क्या करते हैं सप्लायर, वो बेसिक कॉस्ट ज्यादा कर देते हैं. मान लो बेसिक कॉस्ट मान ली उसने 4 करोड़ कर दी, उसने CMC घटा के 3 करोड़ 2.5 करोड़ कर दिया, तो 6.5 करोड़ में आ गया, उसका L1 आ जाएगा. तो एक कंपनी जिसकी बेसिक कॉस्ट 3 करोड़ है वो L2 पे चली जाती है, हायर पे चली जाती है अगर उसने CMC कम नहीं किया. ये जायज वाले मेरा करते थे. जायज वाले जैसे मैंने OCT लेता था, उसका वो बहुत अनाप शनाप 5 लाख 4 लाख महीने का कर देते थे साल का, तो उनका L1 नहीं आता. हमने कहा देखो यार CMC हमारे खराब नहीं होती, डोंट वरी, और होगा तो मैनेज कर लेंगे, तुम इसका बेसिक कॉस्ट रखो ज्यादा, कोई बात नहीं, बस CMC कम कोट किया करो. दूसरी कंपनी 1 लाख कर रही है, तुम 50,000 कर दो महीने का, तो तुम L1 कोट में आ जाओगे. वरना हो गया कि हम हर बार जो है कभी जायज लेने की कोशिश करते हैं, मॉलर वेटल आ जाता है, कभी टॉपकॉन आ जाता है है ना, और फिर साहब फाइल हो गया तो हो गया, अब आप कुछ कर नहीं सकते.
नहीं सर, आपके पास तो ऑप्शन है, आगे भेज देंगे किसी और के पास.
अच्छा, हम भी ये सोचते हैं अरे यार माइक्रोस्कोप है नहीं, चलो जो आ रहा वही ले लो.
एंड में तो यही होता है. इज डॉक्टर फारूकी देयर? डॉक्टर गोस्वामी कुछ कह रहे थे?
I was just saying कि purchase is one thing, another thing is the maintenance part, and that also.
Sir, maintenance पे तो I think we should have a workshop. Frankly, government maintenance is a huge issue.
Anytime. I have a hall in my hospital, have the capacity of around 100 people. आप select कर लीजिए, I will arrange your lunch and we will have a full day discussion on maintenance.
It is very difficult that the vendors are defaulting, the companies are not sending person, so it maintaining.
वो MCD की problem है sir. Is Dr. Faruqi there? I think we've lost him.
Okay.
Anyway, so and sir, there was this very interesting video that we were talking about.
Okay.
The chop. So I was just wondering if you could.
हाँ, अरे बिल्कुल बढ़िया.
And Dr. Hardeep, we were talking about the direct chop. So Dr. Hardeep is a leading oculoplasty surgeon and a very proficient phaco surgeon. So what is for beginners? What would be the best technique for nucleotomy, sir?
Thank you, Bali. I will just explain the technique which I learned initially when I started phaco. Anyway, it was a very difficult days because not much good machines were available and the funds were also not available with us. So nowadays, what we have modified is for the last few years that keratometry is very important. You take the keratometry and see which is the steeper meridian on the cornea, and you give the main port over that steeper meridian so that you can neutralize some part of the astigmatism. So after entering into the chamber, if you feel that the cataract is slightly more harder, then you must use a high viscosity methyl cellulose, or I use normally viscoat in my cases to make a very good capsulorhexis, central capsulorhexis, and good size capsulorhexis, which is very important to do a good nucleotomy. So you do a central trenching, approximately more than 50% of the depth, and should not go blindly to the periphery of the nucleus, because otherwise you will catch up the equator of the nucleus and you will make a PCT with your phaco probe. Then you rotate after doing good hydrodissection, you rotate the nucleus and hold the lower one half and pull with the chopper, and you break the nucleus. The breaking of the nucleus is very important to continue the good phaco, uneventful phaco. After that, you can rotate and keep on chopping in the material and take it away. And this is the basic learning point, that in case you see that it is slightly more harder cataract, then we make 4-quadrant or divide and conquer technique works very well. So I think Dr. Om Prakash is showing a video and he will explain in a better way.
Arey, sir, thank you very much. You are the expert, and I have seen your live surgeries. That was probably the first time I've seen Faridabad and some other place also. Basically, the cataract surgery, there are 2 steps which are more important. अरे बेटा सुनो, हाँ नहीं गया, जा नहीं रहा वहां पर है अब बस अब आ गया सर. Thank you, dear. So stop and chop technique, which is a very old technique. It was designed by Mr. Paul Koch somewhere in early 80s, and it is applicable and effective in all kind of cataract cases, like soft, hard, small people. So it is one kind of soft cataract, which is also very difficult to crack, because now the high-end machine, they just get it, eat up the things, and you can't hold it. So if you can make 2 pieces, even then you can perform the in-back phacoemulsification. So I'm just trying to make the 2 pieces, and I have already made it. So center part has already gone. This is the crack you can see here. But machine vacuum is very high, and you have to always take care that it should not touch the periphery, otherwise you will end up with right. So one part has gone, and now I'm approaching the second part. Don't try to take the rim out at this time, because if you try to take this rim, it will give you the problem. So it is a case where it is small people, rather underdilated. So you can see that I am just making a small tunnel over here. My chopper is just ready to crack, and pupil is not fully dilated. So So now you can see. So now I have cracked one part, and you have to rotate it to make a full crack of through and through to other angle, other part also. You can see the posterior plate cracking is the most challenging work at this stage. And this technique worked very well by dividing the posterior plate. You can see I'm just making the 4 quadrant now, and the nucleus is now almost cracked. And now it's very simple to take it out one by one. I'm just ensuring whether any part is attached or not behind. So again, a very, very hard cataract where I have just, you can see that I was making a small tunnel over here just to reach the center of the nucleus. Pupil is also not very dilated, right? So this is part where I'm trying to go to the center of the nucleus, hardest part of it. And now I apply the crack. You see, one attempt may not be successful. And here I have just hold it, make the crack. And now I'm approaching the other end of it. And I have make the through and through crack. So nucleus are divided in two parts. Now I'm again making the 4 part by dividing again into 2 pieces. So I always say that the part should be totally cracked. Never see any fiber or any plate attached behind, otherwise you will end up in a problem. So now I have divided the nucleus into 4 pieces. So one hard cataract. So it is with dilated pupil. It is slightly easy to operate. You can see that nucleus so hard that my attempts are not very effective. I am just trying to hold it again, and now I have induced the crack. So it always happens that you may require 1 or 2 attempts to crack the nucleus, but ensure that you should have effective crack. It should, the posterior plate has to be cracked. Now you can see the reflex is coming very clearly from behind, and I have cracked the nucleus through and through, though it was very hard. Now I have make 4 pieces. I may make more pieces as per the requirement. The nucleus is very hard. I may piece 8 pieces also. So this is the again one cataract where the axis is not very large, but I have effectively made, because this technique worked very effectively. And Dr. Hardeep was telling that you should try to focus the hardest part of the nucleus by holding with the machine. So once you hold it, it will not go away. So whenever you apply the chopper, it will have it definitely crack. You may made 1 or more attempt to go behind. Again, one totally brown cataract, and you see it is one of the hardest cataracts come in the category, and they are leathery also. So we have to ensure not only the crack but a complete crack over there. You can see that it is sleeping. So it's so hard. Vacuum is around 600 millimeter mercury. So I have just make it 4 pieces or almost equal size, and again, I have, this is my technique that I make 4 pieces of every nucleus, and further piece depend on the hardness. So again, I have made a small piece over here. This is not very hard cataract. So, but again, if you can hold the center part of it, इसमें क्या है सर, एक काम और कर सकते हैं कि जो part of needle है, you can increase if the hard nucleus is very hard. इसमें nucleus इसको जो tip है, tip is very less exposed. So if you are handling a hard cataract, you should increase this part of it.
And trenching is required to deeper, that will increase the length of this.
Yes. So, so the nucleus is totally cracked in 2 pieces, and look this cataract. It is absolutely hard. It's scary. It's scary. So I'm making with caution. I'm making the trench, and I have already induced the crack over here, but leathery. So other part I'm just approaching. So one thing that you should have a free rotating nucleus. Always try once you are handling the cases, spend 2 minutes extra by hydro and all. So make the nucleus totally free from the nucleus, otherwise you will end up in the problem despite all best effort. So the nucleus is now cracked. I'm making further crack of it. So small fragments, so easy to emulsify with minimum amount of energy. So I have just made. So this case I would like to, it's a case of Arjun flex sign. Despite my best effort, I lost the rexes, and you can see the flap. One is coming out from the port, and other part there is a clear cut extended capsule rexes. And at the front 6 o'clock position, I am not very sure whether it has come near the equator or not. So in this case, you have to utilize a very sensitive kind of echo. Expert person should go ahead with it. Nucleus is quite hard, so I'm just trying to do the all procedure in the pupillary plane. So the breaking is very important in these cases, because if you don't break, there are high chance that you will drop the nucleus. In this case, because your rex is already compromised. You can see the flap is, I'm just putting purposely in the side port. So this is the indicator where I always see that yes, I am still in the safe zone. So I always look for these kind of things, and I'm trying to I have already cracked the nucleus, but it is because it is very hard and I am slightly scared inside. So with easy, I have just take it out the nucleus. Even in the compromised cases, normally people don't go for it. And we don't recommend that the beginners or the mediocre or a single eye person we should go. In single eye patient, we should not go for it. Thank you, sir.
Yeah, fantastic presentation, sir. Sir, what would be your suggestion for FACO 1, the power settings, and should the bottle height go up or down, and what about the back?
It differs in all different machines and also in different category of cases, and depending upon the beginner or the expert surgeon. Normally, basically for beginner, ideally the chamber maintenance is very important for the beginners, because they most of the time they will touch the cornea, the keratitis level is very high, they can catch the iris. So maintenance, either you use a maintainer or the height of the this bottle should be high, so that with pressure also the pupil dilates. So in FACO 1, where we do basically the trenching to keep the vacuum low, aspiration low, and FACO power slightly higher, so that you can make a very good trenching. And you can reduce the power in FACO 2 and increase the vacuum and aspiration accordingly as the machine permits. And there should not be any kind of surge, which is basically set up by the engineer. They see the chamber when you put the press the foot switch and go to the FACO mode, you will not see any surge in the chamber. So chamber means that the plastic chamber that we put over the handpiece. So this is the main indication that the surge should also be not in the anterior chamber. Otherwise it will cause keratitis then.
Sir. Now the machines are quite good and their fluidics are absolutely extraordinary and excellent. So if you have a better foot control, what I always talk to my residents and the junior consultant, that you should learn the two things in your life first: best foot control and best focusing. Your one foot should always on the pedal of the microscope and one should on the pedal of the FACO machine. So your foot pedal should be so good that your microscope should remain in the best level of its focus, and same the power aspiration or irrigation mode you have to control with that. If your foot control is good, I think you can very well maintain. What happened that either your focus goes out, you can't understand in which plane you are working, or number two, your pedal is not in your control. So where you don't want to give the energy, your energy is constantly going on. I have seen the junior consultant, they pedal remain on even they don't have anything, a particle occluded in the tip. So that is extra energy which would normally harm the eye and the cornea.
And so the Rex's size, what would be for the beginner, what would be your recommendation? Because, out here in the conference, everybody will say, this much overlap over the IOL haptic.
देखिए सर, अगर आप लेंस की एनाटॉमी देखें, so maximum size of Rex is you can make it 6 mm. भाई जो आपका जनरल एरिया है, आप 6 से ऊपर जा ही नहीं सकते. So if you are making any Rexes not going up to that level, it is somewhere around 5.5 or 5 mm. So there, small Rexes in soft cataract is a problem. Small Rexes in a hard cataract again a problem. So better you learn somewhere that your pupil should be the guide of it, and people Rex's size should be remain around 5 or 5.5. I mean, initially you can learn with your there are some rings are available, but I think they don't work. Basically, you have to learn with your practice that what kind of Rexes you are making and what kind of size is it, right? So 5 mm is perfectly okay, or 5.5 if you want to go for a larger size. Yes, I have seen few of the SIC surgeons. They make extraordinarily large Rexes, and their Rexes is invariably entangled in the general area. But anyhow, they manage it. So their Rexes is too much that at the time of hydro, the nucleus immediately popped up in the T chamber. So they have to put it back. So it should be not like that. And I think 5 mm or 5.5 mm is definitely sufficient.
Sir, but for harder cataract, the rexes should be larger. Yeah. Try to make it at the optimal size, larger rexes in hard. Otherwise, you will be having problem in trenching and doing phaco in the back.
Actually, what happens is the rexes, the margin, it has the capability of distensibility. Yeah. So, like even if you're doing procedures inside, of course, hard cataracts, you should always have a larger rexes size, and that also that allows hydro procedures to proceed a little better. So, what about posterior polar cataracts?
In posterior polar cataract, when you are not sure whether it is posterior polar, but your doubt is always there, and you must give a very high suspicion index in cases of central cataract which appear to be polar. So in such cases, after making the procedure is same till the rexes, but the only hydro dissection and hydro delineation is very important step in such cases. Try to not to do the hydro dissection and be very gentle and slow. Do hydro delineation at different planes of the lens and try to remove the central part first, and slowly you can peel off the periphery. And don't remove the central part, you remove the central part at the end and keep your viscoelastic, and there should not be much of fluctuation of the chamber. That is very important. Otherwise, you will, in most of cases, maybe pre-existing rent is there. If pre-existing rent is there, it is the very thinnest area. It may rupture with the bolus of the fluid. So very gentle hydrodelineation is very important.
Not only that, I have seen in the cases where you successfully did the cataract extraction by phaco, but the capsule, as you rightly said, is very, very thin, and when the person are injecting the lens inject directly into the vitreous. So it happened in so many cases I've seen. So you have to be very cautious in these cases of put the lens in the direction. It's not pointed totally posteriorly. It should be a little downward and toward the back, not toward the posterior capsule.
And it's not a bad practice to use a 3-piece and do the optic capture into the anterior into the rexus margins. So I think so with your permission, if we could conclude the session.
So I think with such a great discussion, I thank especially Dr. Hardeep, who is available with us. I think we conclude the session. It is very effective, and thanks to Dr. Bali and all the participants and audience for their very, very active participation. Thank you so much.
Thank you, Dr. Hardeep, for joining us, and Dr. Anand for chairing the session, and all participants. And I thank the attendees. Thank you so much.
It's my pleasure to be here. Thank you.
Thank you, doctors, for chairing the session. Thank you, everyone. By this, I now conclude Hall F for the day. Thank you.
Thank you.